just in case.
السلام عليكم. بسم الله الرحمن الرحيم. معكم دكتورة منيرة أبو راشد. I'm the co-chair for the Kuwait Dental Implant Symposium and I'm the vice president of the Kuwaiti Association of Periodontology. I would like to start this meeting with a brief introduction. So, good afternoon, esteemed guests, colleagues, and friends. A warm welcome to you all to the first Kuwait Dental Implant Symposium. Today, I'm honored to be part of this significant occasion and to share this platform with such a unique gathering of experts in the field of periodontics and implantology. This symposium aims to bring distinguished minds from different parts of the world together to share their knowledge, expertise, as well as the latest advancements in the field of implant dentistry. We have assembled an impressive panel of speakers who will deliver a wide range of topics, from implant site preparation to the management of complex implant cases and full mouth rehab. On the behalf of my team, the organizing committee, I extend a heartfelt thank you to you all for your participation in this educational platform of implantology. And I would like to present to you Dr. Ahmed Al-Sharad, KDIS co-chair and the head of the Kuwaiti Association of Periodontology. Please welcome Dr. Ahmed.
السلام عليكم ورحمة الله وبركاته. أشكركم على تلبيتكم الدعوة للمشاركة في لقاء الكويت الأول لزراعة الأسنان، والذي يقام بالتزامن مع مؤتمر جمعية أطباء الأسنان الكويتية 23. يقام هذا اللقاء المميز تحت تنظيم الرابطة الكويتية لأمراض وجراحة اللثة، حرصا منها لمواكبة التطورات العلمية في مجال زراعة الأسنان ولرفع المستوى العلمي للأطباء المهتمين بزراعة الأسنان. زملائي الأعزاء، دعوني أستعرض معكم أهم إنجازات الرابطة خلال دورتها الحالية للعام 2022-2023. بداية احنا يعني حرصنا على التخطيط لإقامة الملتقى العلمي الأول زراعة الأسنان، ونظمنا الرحلة العلمية الأولى لمؤتمر الجمعية السعودية لأمراض وجراحة اللثة، والذي يقيم في مدينة الرياض عام 2022. كذلك حرصنا على إقامة لقاء علمي مشترك بين تخصص اللثة وتقويم الأسنان، وكذلك الرابطة حريصة تكون شريك ومستشار علمي لجميع اللقاءات العلمية التي تقيمها شركات زراعة الأسنان. حرصت اللجنة العلمية على اختيار متحدثين مميزين من عالمنا العربي، إيمانا بأن لدينا خبرات كلينيكية رفيعة المستوى في مجال زراعة الأسنان تضاهي مثيلاتها عالميا. فبالإضافة إلى دولة الكويت يشاركنا أخواننا وشقائنا من المملكة العربية السعودية وجمهورية مصر العربية والجمهورية اللبنانية كمتحدثين أساسيين في هذا اللقاء، وكذلك يشارك معنا متحدثين عالميين من الولايات المتحدة الأمريكية ومملكة أسبانيا. في هذا اللقاء العلمي سيتم تناول العديد من الموضوعات المهمة مثل التقنيات الحديثة في زراعة الأسنان، العوامل التي تؤثر على نجاح زراعة الأسنان، التجارب السريرية في زراعة الأسنان وزراعة العظم، وكذلك سيتم غدا إقامة ورشتين عمل متخصصة في زراعة العظم. في الختام أدعوكم جميعا إلى المشاركة الفعالة في هذا اللقاء والاستفادة من المعرفة والخبرات التي سيقدمها لنا المتحدثون والخبراء. أريد أن أنوه أن تربطنا علاقة وشراكة يعني مميزة مع أخواننا في الجمعية السعودية مرض وجراحة اللثة، وسوف نعلن إن شاء الله في حساب الرابطة في الانستغرام عن فعالية ستقام في مدينة جدة إن شاء الله، وسوف نوفيكم بالتفاصيل إن شاء الله على حساب الرابطة. أحب أتقدم بالشكر جزيل بعد شكر الله عز وجل إلى جميع الزملاء المنظمين لهذا اللقاء، وكذلك لإخواني رئيس وأعضاء جمعية أطباء الأسنان الكويتية، والسلام عليكم ورحمة الله وبركاته.
Good afternoon, Assalamu alaikum. On behalf of the board of the Kuwait Dental Association, I want to first thank the society for their great effort. The dream is becoming true, to do a specialized symposium day and a special day with a very busy schedule today, so we'll go on the schedule. I will not go over it. We're going to start first hearing Dr. Mohammed Shamsuddin. BDS obtained October 6th University in Egypt 2011, specialized in periodontology from King's College London, received membership in periodontics from the Royal College of Surgeons, Edinburgh 2017. He is currently working in the Ministry of Health in Kuwait, in Al Adan Hospital, and he works in private practice. The scope of work he carries out ranges of treating, management of periodontal disease, recession cases, crown lengthening cases. The majority of his work, however, revolves around restoring teeth with implants. Therefore, he has a high interest in implant success, implant complications, and implant failures. He will be presenting today vitamin D deficiency, impact on wound healing, and implant failures. Please welcome Dr. Mohammed.
Yeah. Good morning or good afternoon. Okay, I'm going to be presenting today vitamin D deficiency, impact on wound healing and implant failure. To start off with, who screens for vitamin D deficiency before work or after work, or with a show of hands? Okay, great. So not many people, so hopefully this will be informative. Okay. To start off with, what is vitamin D? Vitamin D is a vitamin produced by the body when exposed to ultraviolet light or obtained from dietary sources. Okay. Technically, it is not considered a vitamin as the body can produce it, where it's also known as cholecalciferol. It is a key player in bone growth and metabolism as it promotes the intestinal absorption of calcium and phosphorus. Vitamin D is vital for the health of the brain, the cardiovascular system, respiratory tract, skin, and the immune and endocrine systems. Why is it important in the dental field? It aids in the development of teeth. It promotes the immune response to oral microbial infections, healing after periodontal, oral, and implant surgeries. And I believe it is one of the most overlooked systematic factors. How do we measure vitamin D? I'll go through the basics and then I'll discuss more how it helps us in dental implants and periodontology and all that. So how do we measure it? We measure it through a blood test, either serum or a blood spot. Two of the most commonly used units are nanograms per milliliter or nanomoles per liter, where 1 nanogram per milliliter is 2.496 nanomoles per liters. The measurement is done with a total serum of 25 hydroxy vitamin D. What does that mean? They add vitamin D2 and vitamin D3 together, and they get the total serum. And this is where it's a bit controversial. A lot of people have many discussions on if we are deficient with vitamin D2 or vitamin D3? This is where the controversy lies. Deficiency is defined universally as serum 25 OHD below 10 nanograms per milliliter or below 30 nanomoles per liter. What are the causes of vitamin D deficiency? Firstly, we have diet. We can get vitamin D through our diet. So the natural sources of vitamin D are animal-based, like fatty fish, fish oil, egg yolks, fortified milk, beef liver, and approximately 90 IU, or international unit of vitamin D, may be absorbed through food every day. Therefore, where do the issues lie? We have strict vegans or people that lack intake of these foods. This is where they get deficient. So they need to find an alternative source. Secondly, which is one of the most important, is sun exposure. So the recommended dosage of vitamin D may be absorbed by exposing the face, hands, palms to the natural sunlight 2 to 3 times a week. The common thought is one only needs to be in the sun for half the time it takes for the skin to turn pink. In other words, if it takes 30 minutes for the skin to start turning red, only 15 minutes of sun exposure is necessary. Where do the issues lie? The issues lie if individuals who live in climates with little sunlight, or there's inadequate sun exposure, or they have dark pigmented skin, and or wear high SPF in the sun. This is why in Europe or in places that do not have sun, when the sun comes out, you'll see everyone sitting in the parks with their t-shirts off, trying to get as much sun as possible. Thirdly, we have medical history. So vitamin D is converted in its active form in the kidneys. So people with kidney disease can be at risk for vitamin D deficiency. Also, certain intestinal diseases, such as celiac disease, cystic fibrosis, Crohn's disease, they limit the amount of vitamin D absorption. Also, lastly, obese individuals can have low levels of vitamin D because adipose cells extract vitamin D from the blood. Taking all this information, what are the causes in Kuwait? Because we live in a very sunny country. And they carried out a study in 2016 where the correlation between vitamin D and diabetes was studied. And they found 56% of the population was inadequate. They found 27% was deficient. Of course, this might have changed through time. However, this is something to think about. Why? Why do we have this? Well, firstly, reduced exposure to the sun, because our cultural practice of clothing shields our skin. And this is why we have, in women, it was shown that they were more deficient than men. Secondly, low dietary intake of fortified products and dietary supplements, because the fortification of dairy products with vitamin D is not mandatory, and the consumption of milk is low. And it was found that there was an increased prevalence of obesity over the years. Surprisingly, this has changed my practice, because you would be surprised how many people are deficient in Kuwait. I was deficient. I did a blood test and I was deficient, although you would be surprised. And I think this has also to do with our lifestyle. We get in the car right outside our house, we park right in front of the door of work, so we're never outside. Whereas, when I was studying, I used to commute to work, so I used to walk outside for 10, 15 minutes, so I'm getting sun exposure. So these are all things to think about. I mean, when your patient comes, they don't just need a tooth to come out and an implant to go in. There's many things that you can help them with. And I've seen that I've helped many of my patients through this, because this doesn't only affect the bone and just the dental implants. I had patients that come to me and told me my mood changed. So once I started taking vitamin D, everything changed. I was more energetic. My mood was different. So it's just something to think about. What effect does this have on our dental treatment? Why is this important in dentistry? Firstly, with the periodontium, vitamin D activates non-specific immune responses and antimicrobial protein synthesis by immune and epithelial cells. Okay? It also takes part in the specific immune response and suppresses the destructive effects of chronic periodontitis. Periodontal patients with low levels of vitamin D have also shown poor responses to periodontal surgery. What does it do to bone? It stimulates the activity of osteoclasts, increases the production of extracellular matrix proteins by osteoblasts, and deficient vitamin D have been correlated with low bone density, pathological fracture, and poor bone healing. Case reports have also suggested that low vitamin D was correlated with failure of bone grafts and regenerative materials. How does this affect dental implants? Well, osseointegration of dental implants depends on bone metabolism. So vitamin D deficiency can affect the healing process and the new bone formation on the implant surface. This, however, is very controversial, and I will explain why now. It is controversial because there's not much evidence. I mean, most of our work has to be evidence-based. The evidence shows this was a systematic review that was carried out in 2022, where they took 5 human studies and 6 animal studies. All the studies discussed the relationship between vitamin D and early dental implant failure and bone implant contact. 3 retrospective studies found no significant relationship. On the other hand, 1 retrospective study showed a significant relationship in humans. A case report and a case series claimed that the implant was successfully placed after vitamin D supplementation. 4 animal studies showed significance and 2 showed no significance. And also the authors concluded that to ensure optimal outcomes, it is recommended to supplement the patient vitamin D if the serum level is not within the normal range. One of these studies was carried out in a private practice in 2018 in Italy. It was a retrospective clinical study, and it investigated the correlation between low serum vitamin D and early dental implant failure. The study evaluated 885 patients who were treated with 1,740 implants. Okay? The patients with vitamin D deficiency showed an early implant failure rate of 11.1%, compared to the failure rate of 2.9% in patients with normal levels of the vitamin. Yes, this isn't enough evidence to say, okay, no, we need to give all our patients, but I personally see, because what I've seen, I mean, of course, they concluded that in cases of unknown failure of the levels should be examined, and the operator is advised to administer vitamin D. I'll show you one of my cases early on, before I even thought of something called vitamin D. So one of my colleagues actually pointed this out for me, and it changed the way I practice. So I'm pretty sure most of us have had an implant. You place it in a healthy patient. The bone level is fantastic. However, 3 months later, you come to do either, if it's 2-stage surgery, you come to do uncovering of the implant comes out. You take an x-ray, everything is fantastic. It doesn't look like there's any bone loss, there's nothing. What's happening? You start thinking about yourself, what am I doing wrong? Your confidence starts to become lower. I mean, I definitely went through that. And when I started screening for this, my practice changed. And this is why I thought this is a very important topic. This is one of my cases. This was in 2018. So 3 months after placement, I took an x-ray, and this is how it looked like. And I couldn't believe it. So the patient was healthy, non-smoker, no systemic factors, and the implant wasn't moving, so it wasn't mobile. However, after 3 months, this is considered a failing implant. So instead of taking it out, placing a bone graft, and doing all these things, I cleaned the area around it, which might also have aided in bone formation. However, I did vitamin D test for this patient. Her vitamin D was very deficient. So what we decided to do is to take vitamin D. I didn't decide, so I sent her to the medical doctor. He's the one that prescribed. He gave her vitamin D for 3 months. This was the x-ray 3 months later, believe it or not. And then after I saw this x-ray, so I checked, everything was fine, sent her over to the pros department, and then this was a year later. As we can see, there's a massive difference. And it's actually, when I took these x-rays, I couldn't believe it. I couldn't believe it because it doesn't make sense. People told me, no, you placed a bone graft for sure. There's no way that you could have gotten this much bony infill, but I did. So what is the treatment? So if we have, what is the treatment that I carry out, let's say, with most implant patients? So firstly, I communicate with the patient. I ask them, have you been tested recently? If they tell me yes, I ask them or I ask them to send me or bring their tests with them. And I see, are they deficient, are they normal, are they insufficient? If they were deficient, I ask them, did they have any knowledge about it? Did their doctor point it out? Or is it just, are they doing just normal blood tests and it's coming out? If it was low in the past, what did they do to correct this? And surprisingly, there is a lot of knowledge that is coming up about vitamin D. I'm beginning to see patients coming and telling me, no, doctor, I'm taking vitamin D supplements once a week for the past 2 months. So it helps. I still ask them for documentation to make sure, but it's nice to see that there is an awareness. Secondly, we diagnose the patient. If they've done a test, are they deficient, insufficient, or normal? Thirdly, there should be a customized treatment for each patient. So after serum testing with their medical doctor, they should have a customized treatment. I also recommend to educate the patient. So tell them, if you did a test, don't just prescribe yourself, because, I mean, I've seen a lot of that. My patients would be like, I don't want to go to the doctor. Just tell me what to do, and I'll just do it. I'll buy it and take it. But I always tell them, no, I cannot do that. I recommend you go to your doctor. They'll tell you exactly what to take, how long to take it. So educate the patient that it's important. The follow-ups are important. The tests are important. So it's communicating with the patient is massive when it comes to these things. So when I speak to my patients about vitamin D, many of them ask me about toxicity because, I mean, you get the patients that search everything on Google and they read that, oh, vitamin D, if you take vitamin D supplements, it's going to kill you. So it's good to know what's the toxicity. So what does it do, okay? So the main consequences of vitamin D toxicity is a buildup of calcium in your blood, or hypercalcemia. And it might progress to bone pain and kidney problems. In healthy individuals, how do they get toxicity? Usually it's when they take excessive vitamin D supplements. So some people would take supplements for a year when it's supposed to be only for 2 months or 3 months. Surprisingly, though, excessive sun exposure does not cause vitamin D toxicity. This is due to the regulation and conversion of vitamin D in its inactive metabolites in the body. Most cases of toxicity resolved without serious complication. However, in some instances, severe hypercalcemia can lead to acute renal failures. And the cases of permanent renal damage are rare. They're rare, but they do exist. So it's also good to be knowledgeable with toxicity. So what is our take-home message with vitamin D? So vitamin D deficiency, it can lead to reduced bone mineral density, osteoporosis, bone fracture, progression of periodontal diseases, and possible dental implant failure. Adequate intake of vitamin D can decrease the risk of gingivitis and chronic periodontitis. It is also important for bone metabolism, alveolar bone resorption, preventing tooth loss, and promoting bone formation around dental implants. Patients who also demonstrate poor wound healing response after dental treatment should have vitamin D serum levels evaluated and treated if necessary. So like I said before, I think this is a systemic factor that's overlooked. I've spoken to a lot of my colleagues and I tell them, screen for vitamin D. They tell me, why would you? I mean, and I would tell them, why not? I mean, you're sending the patient for HbA1c. They're still going to do a blood test. Just add vitamin D. It's not going to hurt. And you will be surprised how many people are deficient. For my patients that come for dental implants, I can guarantee around 95% are deficient. 95%, no joke. And it's helped my work a lot. The random implant failures that I used to get in the past are now not there. Thank you. Any questions?
So you're asking every patient seeking for dental implant to make the test?
Yes. Yeah.
You didn't wait until you diagnose CBCT, if there is bone density, low bone density or not. You are automatically asking all the patients seeking for dental implant to do the test.
Yeah. Any other questions? Okay. Yeah. Yeah. Because from what I've seen, when I place an implant, regardless if they're systemic there are no systemic factors. When we're vitamin D deficient, they come back with early dental implant failure. I have x-rays, I mean, this is one of my cases, but I have many different cases where you see the x-rays, you get a lot of bone loss around an implant and very fast, very rapid, and it doesn't make sense. So when someone is healthy, but they're losing that much bone, there's something wrong. And this is where I'm saying I used to feel not confident because I used to say, oh, I'm doing something wrong. I'm either, my technique is wrong, my surgery is wrong, was there bacteria that flew in and ruined this? So, but once I started screening for vitamin D, it changed the way I treat, it changed the way the implants heal and all that.
How do they look, Doc? How do they look? What's the clinical sign? I mean,
there is no clinical sign, but one of the clinical signs
what's the gender, age, specific group?
Gender and age. I mean, this is talking about Kuwait. Generally, everyone is vitamin D deficient. Surprisingly, in younger patients, the deficiency is higher because younger patients actually don't spend time outside. They're either inside, they're at work, they're in the office, they're on their computers, so there's not much sun exposure. Most of them are not as healthy in terms of what they eat as well, so it doesn't help. I mean, they eat a lot of fast food, they eat, I'm talking about the general public. Clinical signs in older patients, actually, you'd see them tired most of the time. You'd see them exhausted. You ask them what's wrong. You check their blood sugar. You check their blood pressure. Everything is fine, but they seem like fatigued. And many of them, when they start taking vitamin D, they come back and they tell me, thank you. My life changed. I actually get up now. I actually walk. I actually do.
Thank you so much, Doctor.
Thank you very much.
Thank you, for this great presentation and new informative lecture.
تمام. اوكي. اوكي.
Assalamu alaikum. Our next speaker is Dr. Abdelkarim Lehmeidan. His lecture is going to be related to sinus augmentation. He has got his certificate in periodontology from the University of Loma Linda in the United States in 2015. He also managed to get an implant fellowship and the American Board in Periodontology while in the same university. He is currently a teaching assistant at the University of Imam Abdurrahman bin Faisal in Saudi Arabia. His research and his main interest is working in the aesthetic zones and grafting. His aesthetic zone lecture, implants in the aesthetic zone lecture, will be later on in the day. So I will leave you with a great lecturer, to be honest, Dr. Abdul Karim, and all the best.
Thank you. Thank you. Okay. Good afternoon, everybody. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء وسيد المرسلين عليه وعلى آله وصحبه أجمعين. I'm Abdul Karim al-Hamidan. I'm a periodontist. Is this too loud or I'm good? All right. And I just want to say thank you very much for having me today. It's really an honor for any speaker, local, international, Gulf, outside. Standing in Kuwaiti podium is an honor because we're lecturing to a very well-trained audience. So we have to present really good material. So it's a stressful situation, but when looking at your faces, it calms me down. I mean, having friends and I would say family, it calms all of us down. So I'm going to be lecturing today about sinus, and later in the afternoon, I'll be lecturing about implants in the cosmetic. So let me check. This one goes on and off, so yeah, okay. So who does sinus grafting? Who does sinus grafting? Okay, all right. I'm in trouble. All right, so I usually start my presentation with sharing common quotes, and I always like to go with this quote particularly. Success is not a bubble, and true success is not a bubble. If it comes from passion and love, it's not going to burst. But the success that we know or we see hiking up really quick, this is a bubble that's going to burst. So just be patient, do what you do best, and we say بالعربي ما يصح إلا صحيح. And a common friend, one time I came to him, I had a complication with one of my sinus cases. So is there any radiologist, maxillofacial radiologist in the audience? Okay. All right. So I go to my friend. He's a maxillofacial radiologist. And he navigates whenever I screw up, he navigates for me and he tells me what went wrong. And I opened one case, sinus infection. I'm going to share with you. And I said, I used good bone, I used good technique. Everything went by the book. What went wrong? And he kept telling me, Abdul Karim, look at the osteomeatal unit. And I said, look, what? He speaks Chinese, radiologists, they speak Chinese. I don't understand. I could not comprehend at the time until he sat with me and he showed me what a radiologist looks for in a CBCT. So I became more careful with my case. So that's my friend. He said it's the osteomeatal unit. So the presentation outline, we're going to be covering a little bit on this goes up. A little bit on anatomy, histology, and I'm going to be touching on clinical approaches. I'll skip the medication because it's a really broad topic, but I'll show you more of my complications. That's the fun part, okay? So I'm not here to convince you that tilted implants don't work to avoid the sinuses, so let's just stop at this point. I know a lot of people here, they believe in tilting their implants to avoid the sinuses. Yes, it works. Yes, it has a good survival. And if you see people who do all them 4 techniques on a regular basis, I know most of you guys do that. I know it's successful. So I'm not here to convince you that tilting your implant is not a solution. But in few cases, it is not a solution. And I'm also not here to tell you that short implants don't work either, because they do. Short implants, they do work. You just need to pick your cases, really careful with these. And you need to know what kind of implant surface you're dealing with, what kind of occlusion, how big of an, is there any parafunctional habits, and so forth. So short implants work. I have my opinion on them, but the literature support that it does work, so I'm not here to convince you otherwise. So the sinus starts developing on the fourth intrauterine week. This is how early that thing starts developing. And it usually starts developing in the form of tubule and then ovoid, and then ends up with more of a pyramidal shape. And it's composed histologically of pseudostratified ciliated columnar epithelium. I always tell my students, don't cut something that you don't know what is it composed of. You need to know what you're dealing with. So it is very important to go through the basics before starting to do these. And very important to navigate, these are the four walls on a coronal section: the roof, the medial, the lateral, and the floor. And then you have also the anterior wall. And if you look at it in a 3D construction, this is how the sinus, can I have another clicker? Yeah, this one is a bit challenging. Okay, excuse me, بس هنزلكم بس, just a second. Okay. And sorry about that. So the sinus is innervated by the trigeminal nerve, and it drains in the submandibular lymph nodes. So if you have an infection in your sinus, don't expect only the infection to be seen at the site. Palpate the cervical lymph nodes. Patients will complain of having palpable lymph nodes at that area. And if you look at the sinus volume, so many of this back and forth to analyze the sinus volume. And okay, and the sinus really is 11 centimeters cubic. And if you want to elevate the sinus for a good 15 millimeter lift, you need to have about 4.7 cubic centimeter material to be able to elevate the sinus for up to 15 millimeters. I know this might sound a bit too much numbers. You know, how is this relevant? Look at this case, beautiful case, huh? You know, this is ready. This screams do lateral window and call it a day. But if you shove material without having an idea how much material is approximately needed to elevate that sinus, you will end up really in something like that. Look, this is a bone tumor. It looks like a bone tumor in there. Patient probably will start walking sideways now. His head is tilted. This is unnecessary bone graft. So if you want to pack bone, you got to be able to understand how much bone approximately is needed. Of course, sinuses are different. Some of them are wide, some of them are narrow. You're doing one tooth, you're doing the whole maxillary sinus. But you have to understand how much approximately, because after the 4 cc of bone graft you put in that sinus, and there is no resistance still, yeah, you should be worried. You should be worried. You might have a perf that you're not aware of. So, and if the patient comes back to you telling you that any of these functions are altered, you should be also concerned. So a good lift does not affect these functions. Okay? And we also know that this has been published back in the late 80s. Lifting the sinuses and keeping that sinus lifted up with a stable blood clot, you will have bone. So really, the type of bone graft that we do put in there is just a scaffold. It's just a scaffold. You put autogenous, you put xenograft, you put allograft, it really doesn't matter. Now, don't put alloplast because the literature is a bit weak on it, and it's not really histologically good. But I'm sure any bone graft that you use will generally serve the purpose, especially if you have a good technique and a good intact sinus elevated. So this has been proven. Bone is going to form over and over again if you keep that sinus elevated. And this was late until later on. This is a bit an overkill where they actually lifted up the sinus and they used a titanium mesh to keep it uplifted. Now this is an overkill. In order for you to take that titanium mesh out, you're going to rip that sinus all over again just to document. But this proves the concept that when you keep the sinus membrane elevated and you wait enough time, that bone is going to form. So a stable blood clot in the sinus is going to do the job. And they actually sampled that, and they found that there is native good bone in there. So the trick is lift the sinus, keep it uplifted, wait. And you also need to look. We just said that not all the sinuses, they look the same. So if you want to rotate the lateral window and your sinus is narrow, you can't. You just use that technique. And if you already have a sinus that's already communicating with the oral cavity and there's only that soft tissue separating them, you need to switch from a full thickness elevation to a partial thickness where you have. And that's where a good eye, a good trained eye to read CBCTs or a radiologist comes in handy. And if you want to elevate the sinus in a fresh extraction socket area, good luck. You're just asking for trouble because it's a bumpy road and you will, at some point, perf the sinus. And look at this sinus. We always tell our residents, you got to go all the way to the medial wall. If you don't see the medial wall, don't pack bone. You got to elevate them until you see the medial wall and then put your elevator in there, keep the sinus uplifted, and then pack your bone. Yeah, I understand. But a steep sinus like that is a problem, always. So don't blame your resident or yourself if you have a perforation in that steep sinus as opposed to a sinus that looks like this on the right side. And septa, just be ready for it. Some septa are just trouble. And depending on how long that septa is, you will decide whether to treat this as one window or connect them, or you're going to do two separate windows and work around that septa. And some septa, they come like that, and if you do see that, just run away. This is just a call for trouble whenever you see septa like that. And some septa actually has been reported in the literature. Majority of the septa exist in the middle area of the sinus, and they come in different lengths, and they distinguish a long septa versus a short septa with the number of 6 millimeters. Now, if you have a 5 millimeter, that's still a nightmare. It's not easy to work around it, but I think everybody wants to publish something to be the first, you know. So septa like that separates the sinus anterior-posteriorly, cannot be worked around. You could access both with 2 hydraulic pressure techniques and elevate the sinus separately. Eventually, it's going to perforate. So you crush that, you elevate, and you wait until it heals. And you got to know what's the prosthetic plan. You don't need to go all the way to the back and elevate if you only crave a single, if you're going to stop at the first molar occlusion. You don't need to go all the way back. So your design of your window depends really on your prosthetic plan. And the artery that, you know, we were trained to be scared with it, that I understand it's a bleeder, yes, it can stop, there are different techniques to stop it, but the literature shows that it's about 19 millimeter up high. So we're really in a good shape, you know? But if you look at different literature, it shows that some could be as close as 5 millimeter. So don't take that one single article and then start doing your sinuses without having expectations like that. And be ready for seeing pathology. If you see something wrong, refer it to the maxillofacial pathologist, possibly an oral surgeon, an oncology team, whatever. Because some bone might actually look really sweet and dense on a periapical radiograph, while it's actually a fibroblastic lesion. And sometimes we see radiopaque, somewhat bone-looking on a CBCT, and it's actually a fungal infection. So if it doesn't feel right, don't touch it. Just send it to the specialist. And by specialist, I mean an ENT, a maxillofacial radiologist, and possibly a surgeon. You see, and everybody, and almost 90% of my patients, Dr. Salim, you might agree with me, everybody walks in your clinic, he said, عندي الجيوب, right? Everybody, and I don't know who diagnosed that, but whatever. But we need to make sure that we differentiate between acute sinusitis and a chronic sinusitis. And really, the way to see that is that presentation, like water floating in the sinus, it's called air fluid level. Radiologically, it's called air fluid level. And that, you combine that with the clinical presentation of your patient, and then you have your diagnosis of acute sinusitis. While chronic sinusitis, look at the bone. The bone that's around the sinus on the inside, it's really radiopaque, and it's not as thick. So that's a chronic sinusitis. Of course, along with what the patient really reports. But that's not my problem. My problem here is, why would I have a problem? Okay, my problem here is that the retention cysts that we see, we interchange them with other things. And I'll explain in just a second. So if you see the sinus is bumpy all around, 360, this is called sinonasal polyposis, refer to ENT. If you see a bump, a sweet-looking bump in there, this is probably a mucus retention cyst, and that's fine. But how often we see these things and we misterm them. This has been reported in a respected journal saying that this is a mucocele. Mucoceles don't look like that. Mucoceles is not as nice as these. These are mucus retention cysts. If you show this to any maxillofacial radiologist, this is not a mucocele. Because mucocele could be really bad if you miss them. It could displace the whole sinus, and it could go all the way to the nasal cavity. So we were trained to look at this, where the arrow is. It's called the middle ostium. The middle ostium. And if it's patent, you're good to go. Go ahead, put in your bone graft. Sinus thickened, sinus not thickened, that's fine. You have a patent middle ostium, you're in good shape. But we'll see about that. So this is what really counts. This is what the osteomeatal unit. This is the middle ostium. And then you have something called infundibulum. And then you have hiatus. And then you have the middle nasal fossa. Now, a blockage in any of these could cause a problem in the drainage. And then if you have an infection, you will start crying, going back to your fellow ENT, bail me out. And oh, ENT, they love making jokes about us dentists. So make sure, read it, and if you can't, just refer it like I do to my fellow radiologist, and he does the navigation part for me. And this is called the osteomeatal unit. Any blockage in any step in that is a potential problem for your grafting. So, sinus thickened. Do we do the sinus grafting? Do the sinus grafting? Well, if you have the sinus flora thickened, it could be either normal or thickened or polypoid. If it's thickened or polypoid, which is anything but normal, look at the ostium patency. And if the ostium is patent, fine. If it's not, and if it's obstructed, refer to an ENT. Now, if the ostium is patent and the patient is normal, ask for any potential sinusitis symptoms. And if there is symptoms, again, refer to an ENT. So if you want to touch sinuses on a regular basis in your practice, start making friends with the ENT. That's the point. Okay, let's move on to some techniques. If you have 1 to 3 millimeter, this is what we train the residents for, but nowadays with different techniques, I'm a bit confused. So I'll confuse you with me as much as I can. 1 to 3 millimeters, do the lateral approach. And if you have 6 millimeters, consider crestal approach. And if you have 4 to 5, it depends. Depends on what? Depends on the technique you're using. All kinds of modification technique that emerged in the recent years. How long your implant is. Do you believe in short implants or you don't? So all these matters, right? So let's see the lateral approach. This is how it all started, back in 70s. 70s. So if your patient asks, how predictable is this? Tell them that this actually started back in the 70s, where an implant were called fin-shape implant. Of course, we don't do these anymore. But then Philip Boyne elevated the sinuses for the sake of creating prosthetic space. And it's worked. And he used autogenous bone, and it worked. So we do a full thickness, we remove the tissue tags, and we outline our windows, and we elevate, and it looks really nice on this, but sometimes it's not as nice. So I'll show you now a video for that. But really, what you need to consider, keep the 3 millimeter. Don't cut where the sinus floor is. And I'll show you in just a second why we shouldn't be doing this. And elevate up to 15 millimeters whenever possible. And this is why we don't want to cut. So see, this is where the sinus lateral window, and this is how far we should, the inferior border of our window, our future window should be. This is right. Now, if you lower your window all the way to the sinus floor, and you do this, you might think that this is an easier thing because you don't have that motion where you have to elevate the sinus starting from the inferior border. But this is wrong because sometimes you try and you take the whole floor with you. You cut and you rotate and the whole thing, the inferior border, you break the whole thing. Now you have the lateral part and the crestal part all gone. So for those who like to use piezo, good luck. It's a safe technique. I love it. There's nothing wrong with it. It's just, it takes time. Lots of time. All right? It's safe whenever you have this artery passing through. I understand, but it takes time. And then Jaime Lozada and all the other group, they developed this, something that looks like piezo, where it rotates. So it's a bit more aggressive, right? It's a bit more aggressive and it cuts quicker, but it's not as aggressive as a handpiece. And you can use that technique as well. Couple of things. There's nothing wrong to keep the window attached to the sinus. So you outline it, you break it, and then you start elevating. Or you can detach it and you start elevating too. Things that you shouldn't be doing in your design. Don't do this design. Don't do sudden sharp angles, because with a sharp angle movement, you will perforate the sinus. And don't do this three-eyed baby face. I don't know, publication, I don't know how this was published. So I'm going to share this quick video with you just to go over the basic steps, courtesy of my faculty from Loma Linda, Dr. Alauddin Al-Arda, for this lateral window surgery. So we agree, I think by now, that not a lateral window should be done without having a preoperative CBCT, preferably also a diagnostic waxing, so you know how far you should go with your window in the future, whether you're doing a single crown, whether you're doing a IFPD. It's also good not to drop your vertical incisions. You will need vertical incisions to elevate so you can access the lateral window. As we said, from the approximately we need to go high up to 15 millimeters. So without a vertical incisions, anterior and posterior vertical incisions, it's going to be really hard for you to elevate. And in the posterior vertical incision, piece of advice, don't go up high because it's going to be hard to close later on. Where you need to really go up high is the canine. But keep in mind that some patients will come back if your vertical incision is deep. They will come tell you, we're still numb in this area, but it's the infraorbital you probably touched. So start with a small mucoperiosteal elevators, and once you open up and you start seeing the bone, switch to a wider mucoperiosteal elevators. And after you elevate everything, you don't have any more attached tissue tags still on the bone. Scrape whatever remaining of the soft tissue, because if you do leave something that looks like a partial thickness, it's going to bleed and you can't really see the outline of your window. We don't use, obviously, a straight fissure burrs in these cases. It's going to be round. And don't put a lot of pressure. That window is not going to be more than a millimeter and a half max thickness-wise. So you don't need to pressure, because the more the pressure, the more the chances that the thing will go in all the way in and you perforate. So once you start, we already know from a CBCT that we have a septa in there. We have to open up somewhat looks like two separate windows, and then we elevate until we go behind the septa, and then we detach that septa and we break it down. You could use a handpiece, or you could use bone rondure, whatever material you have, whatever you're comfortable with, just use it. Detach. And I forgot to mention that whenever we start with a window, start with the inferior border, go mesial, and then go distal. Leave the last for the superior border. Detach from the crestal area, going all the way to the mesial, all the way distal, and try to connect the whole thing. Once it's connected, you can a little bit detach the superior border. And again, it depends on how much elevation you want to do and how long of an implant you are planning to do for in the future. Now, majority of the cases, whenever you ask the patient to inhale and you see this beautiful view, yes, majority of the cases, it does not happen. And guess what? You do have a perfect. Okay, unless if the sinus is super fibrous, it won't move. So don't be disappointed if you don't see this beautiful inflating, deflating membrane. Now, you could use bone syringes instead of putting one thing at a time and feeding the sinus. Consider using something that doesn't really open up quickly. So personally, and that's my personal opinion, I wouldn't use anything that absorbs quickly, something like chrome or anything that resorbs really quick. I'd prefer to use a monofilament, non-absorbable sutures, and continuous interlocking. Do continuous interlocking, it's really helpful. But if you want to use other techniques, simple interrupted, because you're worried if that continuous interlocking loosens up, yeah, you can do multiple simple interrupted knots. And after that, just for you to make you feel good, throw in a couple of simple interrupteds, just for your own peace of mind. Okay, so this is a relatively straightforward lateral window sinus surgery. Make sure you have good primary closure. It is important. Some people might say this is an overkill, but I personally do take CBCTs after. I want to make sure that my bone is contained. And if you don't see fluid in the sinus, you know you don't have a perforation. This is what a lateral window is supposed to look like when you dismiss your patient. Okay, so grafting material, again, we mentioned that you could use whatever, with the exception of alloplastic material. Really anything could work. You want to use the allograft alone, you want to use allograft and xenograft, you want to use cortical versus cancellous, it really don't matter. And for those who say that xenograft is not good, well, the literature supports that implants placed in xenografted sites develop autogenous bone around the threads, between the graft and the implant threads. You can use biologics like PRF or bone morphogenic protein, and they all work. But the funny thing, this is what people used to believe. In 2 years, your xenograft is going to remodel and resorb, right? Right until Pascal Valentini showed 20 years. 20 years, he sampled the sinuses, what he did, xenograft. 20 years, and the particles were still there. But these particles were surrounded by native, healthy bone. So if your patients say, you put cow bone in my mouth, tell them that cow bone lasts 20 years and it shouldn't cause any problems. So cover with membrane versus no membrane, I personally don't. And reason is, look at this, 12 versus 13%. This is what the amount of new bone formation if you cover the window or you don't cover the window with a membrane. So personally, I don't. There's nothing wrong with it if you do, but it's your call. And in cases, I'll explain this. This is one of my cases, and this is how I learned, by mistake. In cases like these, we extract, and we already know that we need a sinus. So we decided to do a socket preservation, alveolar ridge preservation, along with the lateral window, right? So we grafted, but then I push the graft from the socket and it goes to the sinus. I push from the sinus and it comes out. There's no way to stop it, right? And even after I did and covered with membrane, because I was worried, I have 2 openings to the sinus. Imagine how much periosteal releasing I have to do to get primary closure. Remember, this was a socket. This was not a healed site. So, yeah, it worked. I was lucky. I didn't fail. I was lucky. But it wouldn't work all the time. So what I started doing, pull out the teeth and give it some time. Give it between 6 to 8 weeks for the connective tissue to mature, and then come back and do your sinus. And in this case, this is how the sinus looks like after the extraction. And in this particular case, I decided, you know what? I'm going to do only cancellous. I want this cancellous bone to remodel and have really good outcome. And not only that, I want to put plasma in my case. So fine. So look at those 2 nice dome-looking shapes. Fine. And if you look, I have 14 millimeter. I'm placing a 10 millimeter. So I'm in good shape. But what I did not keep in mind, how much remodeling to expect of that cancellous. And we know that cancellous bone graft, because it lacks all the minerals, it tends to resorb more. Not to mention that this dome, in few months, it flattens down. So we have, in 8 months later, I took a post-operative CBCT, and this is how much I have. Look at it. We have 10 millimeters. 10 millimeters, barely. So I lost 4 millimeters. So put into your account, if you're doing a lateral window, slightly overdo it. Slightly. And know your material really well. So we placed our implants, and we were lucky because that's the implant we were planning on doing. But if that ridge resorbed more, I would have been in a bigger problem with the patient. So we already explained that the graft remodeling to expect is about 1 to 2 millimeters, and depending on how much bone graft remodeling you are using, the least that remodels we know is the anorganic bovine, and this has been already proven in the literature over and over again. So prosthetically, it's really important. Who's prosto in the room? Prosto? Okay. All right. I'm sure you guys love us when we say, look at the prosthetic space. In cases like that, what you really need to know, how much prosthetic space you have. You don't want to place your implants flushed with the ridge, because who's going to suffer? The guy or the lady who's going to restore that implant. So in this case, you could either place 1 implant and call it a day for a shortened dental arch, or use 2 implants, short in the back, and avoid the sinus, or maybe angle your implants if you're a believer in that technique, or you could place a longer implant with a crystal approach, or if you convince the patient that 3 implants will serve them better because they can floss around these 3 crowns, good for you. And if you're short on your kids' tuition, maybe you can convince them to place a 4th implant. So really the prosthetic space plays a major role in what's the final prosthetic plan. And we do get outcome from 3D printing. And we do print guys so that we don't have to go and guesstimate where that window is supposed to be. Did I go too anterior? Did I go too posterior? Did I expose the root of that molar in the back? Did I touch it? Yeah, we could use that technology to our advantage. It cuts the time in the clinic, but it needs time inside the lab in the planning phase. And sometimes if you have septa that's bothering you like this one, and you want to know how to do things, you could also use 3D technology to help you minimize the amount of work needed during the surgery and or having a problem with perforating the sinus because of that septa. Now, we're almost closing, so I'm going to wrap it up. So, crystal approach, we all know the crystal approach. It started with Tatum and then with Summers, and we know the osteotome technique, add bone, break the sinus, elevate, and place your implant. And that technique has been evolving, and every year when you go to the companies, they tell you, this technique serves, khalas, no more lateral window. That's what we hear all the time. This is how they sell it. No more lateral window. I said, okay. And I'm just showing you how many technologies are popping out year by year trying to avoid the lateral window. And some of them, they're actually good. This technology came from one of my mentors. It's called internal sinus manipulation. And I'll show you that we put it to the test. We put these techniques in hopes maybe we don't need lateral windows anymore. So even the hydraulics. Some people, they say, use the handpiece, the water in the handpiece, drill the bone, and it will just, elevate the sinus. Some say, we don't have enough money, let's use the monojet. Some say, my balloon is gonna rock. No more lateral window, right? So this is what an internal crystal approach looks like. So we look at the case. This is one of my cases. I guess we had a really good case for that technique. We have 6.4 millimeters. We analyze the ridge. We see how much internal elevation is needed. Because we don't want to do flap elevation, we sounded the ridge and we know how thick the soft tissue is, and we already know where the sinus is, and it's on a slope, and that's the most difficult ones, the slopey sinus, okay? So we want to place a 10 millimeter implant into that sinus. So this is more or less the plan that we have. So we punched and we started drilling, and we stop at the sinus floor before we break it, and we break it with a xenogenic bone graft. I like the xenogenic just because it glows in the dark. Whenever you take a CBCT, you could actually see where the graft is. If it's scattered, you can still trace it. You place your implant, you cover, and this is where the sinus floor is, and this is more or less where the crystal approach. So bear this with me. It looks nice, right? It looks nice, more or less. Say something good. It does look nice? Okay. So it looks nice. You can see the bump, right? And this is what we all put on social media. Good bump. Now I'll challenge that bump concept in just a second. I'll show you what a bump on a PA really means in reality. So that patient left with that healing abutment. So this is how we started. This is what we planned. And this is what the implant, how it looks. Implant in with the sinus floor covered with bone. We're in good shape, okay? So if you look at the crystal approach, the survival of the implant is above 90%. So it's good, not bad, huh? So complications. So these are the complications we should be expecting. You could, it ranges from bleeding, flap tear, membrane perforation, but the number one complication is membrane perforation and the things that follows with infection and so forth, and implant migration. So perforations, some people might tell you, don't worry about perforations, it's only 17%. And some people will tell you, no, it's a bit more. And some people will tell you, no, it's actually 44%. Look at the sample size and see how much perforation there are. And in a crystal approach, 21%. 21% in crystal approach. But my question to them, how was this validified? How did they assure that there was perforation? You will tell me, we use that instrument, right? Or we ask the patient to do the Valsalva maneuver, right? And if there's no bubble coming out, we're in good shape. So go ahead and place the implant. Now, we'll see. So, if you have a small perforation in a lateral window, yeah, you could. First of all, don't panic. Call your mom, your dad, ask for prayers, and then start elevating around that, because you need to release the tension on the perf. That's what you need to do. And if it keeps getting bigger, you could consider either stitching that, okay, or you could cover it with a collagen membrane, for as long as you're sure that this perforation is covered. And if it's more, some people reported, if it's bigger than the 10 millimeters, some people reported that fancy technique where they use this dual membrane, they stitch the membrane. But careful, if you want to do that technique, you're tapping bone tacks in a 1 millimeter thickness of bone. So make sure that when you tack it, you don't break it even further, because it happened to me. All right? So, the bigger the perf, the lower the implant survival. So, at some point, if the perf keeps on getting bigger and bigger, uglier and uglier, abort. Put your ego on the side and abort. Because what really happens is, if you have perforations, the native bone formation is a lot less with perforated sinuses than non-perforated sinuses. The quality of the bone, whether it even looks on good, the CBCTs, the quality, the histological quality of it is a lot weaker when you have perforated sinuses. So, and these are some of the cases that we've done, and we did perforate, but things went well. So not all perforations mean, this is what I'm trying to say, not all perforations mean that your implant's going to fail. Not all the perforations. So this case, we did bilateral sinus elevation, and bilaterally, we had the perf. Okay? But lucky us, we were able to suture it, and then we pushed the envelope a bit where we did a bridge augmentation with it. But because I'm worried to stabilize my membrane with bone tacks, I decided to use suturing technique. So even on the left sinuses, we have perforation, and we cover the perforation with membrane, collagen membrane. Make sure that collagen membrane, before you start packing the bone, it's sealing. Use loops, do whatever. If you have 6 out of 6 vision, good for you. If not, then use loops with good lighting. Suture and then dismiss the patient. This is how 3 weeks looks like. Preoperatively, the patient presented like that, and postoperatively, this is how it looks. And we brought in the patient back for, I don't want to open up that sinus anymore, so I decided to place my implants, and that's how the crowns look like. Okay. If you put too much bone graft, I'm sorry, just let me see. Yeah, this is the complication. So, we did everything by the book. That's another case. Everything went by the book. Okay, we elevated the sinus, we did a good technique, we placed the bone graft, we took postoperative CBCT, and we did a little bit of ridge augmentation with it. 3 weeks, this molar kept on suppurating on the mesial side. We waited, and this is how it looks. When you see the particles scattered in the sinus, that's a bad sign. Bad sign. And the patient keeps on telling you, Doctor, when I swallow, I feel bad taste, and it's called post-nasal dripping. Bad sign after sinuses. Put your patient on antibiotic, but because this is xenograft, it's not going anywhere. So we've decided to open up and then take out the whole graft material. And this is how it looks. Mushy and ugly. Now, obviously, don't do a second attempt of grafting now. Just give it some time. And we used to believe that things heal within 6 to 8 months. Give it 6 to 8 months. Okay. So this is how the patient left on the debridement day. And this is how 8 months still the drainage of the sinus was not in shape. It's on the radiologist that I work with. Not to mention 8 months and still there is no complete resolution of the sinus infection. This is when things start resolving. 17 months. That's when I was able to bring back the patient and do a second grafting for him. So, take a CBCT. That's the message. Take a CBCT, don't rush. The 6-month, 8-month golden number is not always applicable for all your patients. And if you put too much grafting, and this is not autogenous, after some time it will develop central radiolucency. It's called nidus, central radiolucency. It means no blood flow is getting to that graft, and that graft is dead. And for people who want to advocate, yeah, this is how it looks. Internal crystal approach with a window, with a balloon. This is how it looks. So this is on an endoscopy. This is how it looks. But in reality, we take good selfies with these. You know, today I did the crystal approach with the balloon technique, but we don't know what's happening in there. So until this senior colleague of mine decided, you know what, we're going to bring fresh human cadavers and put them to the test. So this is what we did, right? So she compared 3 different techniques: the bone-added osteotome, the dentium technique, and the implantium technique. Okay, they're all crystal approaches, and we compared. Keep in mind, these were fresh human cadavers. They were still in their blood, 2 to 3 days chop. So we took PAs, and we took postoperative CBCTs, and we compared them to endoscopy. So obviously, if endoscopy says perforation, yes, it is obviously yes, right? And we found out that the aid that we get, the perforation, whenever lifting the sinus crystally, 5 millimeters, is 40%. 40%, right? And the addition or the value of the PAs, is very weak in detecting sinus perforation. CBCT is a bit better, but obviously the gold standard is the endoscopy. So whenever you see an implant looks like that, with a nice dome shape, and you want to take a selfie, remember my face. Because you might have the dome, but the perf is on the side. So whenever you're seeing mesodistal. You don't see in a 3-dimension, right? You don't see it on 3-dimension. The only way for you to know is direct vision or endoscopy vision. So I was a resident, and I've decided, you know what? I want to do this. This mentor of mine is called Jason Yamada. He's Japanese, and he's so brilliant. He developed this technique. So I said, you know what, Dr. Yamada, let's bring in another set of fresh human cadavers, and let's put them to the test and compare them to osteotome. Okay? So obviously, you drill, you open up the sinus, and then internally, you detach the sinus. Keep in mind, this is all tactile sensation. You can't see anything. And we compare it to the bone-added osteotome technique. That's the research, basically, right? So this is a case with the endoscopy watching over and telling us, look. Of course, Yamada was not aware. We had the ENT within the endoscopy inside, but the clinician does not know if perforation happens and when does it happen. He might actually continue. He might have a perf in the first 10 seconds. We will keep him working. We'll laugh, of course, but we wouldn't tell him. Okay? So open up the sinus. So what's happening is, it looks like a ladder window, but we're detaching the sinus crestally. So bone added, an implant is going to go in, and then we will see if there is perforation. Obviously, there is no perforation in this one, but that's the other case, one of the cases where we had, and perforation happens. So, do you see the tension around the implant? Although it's elevated, imagine that you're doing this without this release. The chances of perforation is really high. Okay. How much more? 2 minutes, okay. Okay. And this is with the bone-added osteotome. See how thin the membrane. I want you all to see how forgiving that membrane at some point. But then there is a limit, of course. And we keep on, it's like a paper thin. And, you know, it still did not perforate. Elasticity in sinuses differ from one patient to another. Thickness of the sinus differ from one patient to another. The history of that sinus differs from one patient to another. However, what I'm trying to say is don't push these techniques a lot. There are limitations to these techniques, and if you're planning on having a practice of implant dentistry and you're planning on doing this surgery, you need to be trained in both techniques so you have all these tools in your bag, because there is no one size for all. Vertigo is one of the problems. That's why with the osteotome bone added technique, patients, they have this. And for those who want to know what's a vertigo looks like, this is what a vertigo, you have a constant headache that's so painful. And we did later on research using the same thing with the osteodensification technique, but I'm going to have to skip because I appreciate Dr. Lagel. He's been really kind to me today. And are you presenting me for the next lecture? Oh, okay. Okay, never again, huh? All right, thank you so much. All right, so we compared, again, bone-added osteotome. In this case, we cut the heads in a different direction so we don't have to use an endoscopy. So minimize the contributors of that research, cut down ENT. We don't need them on dead people, you know? So now we can visualize, but again, the clinicians who were operating, they have the skill, and they were doing both techniques, and they were very skilled clinicians. So we tried to minimize the bias in this opinion. But really, what we found that the amount of bone-added osteotome techniques when compared to osteodensification drills in a split mouth manner on a fresh human cadavers were really high. Really high. Of course, we were elevating 5 millimeters. 5 millimeters. So actually, the osteotome did a bit better. But if you ask me, what's the sample size? I'll tell you, we were only lucky to get 10 heads. 10. Fresh human cadavers. So I can't say that this research is conclusive, but I can tell you that majority of the bone, of the osteodensification perforated after the implant placement. So if you check and there is no perforation, yes, you might be right, there is no perforation. But once you place the implant, the perforation happens later on. And there is no way for you to know. And we've shown that CBCT wouldn't be able to tell you. So the difference between both techniques was not significant. So make sure that if you have a migrated implants, you make sure you don't, you refer them to the proper oral surgeons, ENT, just like in this case where a fracture got dislodged and then got inhaled by the patient all the way to the lungs. It could be serious. So loose objects will not come down by gravity, okay? And chronic sinusitis that we cause is a potential. So to conclude, we have good evidence. We can't just say that the evidence that we have is weak. We still need more research on certain techniques. Have your own team if you're doing this. Know an surgeon, an ENT, a radiologist, a pathologist. If you plan to touch sinuses on a regular basis, prosthetic plans, don't upset our fellow prosthodontists. And we should be trained on different techniques. We can't just tell our residents, there's one trick that will take care. So whenever you go and shop around for material or instruments, and they tell you, this is the solution, no more lateral window, walk away, because there is no such thing at the moment. With that, I would like to thank you, Dr. Sam, for being such patient with me, and thank you, Dr. Where is he? Dr. Fawaz and Dr. Salim, good friends. I love you guys so much. Okay, you have ask me a question? Now you want to ask me a question? I thought you want me to leave.
No, not yet, not yet.
Anybody have some questions for the...
Doctor.
Yeah, so thank you, Dr. Abdelkarim, for the lecture. Anybody has some questions regarding any sinus lifts procedures or grafting materials or anything that he has presented? You may ask. تفضل دكتور.
يعطيك العافية دكتور. كنت بسأل في the first surgery, why you didn't leave the septa in the middle? Why did you break it?
أي surgery دكتورة؟
الأولى.
Why didn't we leave it?
Yep.
الفيديو قصدك صح؟
الفيديو في كان
في
septa.
septa.
You break it off.
Because the plan was to have multiple implants, and this will be in the way. لا احنا اللي هنا ولا احنا اللي هنا، عرفتي؟ So we need to cut that to be able. If you keep septa and you keep trying to work around it, just for the sake that you want to keep it, it might be an obstacle. Sometimes if that septa is not huge or completely separating the sinus into anterior sinus and posterior sinus, just cut it. It's not that thick. It will come out. So على حسب وين الإمبلانت حيروح. What's the plan? وين الواكس اب؟ شفتي السي بي سي تي لما عملناه كان في radio opaque material representing wax up. Based on that wax up, هذه septa will be in Dr. Alauddin Weiss.
Yeah. Any other questions before we move on? No. All right, thank you so much. Oh, yeah, please, go ahead.
All right, thank you for the presentation and compliments on the presentation skills. So I'm going to be quick about this. So my first question is, whenever you are trying to remove the window, the bony window, at what point, if you find it like a little bit sticky or tenacious, you just stop and decide to keep it?
Okay. The question is, at what point you stop the pressure, right? What point? Because it's going to be looking gray, right?
Yeah, if you're gonna push, you decided to push the bony window.
Okay.
All right?
Okay. So what I do, I don't want to market, but this is the reality. I use the desk, right? And or any other company that has the same tools. So I have this probe that has a flat end. So if the sinus is depressible, then khalas, then that's it. Don't go more. Because you might leave a little bit of thin eggshell bone on it. But it's still depressible, stop. Try now to detach the corners and move on. So if it's a bit depressible, that's an answer to your
All
question.
right, one quick question. In the case of the rupture of the PSA, what's your go-to technique?
Okay. You know, I might say this from a very humble experience. There are people in the audience here that might have more. But I have not yet seen a PSA rupturing. It ruptures with me. I'm not saying it does not. It ruptures, and it ruptures all the time. But I have not yet seen a PSA rupturing and the patient fainting because of it. Let's establish. It's not the greater palatine. Let's put it this way. However, if you really want to stabilize it, you can cauterize it. Fry it. Just fry it, because if you try to clip it, there's nothing to clip. It's already squirting from the side of the window. So there's nothing that you could do, right? If you want to go in with a short needle and maybe inject some local anesthetic that has some epinephrine, yeah, good luck, but it does not stop. The very first thing to do, pack and wait for things to stop. Bone wax, I've tried it once. It loosens up.
All right. Thank you very much, Dr. Abdul Karim.
You were going to give me a gift? Yeah. I'm so happy. Yeah. راضي علينا أبو فهد. الله يعطيك العافية. Thank you so much.
Our next lecturer is Dr. Mohammed Bassam.
كيفك دكتور؟ شو اخبارك؟ ان شاء الله تمام. حبيبي تسلم لي. ثانك يو. يلا رح احط هون انا كرمال معي. يا. Just go ahead. Yes. لا هيدا لا هونيك.
I'd rather if you finish 40 minutes so we have 5 minutes for questions.
I will do my best. Sure.
So, Dr. Mohammed Bassam is an ITI member of the American Academy of Periodontology. He graduated in a general practitioner in 2006 as a specialist in periodontology and implant dentistry from the Lebanese University, as well as the DESS in 2013, practicing full mouth rehabs and hard and soft tissues. Dr. Mohammed has an amazing social media account. I'm one of his close followers.
Thank you so much.
So I really highly recommend
You as well.
watching. Thank you.
Yeah.
I really highly recommend you seeing the way he documents his images and how he produces them and how clean they are, as well as seeing the steps of whatever he does. So I'm sure you will thoroughly enjoy today's lecture. So
Thank
no
you so
pressure,
much.
Doctor. All the best.
Really, thank you, thank you. Good afternoon, everyone. Hope the microphone will not cut now. Just when it's cutting, just let me know. First of all, I want to thank the scientific committee and the KDC and the Kuwait Dental Implant Symposium. I'm so pleased to be in the first Kuwait Dental Implant Symposium. I would like to thank all the organizers, the moderator, and Dr. Ahmed Al-Sharad as well, the head of the Kuwait Association of Periodontology. And it is really a pleasure to be with you. My name is Mohammed Bassam. I'm from Lebanon. It's a country where the mountains meet the sea, and where nature meets history and archaeology, and where there is a lot of archaeological places. And as well in my country, I've learned that coming together is going to be a beginning, and keeping together, it's a progress. And finally, if we work together, we're going to succeed. And that's why we are here in this event, and all the events, the scientific events all over the world, is that we try to share knowledge, learn from each other, and at the end of the day, we evolve and progress all together. Today, I'm going to talk about a procedure that I like a lot, which is GBR, that we integrate in our daily practice, and we're trying to see how we can increase the predictability of this technique and the final result of our technique. And let's always keep in mind so that most of us, we are working in private practice, and in private practice the things are a little bit different than when you're working in universities. You have patients who wants to be satisfied, who's coming for results. They want the job done with the best result and the least morbidity. In other words, we have to avoid complications. And when there is a complication, it should be minor. Today, we're going to discuss thoroughly two cases. One of them is lower mandible. We have it a lot. Patients coming with old bridges. Teeth has been are for extraction, and we have a knife edge or residual bone that is not enough for our implants, and the incisor, the central incisor, the major problem that we have in our clinic, the aesthetic zone. So, as like any case, before we start with it, we have to plan it properly. So, the most important part, other than checking the anatomical features and all of that, we have to study the defect. Many classification has been published all over the years, the past years, but personally, I like the Cologne classification of alveolar ridge defects, which was, it's old, 2013, which is almost 10 years back. But what I like about this classification, that it classifies the cases in the resorption being horizontal or vertical, or it's combined, there's sinus, you need to augment the sinus or no. It gives you as well the augmentation that you need, the amount of augmentation that you need, or the defect that you have, it's less than 4 to 8, more than 8, and all of that as well. One of the most important features in GBR is that, are you going to augment inside the contour of the bone or outside the contour of the bone? Whenever it's inside the contour of the bone, it's not really difficult, but when you're going outside of the contour of the bone, you will have a collapse of your membrane, and you might end up with 0 augmentation. As well, let's see our GBR where it's gonna go. Our GBR will be between 4 to 8 here. This one is with non-resorbable membrane. Here we're talking about resorbable material. And as well, when we're going outside of the contour, we're going less than 4 to 8. And in this classification, as you see in vertical, it's not mentioned. So let's see if we can challenge this classification. So what is our material of choice? Nowadays, with all the papers that have been published, always include autogenous bone. Whatever you're doing, GBR, autogenous bone. How to collect autogenous bone? It's simple. You can go with safe scrapers. There's drills. You can scrape just next to the site where you're doing your implant. When you're placing the implant, if you will combine it with a GBR, while drilling, most of the drills right now, you can collect bone when you're drilling the bone. As well, even if you're going with PRF, you're going with a sticky bone, and all of that, just include autogenous bone. It will give you better result as per the paper published in 2016, and another one in 2018 by Istvan Urban, where he compared adding autogenous bone to his xenograft, 40 to 60, 70 to 30, and 90 to 10, and he found that the best result was 60 to 40. I guess now he's working 50-50. So let's keep it in mind, 50-50 autogenous and another bone substitute. As well, we have to respect the main GBR principles, which is primary closure, angiogenesis means vascularization, space creation, and we will have this stability of the wound after we finish our surgery and we close up, and that was published by Wang et al. In 2006. So, usually for me, personally, I'm going 50-50 auto-xeno. Why? Because I need this scaffold that I made, I want it to last the most possible. And in some publication as well, they compared the GBR to bone blocks. They found out, this is a meta-analysis, a systemic review meta-analysis, they found that GBR gave them a gain of 3.6 and bone block 4.1. Okay, so a 0.6, is it really what we need? A 0.6 different, we will go cut the ramus, you will tell your patient in private practice, well, we're gonna go to the ramus and cut a piece and we will use it in the front. Now here we're talking about bone block, we're not talking about Khoury technique. As well, when you're going with PTFE membranes, the titanium reinforced membranes, the PTFE, you will have great bone. It's really great, it's huge. But what is the complications here? Pus, flap, membrane exposure, and the flap will open, you will end up with pus, and maybe you can manage it, maybe not. And now they're opening a new subject, how to manage the complication of the PTFE membrane exposure. So let's not go into that. Let's find another way. As well, when you're going with Khoury technique, you might end up with a tremendous cases with tremendous volume, bone volume, but sometimes, in like this case, done, somehow it's good. But we ended up with a palatal plate, didn't integrate well, so I had to place my implant as well, GBR. So at the end of the day, I'm going back to GBR. So let's masterize this technique. So the first case is this patient finished her prosto treatments, and tooth number 7 and 8 were for extraction, and she has a resolved bridge because she had a long bridge going from second molar to canine. So they removed it, they finished the prosto and sent it to me for implants. Maybe it should be the other way around, but this is what happened. So I received the case like that. The first thing I do, I extract 7 and 8, and I wait for soft tissue closure, and then I will open my flap and go through the case. So what we did here, okay, I did a CBCT. I have bone almost 3.0, 2.6, a little less. I have the mental foramen opening around 6 to 8 millimeter. And as well, I made a radiologic guide, and as it shows here, for example, you're placing your implant. If you place it in the right place according to the occlusal forces and you will not tilt it, you will end up with half of the implant outside of the bone. So to place our implant properly, in my personal experience, I prefer to place my implant the closest possible to the occlusal, to the direction of the occlusal forces. I will not take the patient to huge surgeries, huge bone augmentation if it's, let's say, a deviation of 1 millimeter, but sometimes when it's more than that, half of the implant is outside, you have to go for grafting first. So I opened a full thickness flap. When we're opening the full thickness flap, just like the doctor just said, we have to remove all the tissue of the bone, all the tissue tags, everything, clean it well. Make sure that when you're opening your flap, make sure that you don't have any tears in your flap. If you have a tear in the flap, just try to fix it right away. And as well, I'm not that fan of vertical incisions, so I basically go with without vertical incisions. And then we decorticate. I decorticated. I placed my tenting screws. Later on, I will tell you how to put it and how many millimeters should be out. After doing that, I jumped directly to expose my mental foramen, okay, and expose my mental nerve. Personally, I don't go all around the mental foramen. I don't expose the whole area. I will just locate it right to the top, the most coronal part of the mental foramen, and just keep it. If I augment there, I will not need more than that. I'm not gonna go for this dislocation or changing the position of my mental foramen. And then after that, I will jump directly to flap management of the lingual flap. According to East Van Urban, we have zone 1, zone 2, zone 3. You start with elevating the retropad, and you go with tunneling, and then you go to zone 2. In zone 2, you start to detaching. You start detaching your lingual flap of the myloidian muscle. And then when you go to zone 3, in zone 3, you can make a release incision with semi-blunt instrument, but I don't really need it. In most of the cases, we will have closure with doing only zone 1, zone 2. You don't need to go to zone 3. And when you're doing the flap elevation, the lingual flap elevation, you will see that by brushing, you start with elevating here, and then you start elevating, detaching your lingual flap of the myloidian muscle, and then you elevate it all, and you will get up to 20 millimeter of elevation of the lingual flap, which will help you in primary closure, the thing that we talked about with Wang in 2006, and the principles of GBR. And then I go to management of my buccal flap. I do it randomly. I do it with a Ronda technique, which you start distal to mesial. After proper elevation and all of that, distal to mesial, 1 millimeter deep, superficial, all the way from distal to mesial. And whenever you are next to mental foramen, you have to be 4 to 6 millimeter away from the emergence of this of the nerve. Why? We don't want to end up with paresthesia and not to sleep the next day, maybe for 6 months as well. So what you do, you start with your incision, distal to mesial, and then when you are at the level of the foramen, you have to stay 4 to 6 millimeter away, and then continue. If you want to do a vertical release incision, you can do that, but you have to be away from the mental nerve. As well, as we said, we have to respect the anatomical feature, and after doing this, you will use a semi-blunt instrument with a brushing movement, apical coronal, to release the tension of your flap, and make sure that all the tension is released. Whenever you have some attachments, just try to locate it and try to fix it. Whenever you have very well released flap, you will finish your case properly. Okay, so about the tenting screws, usually when we talk about GBR, the main augmentation that you want, if you're starting with 2, you want 4 to 6. With GBR, the publications and all the research literature showed it's almost like 4 millimeter. So why to put our screws out more than 4 millimeter? Personally, I put it 4 millimeter out of the bone, and I put it 1 millimeter below the peak of the bone. So it's gonna be out 4, and under my peak of the ridge, 1 millimeter. As well, I put it in 45 degrees, to get the support, proper support for my membrane, as well whenever there's proprioception proprioception forces from the soft tissue coronally. And after that, I pack my bone. When we say pack, we pack. It should be packed, very well packed. Whenever you have, if you see that your membrane is loose, means there's not enough there's not enough bone substitute under it. So when you pack, we mean we pack it very well, and you will see later on why I'm saying that. And then I place my membrane. Whenever I have extended ridges, I prefer to go with auto-tax mini screws to stabilize my membrane. Whenever the site is small, I'm not afraid of that my bone substitute goes out from the apical part. Okay, I go with sutures. And after that, I close. How do I close? I close with non-resorbable 5/0 nylon sutures. Here I use like 3 horizontal matrices, and then continuous interlocking and interrupted suture in the front. Nowadays, I changed a little bit my suturing technique. What I'm doing now, I'm doing horizontal matrix, and I'm using modified vertical matrix and modified horizontal matrix. It's giving me better closure, faster, and sometimes I'm adding some interrupted sutures. So, but when you are releasing well and you're closing with horizontal matrix where it should be, you will end up at the end, you're closing only the soft tissue on top, which is not really where you will have the problem. Mainly you will have the problem really a little bit deeper. But when I change my suturing technique using horizontal matrix, modified vertical matrix, and modified horizontal matrix, the results were better. And this was at day 0, and this is at day after 5 months. Personally, I like to keep it as much as possible. Whenever the patient is not nagging, I'll just keep him. If I can keep him 4 months, 5 months, up to sometimes 6 months, the more you keep the patient waiting, up to 6 months, let's say, the maturation of the bone will be better. When you open, you will not see particulates that is attached to your flap. In this case, this is how the case look after 5 months. Still have how much time? Half an hour or less? Yeah, great. So we opened the flap. This is how the case was as day 0. This is how the case is at 5 months. And what I like about the tenting screws is that you can visualize how much bone you augmented. Even you take the CBCT and you can measure and use the stance and do your during research and all of that. But when you visualize that, oh, I cannot see my screws, and when I tap on that, it's bone. And my screws are inside. I placed them 4 millimeter out, and it's still covered with bone. I had to dig in these 2 points here to get my screws out. So this is the amount of augmentation. So you can see, for example, here, by not elevating the periosteum here a lot, you had this nice emergence of your nerve. So it looks nice, it feels nice when you're placing your implant, and this is the amount of augmentation that we had. We went from 3, this is the screw all covered, this is the screw all covered with bone. And after that, when I wanted to place my implants, I used a digital surgical guide. In this case, it was teeth-supported surgical guide, which is not the perfect one here because it's going to bend at the end. But what I used it for here, just to make sure that I'm placing the implants where the prosthodontist told me to, I planned it to, so he will not be frustrated later on. So we opened the flap, I placed my implants. This is where I had to dig to remove my screws. And this is the amount of bone that we created. And these are my implants. And here, we had to take care very well when placing the implant. We're putting it flush. So you have to make sure when the drill that you are using is exactly the length of your implant. If it has this small tip at the end, you're gonna end up by just checking how much is the depth, you will end up injuring the nerve. So this is the case from 0. This is after placing the bone graft, and this is after placing my implants, and this is at the second stage surgery. And if you see how the bone changed from the second photo to this one, it's smooth, it's corticated. These cases will end up as well with soft tissue management. We go to the gold standard, free gingival graft. Stabilizing my gingival graft, the first one is the primary stabilization. The second one is when I stabilize it more wherever it's moving. This is how it looks. I had some attached gingiva here. I didn't want to remove it, so I started my dissection as well. You started from mucogingival line, and you start dissection. You start your dissection. So this day 0, day 10, and day 25. After that, you wait for maturation of soft tissue. I usually wait not less than 2 months before going with the crowns. And this is how the case was, and this is how it is. We'll go to the next case. I'm not discussing the prosto here because we're short on time. So the next case, the patient came with an attached central incisor. I was I forgot to take the photo when he first entered, so I removed the central, and then I have to take the photo. So I took my camera and took the photo. When I digged with this case, the patient came like 3 years before his first visit with me. He had an external resorption on the central, and the doctor mentioned in the file that he has an external resorption and he has to extract. The patient did not do anything, and he's a French guy. And then he came with a loose crown attached to soft tissue and remaining root inside. When we take the CBCT, you will see that we have lost horizontal and vertical. And let's say most of the cases that you're working on, you have a combined resorption. You have horizontal and you have vertical. So if you go back to the case here, for example, you will see that we did some vertical augmentation just by packing from the first one to the third one. We elevated in this area just by packing. That's why when you pack, try to pack really well. Okay, so we needed here horizontal and vertical augmentation. So let's challenge that classification that mentioned that we need a PTFE or non-resorbable membrane to elevate vertically. So this is the case. What I like about GBR, whenever you're using resorbable material, you don't need to go with big flaps, with long flaps all the way from the second molar to the second molar. You can just limit the case with 2 vertical incisions and a crestal incision, but make sure that you elevate your membrane properly and you don't leave any soft tissue on the bone. And here we removed the remaining root, and then I placed my screw. When I placed my screw, I put it 1 millimeter below the peak of the bone, mesial and distal, and then we pack. This is what I mentioned earlier. If I don't put an attack here, the membrane will, the bone substitute will migrate apically. So whenever you don't have a contained defect on the most apical part, it's better to go with tag, or there's another way. If you're going with vertical incisions, or mainly when you're doing vertical incisions, you can take a suture at the most apical part. Just grab the periosteum from here, and to the other side, grab the periosteum and tie it, and you will make like a small knot all the way at the base of your membrane, so your bone substitute will not migrate apically. I placed here a cross-linked membrane, and then on top I placed a non-cross-linked membrane. At that time I was reading one of the papers that said that cross-linked membranes, the non-cross-linked membranes doesn't have flap exposure of membrane, it has less exposure membrane than the cross-linked membrane. So I said to myself, okay, so I'm going with double layer here, so let me put one cross-linked and one non-cross-linked. So we did that, and I stabilized the second one with suture. And this is the case after the surgery. I'm just like other doctors, I do CBCTs after my surgeries. And this is when the patient came after 5 months. You see on the X-ray, on 3D model, as if you just did it. So it's almost the same. Okay, so this is the CBCT after. This is how we started. This is how it is. This is my screw. Always, we overcorrect. So I overcorrected the whole area, the whole site. And this is how it was, and this is the amount of bone that I've gained. Let's open and see. Okay, I opened, and okay, so my whole screw is inside. That's good. So is this satisfying? If it's hard, it's satisfying. I prepared the best way to finish these cases is with a digital surgical guide to make sure that you're placing your implant properly, 3D position, screw retained will be great. And this is when I placed my implant. At this part here, the bone was soft. So I prefer to remove it because when I place my implants, I always go with a baby bone graft. So I placed my implant in, 1 millimeter deeper. And just always keep in mind, when you're placing your screw, especially in the interior, if you're relying on one screw, try to place it where the implant will be. Why? Because it will help you. It will be like the first drill. This is one. Second, when you remove it, you will not have any holes to fill. So this is the screw, this is the implant, and this is the final, and this is the last implant. This is, sorry, the CBCT after the patient left, and this is this is the baby bone graft that I always do. As per East Van Urban, 2016, he said in his book, he said that when you're doing your baby bone graft after you're doing the first surgery, mainly he was using PTFE membranes in his book, in his technique. When you're doing your second surgery and you're placing the implant, you do a baby bone graft, this will help increasing the quality of the bone that you have. And this is the final, when I place the implants, more than 2 millimeter, more than satisfying. I think Professor Chen will be happy with this. Okay, so let's see if it's gonna be, if it's repeatable. Can we repeat it? So predictable technique, it should be repeatable. I have to use it on daily basis. Is it easy to use on daily basis? Can I repeat it? Can I do it again? So let's see. Patient came during ortho and she had almost knife edge. Tent and bone grafting, blah, 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 all the procedure that I've done before. And this is how she came. I placed my implant. My mistake here, I didn't pack properly. So when we're doing our bone graft, we pack very well. Maybe if I packed well in this area and I extended my membrane between the canine and the lateral and I tacked it there or I sutured it there, I might have had a better result, but still this result is acceptable. I place my implant, I do my second GBR as usual, and I close, and it's gonna be well. Mandible, this patient, both sides, right, left, this is one of the sides, this is the result, place the implants, done. We go to the other side, as well, I placed my screws, bone grafting, and in this case, I had to go with soft tissue free gingival graft first before placing my implants. Why? Because we were planning on, I was planning on soft tissue level implants. And here, for example, we removed the screws. I put my free gingival graft. Here it's the regular one. Here we call it the strip technique, when you're leaving space between the soft tissue, the attached gingiva of the patient and the free gingival graft. As well, sometimes it doesn't work well. In this case, the patient had flap exposure. I didn't manage my flaps very well because I thought that I was the best in town, so I didn't do it well. So I ended up with losing some of my material. But this is what happens when you think that you're the best, or you're doing things very well, just you get lazy a little sometimes. So even though I still had some bone here that I can start with, I placed my implant, added some bone graft, overcorrected, used sutures to stabilize my membrane, used my healing abutment also to stabilize my membrane, and then I closed over it, and this is the case after. This is how the patient was at the delivery day. A huge amount of bone, huge amount of soft tissue of attached gingiva. So this is my last one. I'm on time? Yeah, 2 minutes. So this was one of my first cases. I was saying to myself, let me put my screws 5 millimeter out, as well let me put my screws above the bone peak. I don't want to follow the book. So let me do that, and let's see what's going to happen. I placed my screws, I put my bone. She had an old implant. Placed my bone, my membrane. The manipulation here was a bit difficult with the patient with the short vestibule. So I placed everything, closed, very well closer, no flap, membrane exposure, and this is how it ended up. The screw punched the soft tissue. When I see this, means I lost a little bit more than usual of bone. But still, I gained like 1 to 2 millimeter here. That was enough for me to place my implant. In this case, I went with the sandwich technique, always with resolvable membrane, resolvable material, with autogenous bone, of course. I collect autogenous bone from the ramus, mixed with I placed it directly over the implant surface and the bone, and then I covered it with xenograft, and then placed my membrane, tack it. As well, as I said, the manipulation on the mesial was a bit difficult, so I added a suture on the mesial, and this is how it is. And let me go faster. This is when the patient came for second stage, enough buccal bone. So I dissected, and I went with soft tissue graft over the old implant and the new implant. And this is on day 0, day 25. Day 25 is when I remove all the stitches. And this is how it was, and this is how it is now. So, first of all, respect the anatomical features, just like in any kind of surgeries. You have to respect the anatomical features. You have to check all of that on visually, panoramic, CBCT, everything. Next, you have to study the defect anatomy in order to pick the right procedure for your case. Always use autogenous bone. Go big or go home, always overcorrect. Whenever you're doing GBR, overcorrect the site. Make sure you close over it, have primary closure. Always stabilize your membrane using suture, using tacks, whatever it takes, just stabilize your membrane. Don't place a floating membrane. Many of the cases I did before without stabilization. I came back, and when I did the CBCT, it was new. I used to do it on the second stage. Whenever I have a case with GBR, I found out that I lost the bone that I placed. Always have 2 millimeter of buccal bone over your implant, and tenting screws will increase the amount of bone that you are gaining, especially when you're going outside the contour. Okay? And thank you so much. If you would like to check my daily cases or check what I do on daily basis. You can follow me on Instagram. Thank you so much.
Thank you, Dr.
Questions?
Mohammed, for the beautiful lecture.
Thank you.
I would also like to add to the list that you added at the end is time. Time is very important to give the bone,
That's true.
allow it to form to the level that you can have very successful implant. So what's the time that you recommend us waiting after doing a
Not
really
less than
extensive-
4 months. Whenever
Okay.
you're doing augmentation, bone augmentation, I don't wait less than 4 months. I know there's papers, if you add PRF, if you mix with some things, but still I wait 4 months, not less. Whenever it takes me, whenever I can wait a little more, I will do it.
And why the 25 days for suture? Don't you think it's an overkill? Some people might want to remove it like in 2 weeks.
No, the
maybe.
patient comes at 10 days to remove the stitches in the palate, and then I will check the wound, and I will see the site of the graft, and I will see if there's any loose sutures, I will remove them. Otherwise, I will let them wait like 4 or 5 days more, and then I will remove the stitches, mainly the overwrapping stitches. If we're going with, let's say, the free gingival graft, when you go from top to bottom, this one, this continuous one, this is what I use sometimes. I remove it at 14 days, and then I keep some stitches if I see that there's some places that is a bit loose.
Okay.
That's it.
So, any questions from the audience? Yeah, we have a question in the back over there. If you can pass the microphone, please.
Thank you for presenting. Just you mentioned one of your cases, you decided to place soft tissue implant rather than bone level.
I'm sorry, but I cannot see you.
He's asking that one of your cases
I
you
cannot
place
see
a
him.
soft tissue.
I don't.
So one of your cases, you
Yeah.
mentioned you placed soft tissue level
Yeah.
rather than bone level.
Yeah.
Just for curiosity, when do you choose soft tissue implants?
Just
rather-
for the sake of the length.
All right.
Because I had the length of the bone, the length from the top of the bone to the nerve, that was around 7.5. Yeah, and I preferred to place a 6 millimeter implant. Unfortunately, on the market here, there's only, I think, the Astra.
Astra.
And Astra, mainly they're not getting it. So,
Yeah, I got it.
so
Yes,
I had
think-
to go with the soft tissue, which is Straumann, 6 millimeter soft tissue, because the BLX as well wasn't here.
Thank you.
That's it. Welcome.
Any other questions?
Hello.
No? All right. Yes, please.
So you prefer to use the tenting technique rather than the reinforced membrane techniques?
Yeah,
So what's your point of view?
it's complications.
Can you use the mic?
Okay.
Yeah.
You prefer to use the tenting technique rather
Yeah.
than the reinforced membrane.
Yeah.
What is the point of view?
Look, the reinforced membrane, it's a useful technique, and it works very well whenever you have, you need an augmentation that is around 4 to 8 millimeter, okay, or less than 4 millimeter is fine, but I think the maximum range is 6 millimeter with the titanium reinforced membrane. But the thing is that the complications that you get after the titanium reinforced membrane is really horrible. You will get separation if you had a complication. If it works well, it's great. You will get a better than the tenting screw, for sure. If you're doing Khouri, as well. If you're doing bone blocks, it's good. But Khouri mainly now we're working with Khouri rather than bone blocks. But if we're working with Khouri and PTFE and it works well, it's great. You will get a very nice bone. But if you have a complication, either you will manage soft tissue to reclose, if it's possible to reclose. I told you that now they're trying to find ways to close it again and try to keep everything in. But whenever you have suppuration, you will end up sometimes to reopen, remove everything, and close. So this is the main thing. But as you see in the last case, even with if this was done with PTFE and we had a complication, I have to remove everything. But at the end, the patient came after 4 months, and we just removed the screws, placed our implant, do with bone graft, and done. That's it.
All right, thank you so much, Dr. Mohammed. Before you guys leave, we'll be back here in half an hour, so 3 o'clock will be the next lecture. So see you soon. Thank you, Dr. Mohammed, again.
Thank you. Habibi. Thank you so much. كلك ذوق.
Hola, hola, hola. Hola, hola, hola.
Okay, I hope you enjoyed your coffee and snacks. It's my great pleasure to be a chairperson for this specific Hello. Test, test. Test. Yeah, it's one. Sorry for the delay. I have the great pleasure to be in this specific session because both of the speakers are alumni. Let me introduce our first speaker, my dear friend, Dr. Fernando Suarez, who earned his DDS from the European University of Madrid in Spain. He completed his certificate and master's degree in Perio at the University of Michigan. Currently, Dr. Suarez works in private practice in Madrid. He's the program director of the Department of Implant Surgery and Prosthodontics in Alfonso X El Sabio University School of Dentistry in Spain. And he's also a visiting assistant professor at the Department of Periodontics of University of Iowa. Dr. Suarez is a diplomate of the American Board of Periodontology. For the contribution of science, he published scientific articles and textbook chapters in the field of perio and implant dentistry. Until yesterday, I checked this in the ResearchGate. He has 103 publications and more than 3,400 citations. So without further ado, please welcome Dr. Fernando Suarez.
Thank you very much, Ali. It's really for me a pleasure to be here today and be surrounded by many good friends. And thank you very much for inviting me. The topic that we are going to cover today, it's a topic that we have seen very frequently in a lot of meetings. We all have heard about periimplantitis very, very often. But what we are going to do today is we are going to give it a different approach. And I'm not here to tell you a recipe or an instrument or a certain device that will cure all periimplantitis. We are here today to learn a little more about this disease, so hopefully we can be able to treat it better, more predictably, and at the same time be able to prevent periimplantitis from happening. Before I start, I would like to acknowledge quite a few people that without them, none of this will be possible. I'm very lucky, very fortunate to have a very great group of colleagues and friends throughout different schools. And the clinical cases, and as well as the publications that I will be sharing today, is the results of not only my work, but the work of a great group of individuals. And I would like to start by showing some cases that I did, as Ali said, when I was at the University of Michigan. And this is a case that was referred to the perio department from AGD. And the referral said, please remove the most distal implant. That implant is moving. Other than that, everything is looking great. And they sent the patient down with some periapical radiographs. They said, there is no bone loss. We don't know why the implant is moving. Please remove it. We proceeded, the first thing that we did is that we proceeded to take some better radiographs. And when we look at the panoramic view, we realized that the picture is a little different than what they were expecting. So this is a patient that would not accept any of the treatment. He wanted to keep all his implants, so we have no choice to perform resective type of treatment. We removed the implant that was mobile, and this was the final result after resective therapy for periimplantitis. We have another case, a case that I treated in combination with my good friend, James Mailoa. This is a very unfortunate case. This is a patient that she received guided bone regeneration, placed 3 implants. The implants failed soon after. This is the second set of implants that this patient had. And only in a few months, we see this case of periimplantitis. This is obviously a hopeless case. These implants should be removed and basically start over, but the patient denied any sort of treatment that would remove those implants. So we proceeded with periimplantitis treatment, and this is the situation that we have after a few months. And here we have another case that I treated myself. This is one of my favorite patients back at the University of Michigan. I saw this patient when I was in my first year residency. She came from maintenance. She has natural dentition on the maxilla. And she came from maintenance. And I said, that's great. Why don't you remove your bottom denture so I can take a look at those implants? And she was very surprised. She was like, why are you asking me to remove your denture? She was like, because I want to take a look at those implants and clean the implants. And she told me, well, nobody has ever told me that before. When I come for cleanings, they only click my top teeth. Nobody cares about the implants. So this is the situation that we have a few years after implant placement. We do resective type of therapy, and these are the results that we have after 3 years of therapy. And when I look at these cases, these 3 cases in general, even though we can claim that from the periodontal point of view, these cases may be successful if we were able to reduce probing depth, we can also realize that periimplantitis is much uglier than what we see in journals, in magazines, in social media. We all want to post the cases where we can do regeneration of a contained defect around an implant. We all love to do CTGs around dental implants, but the reality about periimplantitis is that many cases are very ugly. What would happen if these implants were in the anterior maxilla? Would we call this success? And not only that, these are cases there is a huge amount of destruction of the periodontal tissues, both bone and soft tissue. These cases are very challenging to treat after the fact, once periimplantitis has occurred. And what about the success? What happened with these implants in the long term? What do we know nowadays? So when we look at articles that look at success rates for periimplantitis, if the clicker one to works, we realize that it is not as promising as we've been told. The success rates, they ranges from 20 to 40% after 10 years, but also after 1 year. Success rates are pretty low. Are we telling our patients that what we do, trying to save those implants, it may be successful in 20% of the cases? We have more research looking at that. Once again, looking at around 40% success rate. And very importantly, from the implants that they do not success, most of those implants have to be removed after a while. They obviously continue losing bone, and some of them have to be retreated. So this is something that we investigated very recently. This paper is still online ahead of print. And we were specifically looking at all the research that has been done, that has been treating periimplantitis with at least 12-month follow-ups. And when we look at these investigations, we realized that the success rate is actually very low. Here we have the number of investigations. The higher, the more investigations, and here we have the percentage. As we can see, for peri-implant mucositis, the success rate is equal or lower than 60%. For peri-implantitis, lower than 50%. So we concluded that peri-implantitis is generally unpredictable and infrequently achieve the successful treatment of this inflammatory disease. So what we are dealing with when we talk about peri-implantitis, what we're dealing is with a disease that is very challenging to treat and is case-specific. We all want to regenerate, but the reality is most cases cannot be regenerated. We are dealing with a disease that is unpredictable. We have seen a success rate below 50%. If you were the patient and you go to a doctor because you need a surgery and they tell you the success rate is less than 50%, will you take the chances? Will you take that surgery? It is a disease that is very often anesthetic, and it has very poor long-term outcomes. Consequently, what we have done in our group of investigation back at the University of Michigan, University of Oklahoma, and now in Spain, is that we are no longer following the trend that we see nowadays, that a lot of people are very focused into the treatment of this inflammatory disease. But by the time that we need treatment, very often it's too late. What we are doing today is taking a step back and focusing on why peri-implantitis is occurring. So if we can understand peri-implantitis better, we will be able to better treat it, and we will be able to prevent it more efficiently. How do we start with the prevention of peri-implantitis? We obviously need to understand what we are dealing with. The concept of osseointegration is nothing new to nobody in this room. This was a breakthrough in the dental field. But as important as osseointegration is, that direct contact between living bone and the implant surface, we have another component that is equally as important for the long-term stability and for the aesthetics of our implant. That is that soft tissue component that surrounds our dental implants. This soft tissue component is the peri-implant phenotype, both soft and hard tissues, and that refers to the dimensional, morphologic, and topographical features that the tissues, both hard and soft tissues, that surround dental implants. And which one are these? Well, we have 4 different components. We have the keratinized mucosa, we have the mucosal thickness, the supracrestal tissue height, and the peri-implant bone thickness. And out of these 4 factors, there are 2 that are very, very critical for the prevention of peri-implantitis. And we are talking about the supracrestal tissue height, formerly known and very often referred in the literature as biologic width around dental implants, even though the correct terminology will be supracrestal tissue height, and the peri-implant bone thickness. Why are these 2 very critical? This is a research recently published by my good friend, Alberto Monge, that they demonstrated that implants that are placed with a thin buccal bone or lingual bone, it will likely collapse and resorb over time, creating adhesions of the implant surface. That the adhesions will make that implant more prone for the development of peri-implantitis. So having less than 1.5 or 1 millimeter the day of implant placement can be a risk factor for the development of peri-implantitis. And what about the soft tissues? What soft tissues do we have around dental implants? Well, we have the exact same 3 structures that we have around teeth. We have our sulcus, our junctional epithelium, and of course, our connective tissue. Then when we average the 3 of them together, we are talking about a length of somewhere between 3 to 4 millimeters. And you may be wondering, why is this relevant? Why am I even bothering describing the soft tissues around dental implants? Because if we don't respect these soft tissues, if we don't give biology what they need, bone loss will occur. This is a very classic study performed in 1996 by Berglund and Lindy. And what we did, they placed implants bilaterally in a canine model that half of the implants, they remove a substantial amount of the soft tissues. They made them thinner. They let those implants heal. And after 6 months, they did histological analysis. And these are the results that they presented. They concluded that when the mucosa is less than 2 millimeters, I'll say the conclusions, bone loss will always occur. And if we don't have a certain amount of soft tissues to allow the establishment of the supracrestal tissue heights, the soft tissues will not grow. Bone loss will occur to compensate for the establishment of those soft tissues. This is a topic that, as you know, has been extensively investigated mostly coming from the same group of people in Lithuania, that they concluded that when we have thin tissue, we will always have bone resorption. When we have thicker tissue, that provides stability. It prevents the bone loss from happening. The good news is that the thin tissue can be thickened and can be effectively thickened, and it behaves as well as the thick tissues. They have a protective mechanism against bone loss. And they also concluded something very interesting, that when we have thin tissue, it does not matter if we place the implant supracrestally. Some people claim that if you place the implant away from the bone, that will prevent bone loss. If we use platform switching, different type of connections, all those things work great. But if we have thin tissues, biology always wins. And if we don't have enough height for the formation of the supracrestal tissue height, bone loss will always occur to compensate for the formation of those soft tissues. This has been extensively studied by many other research groups. In particular, this one is also coming from Lithuania, where they can see the bone loss that occurred with thin, as we said before, thin tissues that were thickened, and we can see the difference with the thin tissues that were not properly managed or treated. Many years ago at the University of Michigan, we did our own investigations where we performed a systematic review, and not surprisingly, we conclude that this is a very important factor for the establishment of the supracrestal tissue height and the prevention of marginal bone loss. So we can conclude that the maintenance of the crestal bone and the stability of the implants, it relies tremendously in the peri-implant phenotype, both hard tissues and soft tissues. And are these the only factors playing a role in marginal bone loss? Of course not. We know that we have hundreds of factors playing a role in marginal bone loss, some local, some systemic. Some of these factors are deeply interconnected with one another. For example, as we were talking before, the type of connection that we have around an implant. If we have an implant that is placed at the bone crest or below subcrestally, the type of connection that we use will play a major role in the development of marginal bone loss. If we placed an implant supracrestally or a soft tissue level implant, obviously the connection becomes a factor of secondary importance. The supracrestal tissue height as well as the height of the abutment, these are factors so deeply interconnected. And now the question is, why is this so relevant? Why should we be that concerned about marginal bone loss? Who cares? How many times have we taken a radiograph and then when we want to restore our implants, a few months later, we see a little bit of bone loss? Why should we be concerned about this? Or in other words, why is marginal bone loss so critical? And we do have research that shows that marginal bone loss, particularly early marginal bone loss, it is really connected with the development of perimplantitis. This is another investigation that we performed back in Granada, in Spain, where we look retrospectively at hundreds of implants. And we divide those into implants that lost less than 0.4 millimeters within the first 6 months of function, and implants that lost more than 0.4 millimeters within the first 6 months in function. We follow up those implants for up to 18 months, and this is what happened with these implants. The ones that lost less than 0.4 millimeters remain stable for the rest of the investigations. The implant that lost more than 4 millimeters, they continue losing bone over time, up to almost 2 millimeters when we concluded these investigations. So what we found is that early marginal bone loss, increased rates of marginal bone loss, is a significant risk factor for the prevention and the occurrence of perimplantitis. And we are not the only ones that have concluded this. Other groups around the world, this one particularly coming from Belgium, they concluded with the same numbers, somewhere between 0.5 to 1 millimeter. And this is another investigation coming once again from the University of Michigan by my good friend Andrea Ravida, that they concluded that the exposure of those interproximal threads, they are a significant risk factor for the development of perimplantitis. So why should we care about marginal bone loss? Because if we don't have marginal bone loss early, during the early phases of implant placement, we will not have perimplantitis. Marginal bone loss may or may not progress to perimplantitis, but without marginal bone loss, there is no perimplantitis. So a factor that is so often overlooked, we should be paying much more attention to those critical factors that play a role in marginal bone loss and prevent, to the best of our capabilities, the occurrence of marginal bone loss, particularly within the first 6 months in function. Now let's talk about peri-implant mucositis. And I want to show you a case. Again, patient at the University of Michigan, comes with inflammation, exudate, bleeding on probing. So given these clinical and radiographic considerations, we conclude that this patient is suffering from peri-implant mucositis. What do we do in this case? We do subgingival instrumentation, irrigation. We want to make sure that they clean the implant surface as much as we can. We continue with locally delivered antibiotics. In this case, we use a product available in the US, which is called Arestin, which is microcyclic microsphere. And we closed it up to maintain those locally delivered antibiotics in place, make sure that they don't come out through the sulcus. Here we have the evaluation at 2 weeks. We continue following up after 7 weeks. We are not hoping, we are not expecting any regeneration, so there is absolutely no problem whatsoever with probing after 7 weeks. We continue following up the case. Here we have the 3 months, 6 months, and 1 year follow-up. And here we can see a comparison before and after how we had successfully treated this case, peri-implant mucositis. And very importantly, when we treat these cases and we resolve inflammation, we are giving a space for the patients and for us to perform cleaning. If implants cannot be cleaned and maintained, they will eventually, it's just a matter of time to develop peri-implant mucositis, and eventually they will more than likely progress to peri-implantitis. Why is hygiene so critical? We also have research that show they looked at implants that have access to hygiene and implants that did not have access to hygiene. And out of those implants, 75% of those implants that they didn't have access to proper hygiene and instrumentation, almost 50% had peri-implantitis. So we see how access for cleaning is a significant risk factor for the developing of peri-implant mucositis and eventually peri-implantitis. On the other hand, when we are looking at implants with adequate access, we realize that the prevalence of peri-implantitis is much lower because those implants were able to be properly cleaned and maintained. This is also another investigation coming from the University of Complutense in Madrid, where they show that you can successfully treat peri-implant mucositis cases if we are able to clean the surface and change, modify the contour of the prosthesis, allowing patients to clean. It does not matter if we treat this case successfully, if we don't change the design of the prosthesis, if we don't allow patients to clean, particularly interproximally, mucositis will recur, and eventually that will transform into peri-implantitis. Here we have some of the examples of the publications where you can see the huge change that has been happening in the peri-implant mucosa, in those tissues surrounding the implant, by only subgingival debridement and modification of the prosthesis, allowing for the patients to clean, particularly interproximally. What about maintenance? Also very, very, very critical. When we look retrospectively at the incidence of health and peri-implantitis among patients that were compliant and not compliers, we realized that out of patients that were regular compliers, 72% would have healthy implants, whereas peri-implantitis only occurred in 53% of the cases. When we looked at peri-implantitis, we realized that among regular compliers, the incidence of peri-implantitis was very low. People that come to maintenance and people that are able to clean their implants have very low prevalence of peri-implantitis, that it increases 5 times to patients that do not come for maintenance. And now the same question. Why are we talking about peri-implant mucositis instead of talking about peri-implantitis? Why should we even care about peri-implant mucositis? Because of the exact same reason that when we were talking about marginal bone loss. Because we will not have peri-implantitis if we don't have peri-implant mucositis first. So we need to go to the root of the disease. The problem that we are facing nowadays with peri-implantitis is that we take care of the disease when it's already too late. We have tons of research, we have tons of meetings, we have tons of publications talking about how can we effectively treat peri-implantitis and implants that have lost 20, 30, 50% of the support. What we should do, what we have been doing, is taking a step back and focusing on the root of the problem. If we don't have peri-implant mucositis, we will never have peri-implantitis. If we don't have early marginal bone loss, we will never have progressive bone loss. So we should be paying much more attention of these factors that are often overlooked, see our patients frequently, and take early marginal bone loss and peri-implant mucositis very seriously, because we will be preventing major issues. And now for the remaining of the presentation, I wanted to change topic back and talk about an emerging concept in the field of peri-implantitis, which is the presence of titanium particles around dental implants. Is there a link? As you know, the 2017 World Workshop by the American Academy of Periodontology and the European Federation of Periodontology, they concluded that there are a variety of risk factors for the presence and the prevalence of peri-implantitis. The main two factors that they talked about is history of periodontal disease and, of course, the lack of proper maintenance. They also talk about smoking, diabetes, and they looked at 7 different factors which they term under areas of future research. These are factors that we have some evidence, but we need to do more research to really conclude what's the influence that these have in peri-implantitis. They are looking at the presence of keratinized mucosa, excess cement, they are looking at genetics, iatrogenic factors, genetic diseases other than diabetes, of course. They are looking at occlusion, and they're also looking at the presence of titanium particles. And back in 2017, they concluded with a few sentences. First of all, that this is one of the areas that needs more research. The influence of these titanium particles remains to be determined. But they also conclude that from the little evidence that we have back some years ago, they also saw that implants presenting with peri-implantitis appear to have a higher concentration of titanium particle surrounding those implants. So when we look at this case, it is often misunderstood that we hear particles and we immediately think that is something negative, that is something bad for whatever location those particles are. And we need to understand that particles are not always bad. Nanoparticles and microparticles are actually used in medicine, for example, as a drug delivery method. If used properly, with the composition and the concentration that we have, these particles can be very useful for the treatment of certain diseases. However, the issue that we are facing around dental implants is that we have particles with characteristics that we do not want in locations where we don't want them to be. This is a field that has grown exponentially over the last decades, the presence of titanium particles and dental implants. And as we can see, over the last decade, the research and publications that have been performed in this topic, they moved from barely a few research in 1990s to up to 54 manuscripts that we have published in 2022 only about the presence of titanium particles and dental implants in relation with the incidence and prevalence of peri-implantitis. Last time I checked, very recently, we already have 32 systematic reviews in this topic. What is the relevance and the repercussions of these titanium particles and peri-implant diseases? And we were one of the very first ones talking about this topic, that we created a review and we had a focus. We wanted to know first, are these particles really present? If they are, where are they coming from? And where are they located? Is it only within the oral cavity or are they located somewhere else? So when we looked at the presence, we were not surprised to find that implants, both healthy and diseased, have titanium particles and ions, both in the peri-implant soft and hard tissues. But we're also surprised to find that even patients without dental implants have particles in their mouth. Where are the particles coming from? Contamination from food, cosmetic products, other dental prostheses. Not only dental implants have metal particles. When we look at the origin of these particles, how is it possible that somebody has so many particles around the soft and hard tissues? Well, there is 4 main mechanisms nowadays. The first one is simply by the installation of a dental implant, that friction between the implant surfaces and the bone that causes the release of some of the particles within the implant surface. The movement, the friction between the abutment and the implant itself, that also caused the release of titanium particles. Of course, the many different methods that we have to detoxify the implant surface, particularly the use of perimplantitis, very often performed nowadays. And finally, just by simply corrosion. The implant surface over time, particularly in the presence of bacteria, get corroded, and that promotes the release of particles and ions to the environment. And where are these particles located? And I want to remind you that all these are coming from dental implants. Obviously, the particles found in distant organs, they are coming from animal research, but animal research with the use of dental implants. After the use of implants, we can find particles in the soft tissue, plaque, bone, regional lymph nodes, and distant organs. So those particles are digested by macrophages, and they travel everywhere within the body. And something very relevant from this investigation that is also overlooked frequently is the size of the particles that we found in this investigation. And I will explain to you in just a few minutes why this is so relevant. We found that the particles that are found in the oral cavity are very frequently within the range of 100 nanometers to 54 micrometers. Here we have a few examples of the articles that we were looking at. This is performed at the University of Washington in the United States, where they were looking at the presence of titanium particles with a plaque around dental implants. They compared healthy and diseased implants. Not surprisingly, implants suffering from perimplantitis have more plaque than healthy implants, but when they looked at the presence of the concentration of titanium particles, we found a significant difference between the implant surface for perimplantitis and healthy implants. This is another example coming from Argentina by the group of Olmedo, where they found much more particles around perimplantitis cases compared to healthy implants. And this is data still unpublished from the University of Oklahoma that we performed years ago, where they also found higher concentration of titanium particles around diseased implants than around healthy implants, particularly the ones that were previously treated for perimplantitis. So no longer there is a question about whether or not we have titanium particles around dental implants. The question that we need to answer nowadays is what are the effects of those particles? What are the repercussions? Because it's been proven again and again and again that we do have those particles surrounding dental implants. What did come first? Do having more titanium particles cause more perimplantitis? Or is it the presence of perimplantitis that caused the release of most titanium particles? And the answer is that it's bidirectional. It goes both ways. When we have perimplantitis, we have bacteria, we have a more acidic environment, and that caused the corrosion of the implant surface, and consequently the release of more particles. If we have more particles, that will cause more inflammation, that will cause obviously perimplantitis. So it goes both ways. They feed each other. So what are the effects of these titanium particles? And we learned this from the orthopedic field of the process called osteolysis. This is a very complex phenomenon that is still nowadays not fully understood. But we know that just by the presence of these particles and ion, there is a cascade of inflammatory events, mostly led by macrophages, that they turn into the release of pro-inflammatory cytokines, osteoclasts, and of course, bone resorption. And this has also been proven in the implant field. We have quite a few research talking about how titanium can aggravate the inflammatory response, and hence, the presence of these particles make the treatment of perimplantitis less predictable, less efficient. We have other research talking about a modification of the microbiome of the bacteria living surrounding implants with perimplantitis. We have more research talking about the negative effect that the perimplantitis have on macrophages, that they induce M1 polarization of macrophages to a pro-inflammatory state. More titanium particles cause more inflammation. We have more studies talking about the influence on the microbiome. And this is one of the most critical research that we have around implants and titanium particles. The very peculiar situation that we have that they don't have our colleagues in the orthopedic field is that we have an environment that is highly contaminated. We always have bacteria in our mouth, more so when we have periimplantitis. So in this research, what they do is they have 4 different groups, where they have a control group without LPS and without particles. They have an LPS group, they have cobalt particles in this case, and they have the combination of both, particles and LPS. And as we can see, the destruction that occurs with that synergistic effect of LPS produced by bacteria and titanium particle caused the bone loss to grow exponentially compared to LPS or particles alone. This is one of the investigations that we performed at the University of Michigan, where we also concluded that those particles surrounding the implants, they do have the ability of cause DNA damage in oral epithelial cells. And I wanted to show you this research to conclude. And this was part of my thesis back at the University of Michigan. We are talking about 2013, 14, where we didn't even know if we really had titanium particles surrounding dental implants. That today is no longer a question, but that was part of the investigation. So what we did, we used some animal model to place the implants. We performed the osteotomy and we looked under the microscope. And we also got some particles directly from the implant surface to have those with the exact same characteristics that we may have in the oral cavity. We used different types of implant systems, as you can recognize. And we performed implantoplasty around all those surfaces to obtain those particles and culture them with normal oral epithelial cells. This is the process of how we did it. We were culturing the oral epithelial cells. We were cultivating them with the titanium particles. And we used 2 different markers, both BRCA1 and CHEK2. These markers are used very frequently, commonly, in cancer because they are both being expressed when the DNA is being repaired. The more these proteins are expressed, that means that the more DNA damage we have. This is how we looked at the cells after the quantification with the titanium particles. We quantify the total number of cells, and then we look at the ones in red that are expressing those proteins, both BRCA1 and CHEK2. And let's take a look at the results. As you saw from the beginning, very simple experiment. We performed those osteotomies, following, of course, the manufacturer recommendation. We can see the very clean osteotomy, the very clean bone. We install our dental implant, and upon removal of the dental implant, we can see the huge amount of contamination by those particles surrounding the peri-implant hard tissues. Here we have an example of those different implant surfaces and the different titanium particles that were cultured with the normal oral epithelial cells, and we can see very different morphologies, very different locations. And here we have some of the examples that we have. Going back to the results, we saw not only a significant difference in these 2 markers compared to the control group, but we also saw a huge difference between different implant surfaces. Not all titanium particles, not all sizes and concentrations have the same effect with oral epithelial cells. So what were the conclusions of this investigation? That titanium particles, they do release as the consequence of implant placement, that they do cause DNA damage, and that different implant systems trigger different responses in the peri-implant environment. So what do we know? What do we know today about the presence of titanium particles and peri-implantitis? Titanium particles can cause all these factors, the presence of them around our implants. And what we were talking before about how critical it is the size of these titanium particles, there is 4 main factors that play a role on what is the influence that those particles and ions are going to have within the peri-implant environment. And we are talking about size, concentration, composition, and morphology. Out of these 2, we have 2 that are particularly critical. And when we talked about the size, there is a certain range that is the most detrimental for the peri-implant environment. And that range is somewhere between 100 nanometers to 10 micrometers. Why is this so critical? Because the size of these particles will influence how the macrophages interact with this particle, whether those particles are going to be digested, engulfed, or they are going to try to do some extracellular digestion of those titanium particles. And if you remember correctly, you can see that the particles that are the most detrimental for the preimplant tissues, both hard and soft tissue, are within the same range that we find around our dental implants. So to conclude, what we know today about titanium particles and peri-implant diseases is that there is certainly an association. We know that more peri-implantitis will cause more release of titanium particles, and more titanium particles will cause more peri-implantitis or a greater degree of peri-implantitis. We know that there is a potential to promote biological complications, as we saw before, epigenetic changes, dysbiosis, N1 macrophages polarization. And we know, very importantly, within the oral cavity that the presence of LPS and these titanium particles, they do have a synergistic effect. There's going to be so much more bone loss when we have both components than if we have just one of them separately. And before I finish and we go to questions, there is one main question that I wanted to answer before, which is the one that I get usually. That is, does the presence of titanium particle means that we are going to have peri-implantitis? And the answer is obviously no. We are doing research the last few years, but we've been placing implants for decades. So more than likely, we have had titanium particles around the dental implants since the beginning of dental implants, and we never knew about this topic. We are only learning about it in the last decade. So what happened? It is simply one other factor that plays a role in the initiation and progression of peri-implantitis. So it's something that we need to be on the lookout. Same thing happened with peri-implant mucositis, and same thing happened with marginal bone loss. If we have marginal bone loss, does that mean that we are going to have peri-implantitis? No, but we are certainly more susceptible. We are certainly much more likely to develop peri-implantitis. If we have peri-implant mucositis, does that mean that we are going to have peri-implantitis? Absolutely not. But if we have it, we are much more likely to have peri-implantitis than if we don't have peri-implant mucositis. So all these factors, they play a role together. And against this factor, we have the susceptibility of our patients. Not every patient is the same. So just because we have some of these factors doesn't mean that we are going to have peri-implantitis. But we should do everything that is in our hand to prevent and to take action against these things to protect the long-term stability of our patients and our implants. And with this, I want to thank you very, very much for your attention.
Okay, we have time for 2 or 3 questions. Okay, one question there.
Okay. Are there any studies about zirconia particles related to zirconia implants, which is like newly introduced?
As far as I know, zirconia is much harder than titanium, but the critical effect that we see with this titanium particle is mostly related to the size and the concentration. As we saw, there is a specific range, mostly between 100 nanometers to 50-something micrometer, that is very detrimental, and it's also the concentration. It's not the same to have 100 particles than thousands of particles. So if I have to guess, because I don't know the answer, it is probably very similar, if not the same effect, because it's just the presence of the particle itself. The exact composition of it, whether or not it plays a major role, that's a great...
Because those companies, sometimes they advertise the product as an alternative to titanium, and it is like particle-free. But I think it's pretty the same.
So they are harder. So I bet there will be less particles through the process of, for example, implant installation. But there is so much we don't know about those implants. Are people performing implantoplasty or zirconia implants? What happened in the long term? We don't know. And this type of research is very hard to perform. You go to a company and say, just give me your implants, then I'm going to get some particles and culture them. They're probably not going to be very happy about it.
Thank you.
Okay, one more question.
I would like to ask about the treatment protocol when you have such cases?
What case?
Peri-implantitis caused by titanium particles, or what would you do when you have this in your clinic?
So in reality, when you see your cases on a daily basis, now I know for sure that there are particles there, but there is really nothing that you can do. The only thing that I have modified, knowing what I know today about titanium particles, is when I do implantoplasty or whatever method I'm using to detoxify the implant surface, I'm much more careful. There are several ways that you can do that. You can put a rubber dam before you do implantoplasty, trying to collect all those particles that you remove later. You can use bone wax to protect that area before you do implantoplasty. Or some things that I'm doing right now, but I'm not a big fan of it. Before you degranulate and you clean very well the defect, you do implantoplasty first. So those particles are going to be accumulating within the tissues that you will remove later. But the truth is, I'm confident that all the cases with peri-implantitis have titanium particles. They may have a little more or a little less, and there is nothing that we can do about it. Even if you remove the implant and place a new implant, there will be titanium particles. So the question is not whether or not we have them, is what type of particles we have and the concentration of those. We need to minimize those as much as we can.
Thank you.
Thank you, Dr. Suarez.
Thank you. De verdad, take a photo. Thank you, Lee.
It takes 30 seconds. I'll do the introduction. Assalamu alaikum, معكم Khalid Al-Awadi. I'd like to introduce our next speaker, which he doesn't need any introduction, Dr. Rodrigo Neva. He earned his periodontics and master's degree from University of Michigan, where he was appointed clinical assistant professor at University of Michigan. Later on, 2010, he was graduate program director at University of California. Currently, he's head of department of periodontics at Penn Dental Medicine, chairman, clinical professor of periodontics, and he also serves as board director of the American Board of Periodontology. So without further ado, Dr. Rodrigo Neva.
Good? Great pleasure to be with you here today, and a great pleasure to be back here in Kuwait. I'd like to thank the organizing committee for the kind invitation, which gave me the opportunity to see my brother, Khalifa Shamari, for the first time in 20 years. So this was a very emotional day for me to be able to reconnect with my dear brother. We spent a lot of time at the University of Michigan together, and I learned so much from him. You're all very, very lucky to have him here. So I'd like to also thank everybody who was involved in the meeting, putting this meeting together. I think meetings like this become more and more important because of the fast advancement that is happening in our profession. So we need to be really on top of our games. And this is something that I started working with about 10 years ago. And I have to say that this completely changed the way I look at implant dentistry. So this really was a huge paradigm shift in my implant practice, and we're going to talk a little bit more about it today. So when we talk about implant dentistry, we know how much implant dentistry has changed the practice of dentistry. Khalifa and I were talking about this before. Our decision of saving teeth and pulling teeth has been influenced by the development of implant dentistry. When we were being trained in implant dentistry, we looked at implants as the future, something that was completely bulletproof. But as Fernando was showing before, that's not so true anymore because we've learned that implants can have some very significant problems. So in my implant practice, I still place a lot of implants, but I'm a lot more selective on when to pull a tooth nowadays than I was 20 years ago, especially because we don't want to deal with periimplantitis. We want to prevent it from happening because when it happens, there's really no solution for it. But this implant dentistry really changed the way we practice dentistry. The implant dentistry, or really the vintage implant dentistry, was very different than what we do nowadays. Everything started with prosthodontists trying to figure out ways to provide fixed replacement for teeth. And they were very creative on what they did. And I also like to really respect what people did in the past. As crazy as this looks, I mean, there's a lot of great things that were tried in the past, didn't work because technology wasn't there. But things like a subperiosteal implant, this is coming back with modern technology. Because back in the day, to do a subperiosteal implant, patient needed to have a surgery to have a flap elevated, impressions of the bone. Then this was sent to the lab, cast, a framework, and then the patient was brought back at the end of the day or the next day to have another surgery to be for this to be put in the mouth. With CT scans, with 3D printing, we have a capacity to do this before a patient even comes to the office nowadays. So it's very important for us to always respect what was done in the past, because sometimes things didn't work because technology wasn't ready, but the idea was good. And I think that this was actually a really good idea. Such as the blade implants too. We struggle so much with ridge augmentation. A blade implant doesn't require ridge augmentation because it's so narrow. A root form implant requires more bone augmentation or more bone anatomy. And then you run into the issues of having dehiscences, like Fernando said, that could lead to periimplantitis. So always important to look in the past and try to learn from it. But when we look at implant dentistry and how much implant dentistry has really changed and evolved over the years, there's someone that we have to really recognize, which to me was the great father of implant dentistry. I was very lucky to have him as one of my mentors in implant dentistry and to have learned a lot from him. Unfortunately, we lost him 6 years ago, but I think if he had a chance to stick around for a little bit longer, he would be probably having a lot of fun with the things that we develop nowadays. I'm glad to see that a lot of his legacy now is being revigorated because his son is finishing up his periodontal training and he's opening up again his institute, and he will continue to teach dentists on how to place implants, on the right concepts of placing implants, just like his father did. But Carl is the one who really made implant dentistry more user-friendly. He instructed so many clinicians on how to practice implant dentistry. And with this influence that he had in the profession, he really described a lot of protocols that we still follow for implant treatment. So with the advancement of the root form implants, this is something that was no longer done by few, but now it started to be done by many. Anyone could be trained in implant dentistry and be able to do this and treat their patients with that. So in today's day and age, when you look at implant dentistry, our standard for success is much higher than it was before. In the past, we were just looking at trying to give the patient a fixed replacement for the missing teeth or tooth. Nowadays, we want a lot more from our implants. We want our implants to be surrounded by adequate bone and soft tissue. And we also want them to look like normal teeth, which wasn't a priority in the past. In the past, if it wasn't a removable prosthesis, you're already ahead of the game. Nowadays, we want it to look like a normal tooth. So the bar is set a lot higher than it was in the past. But we all know how important bone is in implant dentistry. Bone is what really holds these implants in the mouth. But I don't think we have spent enough time looking at bone and what bone does and how important bone is for the success of implant dentistry. Bone has some very specific features here, which is it has some flexibility. It can actually allow for deformation. Bone can actually widen in compression, lengthen over tension. And all of this is because bone is very irregular. If bone was 100% cortical, it would actually be weaker. So that interaction between cortical and cancellous bone is what makes bone so special and so capable of being constantly remodeled and being renovated so that our function can actually be adjusted. Someone who may spend some time in a hospital, maybe in bed for 2-3 months sometimes. When they leave the hospital without good physical therapy, they are unable to walk, not just because they have lost muscle mass, but they actually have lost bone mass because of the lack of function. So it's very interesting to see how bone is constantly reacting. So bone is a very, very active tissue. And bone integrity or bone composition is key for the success of implant dentistry. We need a ideal mineralized component of bone, and we also need the organic part of bone to be properly balanced so that the bone can maintain these functions. So a big misconception that we see in implant dentistry is that we want hard bone and we want really good implant stability. We want things to be rigid. That's not true. We want this nice balance between mineralized tissues and organic tissues so that we have this interaction and this balance for the bone to continue to maintain its stability over time. So, this was my book where I learned implant dentistry. And I like to look back at old books to see how relevant things were or still are based on older concepts. So Mish's book in implant dentistry still is the best sold textbook in dentistry ever. This, including every specialty that is out there, is the best sold book ever. So this is something that Dr. Mish left for us. And when I was actually on my way to his funeral, I picked up his book and I started reading it on a plane. And I found these 2 chapters here that were written in 1999 or before, because this was published in 1999. And I said, like, wow, how relevant these chapters still are nowadays, even after so many years. So I really have the most profound respect for Dr. Mish because he was really ahead of his time. A lot of people never understood him very well. They criticized him a lot, but he had great ideas. And he had a very early understanding of things that, for me at least, took me another 10, 15 years to understand. So that's what happens when you're too smart. Sometimes people just don't understand you. And that's why he was so heavily criticized when he was still lecturing and teaching all these things. But let's look at these 2 chapters. Chapter 8 and chapter 25. Chapter 8 talks about bone density as the key determinant for clinical success. And chapter 25 talks about density of bones, effects on surgical approach, and healing. So, what do these 2 chapters have to say? Let's start here. Chapter 8 talks about the highest failures of implants back then, in 1999, were associated with poor bone quality. And that's why implants were not even an option in posterior maxilla. They were rarely used in posterior maxilla. Nowadays, they're commonly used in posterior maxilla, but back then, that's when we had extremely high failure rates of osseointegration, not of an implant that was placed and then was later restored and failed. No. Implants wouldn't even take in the posterior maxilla. So they were rarely used there. And it also showed that the longer the patient remains edentulous, the less bone quality or density will be found there, which is something that we never really thought about. We're always talking about the volume. We would measure things on an X-ray, on a radiograph, on a CT scan, but what's the quality of that bone? So quality is not something that has been extensively discussed in implant dentistry. And the longer someone remains edentulous, the less bone quality you will find simply because that bone hasn't been properly stimulated. Just like that patient that was laying in bed for 2 months or 3 months. You have lost bone mass. And that's why we have seen in some patients, for example, what we call a hollow bone. And you can find hollow bone in the mandible. I've got into trouble many times in the posterior mandible. Patient had been edentulous for years and years. I would place an implant and I would try to go a little bit subcrestal. I'm talking about like first molar area. And then when I went subcrestal with my implant placement, my implant just fell sideways because there was no trabeculation in that area. So these are significant factors in implant dentistry. Mish also classified bone density, and we went from D1 all the way to D5, and we all have seen this. But when we go to chapter 25, which talks about the effects that it has on the osseointegration, he clearly states here that D1 bone is not the most desirable bone you would want in implant dentistry. Why? Because it has less blood supply. So an implant actually takes longer to heal when you have excessive bone density. So the most ideal bone would be in the D2 or D3 category. Of course, D4 would be a very low density bone, which you would struggle with stability of an implant. But D1 is not the most desirable bone to be used. And I like to emphasize that because that is the first mistake that everybody makes when they start looking at osseodensification. Because I made that mistake. The first time I tried to densify bone, I was aiming for D1 bone. And I had very high implant stability, but then I had very poor healing of that implant. So if there's one lesson to learn from what I'm going to show you today, is that never go for extremely high bone density, because that's detrimental to the process of osseointegration. Just something that people tend to forget and ignore. But there were early attempts to densify bone, to make that bone that has low quality to actually end up with more quality. And this happened with implants that were used in the past. For example, the implants that were tapped in place. Like an implant like this was never drilled, an osteotomy was drilled, but this, since it wasn't a screw, it was a basket type of implant, this was actually placed with osteotomes. It was hammered into the patient's mouth. Why? Because they didn't like their patients and they wanted the patients to suffer and struggle? No. Because they were trying to compress the bone and make the bone more dense as the implant was going in. So, traumatic, low precision, low predictability, but there was a lot of attempts to try to manage this poor bone quality or poor bone density that was also very commonly associated with the lack of osseointegration or with implant failure. But what really started contemporary implant dentistry was the introduction of this root form implants, because this was the only thing that was really reproducible. All these other methods work well in the hands of few, but not in the hands of many, as I said before. And this is what really kick-started contemporary implant dentistry. If we go into the 90s, something that I can clearly describe all the implant research that happened in the 90s. There was a big battle between two implant companies, which back then were the major implant companies. One had a screw type of implant that had no surface treatment. This was called like a machine implant. And the other one had a less aggressive screw design, but had surface texture. So these two companies were fighting against each other to see which one had the best design, had the best implant. And in good bone quality or in good bone density, there were no differences. But when bone density started to become lower, the texture implant surface showed to have more success, including the posterior maxilla. And this completely changed the industry for the first time. Nowadays, we no longer see implants that are machine or polished surfaces. All of them have surface texture. And part of what Fernando was showing before about titanium particles come from that. Because if you have a textured surface, you're more likely to damage that surface while you're placing the implant. That's why you end up with the particles. Because if the implant surface is solid and rigid and has no roughness on it, it's less likely to happen. Maybe there's one reason why a lot of these ancient implants, we can call them ancient because they have been in the mouth for over 40 years now, when you find them, they still seem to be holding up pretty well. So, was it really like an evolution to change implants? Because we changed the implants to try to overcome a problem, which was the lack of bone density, right? We made the implants rough to compensate for the lack of bone quality. So maybe we didn't fix the problem the way we should have fixed it. Something for us to think about. So, when you look at also in Mish's book, in the effects of surgical approach and the healing based on bone density, you can clearly see here how the protocols for placement of an implant were different based on bone density. For a D1 bone or a D2 bone, you had every single step and you have all the drills and even a tap to allow an implant to be placed without significant bone compression. But when we went to D3 and D4 bone, this was a more compressive osteotomy preparation. And something that Khalaf and I did a lot back then was if we're placing an implant in the posterior maxilla, we would actually do our osteotomies with osteotomes, not with burrs, because we wanted to compress the bone laterally to allow for better implant stability. So these are like just early methods to try to overcome lack of bone density to create better bone density or densify the bone. So Dr. Mish also designed his own implant system, fully and solely based on bone quality. The Maestro implant system had different designs based on the type of bone quality that you're dealing with. It's a great idea, but not very practical, because since you only assess bone density at the time of implant placement, you would basically have to have 4 implants available for every osteotomy you're drilling. So I would need like a 4x10 in a D1, D2, D3, and D4, and we have to tell my assistant which one to get based on my assessment of the bone density. So not very practical. That's why this idea didn't stick. But it was a good idea. Nowadays, what we have is we have implants that have to do it all. So these implants, they are designed to be used in a variety of clinical situations. We won't have site-specific implants. So we have implants that have hybrid designs to allow them to be placed in a variety of situations, variety of areas in the mouth, a variety of loading protocols. They have to do a lot more than implants were asked to do in the past. And with that, we have the capacity to, of course, treat our patients in a very different way than we treated 20 years ago. Implants were never developed or designed to be an aesthetic replacement for missing teeth. And nowadays, we all have cases like that in our offices, where we're very proud of what we achieve from an aesthetic point of view, but this was something that was designed for function. So we are reestablishing function on the patient. But nowadays, we can also do that with a very, very high aesthetic outcome. And we should be proud of it. What we can't be so proud of is this. Because to me, this is the dental pandemic. Wherever I go, wherever I present on implants, everybody has the same problems. Fernando showed us very well. We didn't expect this 20 or 30 years ago. We weren't expecting that at all. We were expecting implants to last forever. We learned that they don't. Some of them may, if our patients die before the implants fail, but literally, most implants we place are designed to fail eventually. It's our job to make them last as long as possible. So that's why we have to look at implants in a different way that we've looked at them in the past. So modern osteodensification also came from one of my mentors. Dr. Salah Huwais used to drive from Jackson, Michigan once a month to the University of Michigan to teach us in the clinic. And he's been thinking about this for a long time, until at the Perio meeting in 2014, he gave me this kit. And he said, like, Rodrigo, I have this idea, and I have hired some engineers to design this burst, and I want you to try them and tell me what you think. And he gave me this kit. I went back. He called me like a couple months later to ask me how it was going, and I was embarrassed to tell him that this was still sitting on my desk, and I never used it. So I said, like, just refresh my memory, Salah. Tell me, what am I supposed to do with this? It's like, no, this burst, they will cut in both forward and in reverse, and with that, we'll make the bone more dense. Really? Okay. So I started using them, and quickly, I realized that my issues with implant instability, or lack of implant stability, were gone. Because drilling the osteotomy that way, which I never thought it was possible to do it in reverse, would actually take care of the problem. But I also ran into some complications. As I said before, I started to turn every osteotomy that I had in front of me into a D1 osteotomy. And with that, I lost a lot of implants. So we have to remember that this is a tool that should be used when needed. Not just because you can make the bone more dense that you should make the bone more dense. This is something that is designed for patients that have deficient areas where you normally wouldn't be able to place an implant or wouldn't have ideal stability of that implant. You can change that. That's what it has to be used for. Not to make every bone into D1 bone, because this is only going to affect osseointegration. So what Salah did, he touched into something that was completely untouched in implant dentistry, because we had seen all kinds of advancements in implant dentistry, but nobody had paid attention to instrumentation, which is kind of funny, because everything in dentistry is about instrumentation, right? Think about endodontics, how many files you have available to do your root canals. Look at restorative, how many types of composite materials you have for all of that. In terms of bone, we never care about instrumenting it in any different way. So bone instrumentation is something that was really never studied very well in implant dentistry. So basically what we had was just a simple adaptation of commercially available drills. You go to a hardware store, the drills that we use in implant dentistry look exactly the same. They're just smaller and cost a lot more. But they were exactly the same. Why? Because that's what was used in orthopedics. In orthopedics, a lot of orthopedic surgeons still use like a normal drill bit or a normal drilling unit that you would buy at a hardware store to just sterilize it and use it for the large implants that they place. So why not do the same thing for implant dentistry? And that's what was done. And that's why these drills never had the precision that they should have to drill bone. Because when you go to the hardware store, they have specific drills for metal and for wood, for example. You try to get like a wood drill bit and try to drill into metal, you won't go anywhere. And the same thing the other way around. So that's why we've always struggled with our osteotomy preparations in implant dentistry. Because we would go to hard bone, and then all of a sudden we drop into cancellous bone, and we see the burr just trying to lose balance and shake. Why did it happen? Because you're dealing with these different bone densities. And the drills were never designed for that. That's why it was so hard to drill implant osteotomies. But we learned and we adapted. But we never had like a specific drill for this purpose. So looking at an anatomy of a drill bit, we have what? Cutting at the tip, and we have flutes. The flutes have no cutting action at all. They're just designed for extraction of debris from the hole. If the debris is not extracted from the hole, it burns on the end of the hole, and it burns the burr, and you have no cutting whatsoever. So this is basically like a fan that is working against you because it's designed to remove everything from that osteotomy. So imagine it was a fan that's just blowing everything in your face. That's basically how the flutes work on a burr. So what would happen if you just like turn it the other way around? Here's what you see. Let's just do a comparison here of a regular drill bit and a drill that is designed for ostensification. And this is gel. Gel has uniform density. So what happens if you use these two drills in gel? When you look at the left side of your screen, you're going to see that the drill has done what it's supposed to do. We just remove enough gel for it to create a hole. On the other side here, this drill is not doing that. What it's creating is creating this tornado because none of the particles are being removed. And that's why the drill was dancing so much when it was being used. So a drill like that is it was not designed for something that has uniform density. It's something that was designed for something that has varying density. And that's basically why they work so well for bone. So the idea behind these drills is for them to actually extract bone from more dense areas and to relocate that into less dense areas so that we have a more uniform density within the osteotomy itself. So these burrs would never work for anything other than bone. So this universal drills that we have with this densification kit really changed the way we look at osteotomies. And I really like the fact that they are universal because I work with 3, 4, 5 different implant systems. And I can use it for all the systems that I have. And this is what has become like my method of drilling osteotomies. But doesn't mean that I always use it in reverse because the burr cuts both ways, in forward and in reverse. Just important for you to understand that you're getting that densification when it spins in reverse. But in forward, it cuts like a normal drill or better. So the goals of densification are really to treat bone in a more gentle way. So to preserve as much as you can, enhance stability with that, and treat the bone with minimal trauma, which will have an effect on how bone heals. So you have two modes. The mode of precision is when a burr is spinning in a clockwise direction, and densification when it is spinning on a counterclockwise direction. And it's based on this common situation that we have with regular drills. We know how much bone is wasted when you're drilling an osteotomy with a regular drill. This is all bone that ends up in your suction trap and is wasted. So instead of wasting all that bone, what we do is we basically reinsert it into where the bone has less density, which is the trabecular area. So with this, we create more density just next to where that implant will go. So what we're trying to create is like a lamina dura around that osteotomy. As you can see in this picture, bone is not only compact laterally, but also apically, which is something that you have to take in consideration. Because sometimes by densifying, you're shortening your osteotomy to a point that you have trouble placing the implant all the way in because you have compacted too much bone apically. So if I have an abundance of ridge height, I'm always planning for an implant 2 millimeters shorter than I would probably place if I'm densifying. Why? Because I will still drill, for example, a 10 millimeter osteotomy, but I'll put an 8 millimeter implant. Because if I try to place that 10, chances are it won't go all the way in because I have packed too much bone at the apex. But my bone to implant contact will be so much higher than if I had drilled this with a regular osteotomy preparation, that 8 millimeter implant will have much more surface area in contact with bone and prone to osseointegration than if I had used a 10. So it's a different way to look at implant dentistry and how to practice it and how to apply that to our patients. So traditional implant dentistry was always based on compression. You drill a hole that is smaller than the implant, and you get stability by placing this bigger implant into a smaller hole. So this is solely based on the concept of compression of bone. But bone doesn't like to be compressed. There's a very, very small threshold that bone allows to be, that can be compressed without having a reaction. Because if you compress bone too much, this is what happens. You had good stability, but then all of a sudden you have pressure necrosis, the bone dies back, and you have sometimes a failed implant or an implant that already comes with a significant bone loss around it from the bone being traumatized at the time of placement. So when we look at ossification, what we're really looking at is trying to get proper adaptation between the implant and bone. So we want to increase adaptation, and that's where the stability comes from. So the level of under-preparation of an osteotomy with ossification totally changes. Think about the implant systems that you have used. For example, sometimes you have a 4.1 implant, and your last drill is 3.5. So you have a 0.6 millimeters of under-preparation of that osteotomy, right? You try to do that when you're densifying bone, you can place that implant because you have increased so much the density of that area. So my average under-prep of an osteotomy densification ranges from anywhere between 0.2 to 0. A lot of my osteotomies are the exact same size of the implant. So how can that be possible? That implant will never stabilize. It will, because I have changed the density throughout that osteotomy. So it's a different way to look at osteotomy preparation. We want to get as much adaptation as possible. And it's more like working with a metal screw. A metal screw has to have the exact same size of the hole that you're putting it in, otherwise simply cannot drive it through. So we want to get this level of adaptation when we're using it, so that with that we have the stability that we need to have, but we don't see the bone reaction. And that's the magic of this approach. So with this, we have minimal trauma during bone instrumentation, which allows us to preserve more bone, and we stay away from bone waste or excessive trauma during osteotomy preparation. So how does this work? Let's look at some studies that we have done. This is a very interesting study here, which is just simulation in a pig tibia. And during this simulation here, we can see how osteotomies were drilled with regular drills as well as ossification drills. And we can see the significance of that in terms of insertion torque and what actually happens to the osteotomy. Here's an example that you can see very clearly of this halo of bone that forms around the osteotomy that has been densified. So what are the effects of that? You see that progressively, we have almost like a fill of this socket walls or this osteotomy walls with this bone coagulum that was extracted from areas that had more density and transferred to the areas that had less density, and that's how we change this significantly. So there's a significant effect here in terms of insertion torque, which of course addresses the issue of lack of stability. So you can see what a standard drill would look like, densification drill in forward mode would look like, and something, the same drill used in reverse, what it would look like. From a radiographic perspective, you can see the creation of this lamina dura around the osteotomy, which is just what you need. You don't need to change the density of a whole segment of this patient's mouth in order to place that implant. You just want that density in immediate contact with the implant that is being placed. And that's how you see that effect. But let's look now to more like in vivo studies. This is a very interesting study in which we put implants of the same size with the same level of under prep, just drill the osteotomies in 3 different ways. So here you have a control osteotomy, counterclockwise and clockwise. The counterclockwise, they torque at over 100 Newton centimeters at the time of placement, to the point that the internal part of the implant actually stripped. We broke the implants trying to put them in. The torque was extremely excessive, and that's where we learn that we should never keep the same level under prep with this type of instrumentation, because if we keep the same level under prep, what happens is that we have too much insertion torque. Our goal is not to get that. Our goal is to be in the sweet spot of 50 to 60. So it's something that you have to try at the time of placement, and if you run into excessive torque at the time of placement, you should take the implant out and go one size bigger. With that, you're getting close to that adaptation that I was talking about without having the compression that we want to stay away from. So in animals, especially when you're working in iliac crest, this bone is very porous, is very forgiving. So despite having extremely high insertion torque, we saw no issues at all with the osseointegration of these implants. In fact, we had the highest osseointegration and bone-to-implant contact when we use densification. So this is something that can actually speed up osseointegration in many ways, because you have much closer adaptation between bone and the host and the implants. And this is a very interesting study that we did where we compared machine implants with surface texture implants. But hold on, didn't I just say that these implants are no longer available? The truth is that every implant is born that way. Surface texture is done later in the fabrication of the implant. So we asked for a company to just give us implants with no surface treatment, because we wanted to compare them side by side. Remember what I told you about before, about how in the 90s we changed the industry by going everything surface treatment? I wanted to see if we could actually overcome the deficiency of a non-osteoconductive implant surface by simply instrumenting the bone in a different way. So what we learned is here. When we look at the machine implants that were placed in a counterclockwise osteotomy preparation, let's just compare to an acid etch implant with regular instrumentation in D4 bone. Can you see how, despite not having a surface texture or not having an osteoconductive surface, you have a much more robust osseointegration of an implant that has all these features but is being instrumented in a different way. So this is something that could potentially change the industry again. And it is changing, because more and more implant companies are coming up with less texture surfaces than they had before. Why? Because they know that now we can control primary stability and bone density in a different way. And having less texture surface will probably lead to less titanium particles that may create problems with the implants that we place. And maybe with that, we can also prevent periimplantitis. So very interesting to see how instrumentation can have a significant impact here. Very significant impact. So, with this, we may have a solution or one possible solution for what we are talking about here. Maybe this will give us an opportunity to go back to what we did in the 90s and be less texture. And with that, maybe we will have a better tool to prevent periimplantitis, simply because we can instrument bone in a different way. So, this is one more study here. This is study number 4. And we have over 100 studies that have been published on this already. But to me, this was an interesting one, which I'm basically comparing 2 types of implant systems here. This is done in Elia crest of sheep. It's a great model for D4 bone. And what I'm comparing here is just 2 different types of Astra implants. Astra invested a lot of money in developing an implant that had better stability. The traditional TX had very, very low insertion torque, as you can see here, very low RFA values, which we managed to correct them by changing the osteotomy preparation. When we went to the new implant that invested a lot of money to create, yes, this implant performs better than the old one, but still something that could have been completely changed just with osteotomy preparation. So the answer is not so much in the implant, it's more on how you treat the bone. So, almost 10 years into osteodensification now, osteodensification is going beyond implant dentistry. I think it's something for us to take pride of, because we've brought so many things from medicine into dentistry. And now we're actually giving back to medicine. So what we're doing with osteodensification now is actually using the same methods, but in orthopedics. So this is like spinal fixation. So spinal fixation normally leads to a lot of downtime for the patients, because these fixation devices, they take longer to integrate. They don't stabilize as well as the dental implants that we place. So we actually have ongoing research on the stabilization, spinal fixation with or without osteodensification, as well as some other long bone prostheses that are also dependent on osseointegration for patients to be rehabilitated. So with this means less downtime for the patients and faster rehabilitation of these patients. And we have seen significant effects of that on the samples that we have analyzed so far, which we have a much better and much higher insertion torque, which will give a lot of more confidence for the surgeons when they're doing this. Compared to regular drilling, much more uniform osseointegration and pull-out tests to remove them. So for this, we have to really understand that there's a big difference between compression and densification. Compression is what we have always done. This is like placing a screw into wood. Wood allows to be compressed, but bone doesn't like that compression, as I said before. We don't want to stay away from that. We want to get into adaptation, as I said before. That's what we try to do here, so that we can maximize that healing properties. But of all these factors, probably one of the most valuable one that I have in my practice with osteodensification is the precision. Because these are burrs that were specifically designed to cut bone, in forward or in reverse. I only use reverse when I need to densify bone, but they cut extremely well in forward, better than any drills that we have used before, because these burrs don't give us that precision. It's almost like nerve-wracking to see like a first-year resident placing an implant and seeing him like bouncing around with that burr. It's not like drilling into a tooth with a high-speed burr. Over time, we learn and we gain confidence drilling. But we all have to agree that sometimes it's difficult to do that based on the anatomy of the patient. So here's where everything changes. That's my most favorite use of the burr is actually in forward. Because in forward, I have the precision that I never had for something that we do all the time in today's implant practice, which is to place an implant immediately. Now we're not drilling into something flat, we're drilling into a hole that has walls with different densities, and all of a sudden you're trying to place an implant this way and it ends up sideways, and have to change this way or that way. Why? Because the burr doesn't guide you to the direction where you have to go. So yeah, maybe you get lucky on a center incisor, but how do you put it exactly where you need on a molar area? How do you get that precision? Without having a burr that cuts laterally and also is designed to be used in that way. So with this, not only you can get good placement, precision, but you also have the capacity to minimize the bone that is wasted so that you have better bone adaptation and better bone around that implant, minimizing the gap and minimizing the amount of bone that needs to be formed. So situations like this in which you have a molar that was extracted, I can drill right into that septum and I can start to expand that septum, and all of a sudden my implant has pretty much 3 walls all the way around. I have minimized the effect of that immediate placement on that case. So before and after, it's almost hard to see that there's only 10 minutes between one x-ray and the other. So we have the capacity to do that. And this has major effects in terms of healing, how fast we can rehabilitate our patients, and how fast we can send them back to the restoring dentist to have the final restorations placed. So this totally changes our approach here. Instead of letting these areas heal, we have a better capacity to place these implants immediately. This has an effect on healing, so 3 months down the road, most of these cases are being sent back to have it restored. So it speeds up the process, but without compromising the outcomes. Situations like this, which I have a premolar that needs to be extracted, how could I place this implant without this burrs? Because if you look at where I was before, if I had followed the apex, I would be on top of that root of that first molar. Now I can drill an osteotomy right into the wall, and now I have this implant placed exactly where it needs to go, and that's how you can bring it to a more ideal outcome. So it really is a tool that can be used for so many clinical situations, such as immediate placement of a maxillary molar site. Took the tooth out, expanded that septum, and now this implant is completely covered by bone. Similar situation here, extracted this premolar. I want to place this implant in the most ideal restorative position, which is not on the buccal socket or on the lingual socket. It's actually dragging the lingual socket more buccally. And that's how you end up with this implant exactly where it needs to go, because you can drag this laterally. You can move it. You can put weight on one side, and the burr will follow you. And this will have an impact on healing. Same situation here. I'm expanding that septum, and with that I have complete, on a more ideal site for implant placement without having to wait normal healing times to have this case finished up. And with of course, with this you have preservation of not only bone but also soft tissue. You minimize the number of procedures the patient will have to go through, which of course would translate into more predictability of treatment, just coming from there to here. Situation like this, patient had this molar that had root fracture. Root fracture on that molar, I have to extract that molar. I'm going to expand that septum the same way. which allow me to place the implant at the same time. I'm still treating this residual sockets. I'm putting a membrane over and everything else, but this is an immediate post-op of the case, and then later on, it can be finished up with the final restorative treatment. Also, minimizing the number of procedures, but still maximizing treatment outcomes. And of course, when you go into the more aesthetic cases where you need to have an implant placed immediately and a provisional, here's where you want to have not only the most precise placement of your osteotomy, but you also want to have confidence of a good insertion torque to allow this to be temporized, and with that, you can preserve the soft tissue and end up with an ideal aesthetic outcome. Here's where the predictability of osteoification in giving you ideal stability becomes critical and becomes really important in doing cases like this. So, what other applications we have that are very interesting in today's implant dentistry? Sinus elevation. This is something that has completely changed my approach to the management of the deficient posterior maxilla, the pneumatized sinuses. Because I used to be someone who would do everything from a lateral approach because I wanted to visualize things. But the Cresto approach, we all agree that is way less traumatic, it's way less invasive. But methods of doing that from the crest have never given us predictable outcomes. The traditional Summers osteotome, probably like 3 out of 5 would perf the sinus, and all the other methods had the same level of success. This method totally changes your approach to crest sinus elevation, because here you're not only pushing the membrane up, but in many cases you're autografting the sinus. Remember that image that I showed you of that bone that gets packed on the bottom of an osteotomy? Well, if you break the sinus floor, it will go up there and it will start to fill up the sinus for you. So with this, the number of lateral window sinus lift that I do nowadays has probably dropped like 80% to what I was using before. And this is a very safe method, because when these burrs are drilling in reverse, they are very, very gentle against that sinus membrane. So not only you always have a layer of irrigation or solution that goes before the sinus floor, but you also have these drills that are extremely gentle against that sinus membrane, minimizing the chance for a perforation. So here's a long video of Dr. Pinto here. I'm not going to go through that, but you can see here in the model how you can have that effect that is happening against the sinus membrane. This changed things to a point that a lot of this crestal lifts, I don't even charge my patients for. To me, it's just part of creating an osteotomy preparation for the patient. It's not like it's an additional procedure that I have to schedule my patients for. So this maximizes my ability to treat the patients, but also minimizes the cost to patients, which is significant because more and more patients are interested in having this type of treatment done. And if you can simplify it and also reduce the cost, why not? So how much bone you can actually get into the sinus really depends on how much bone is residual on the ridge. You can't expect to lift 4 or 5 millimeters if you only had 2 millimeters of ridge to start, right? It's just common sense. If you have 7 millimeters of residual ridge, I can probably grow another 3 or 4 just with the bone that is present without adding any other material. If I need more, of course I use more. But this is just a typical like sinus floor bump that I would do as just part of my osteotomy preparation. And because I'm not using any biomaterial, I'm not even charging the patient for that. But of course, you can't get too greedy. If you try to force this burr against the sinus floor and you keep pushing and pushing and pushing, you're going to end up with a perforation. So you have to know exactly what to do with them and how much to look for. But I like this approach of treating an osteotomy, treating a socket with a socket graft, building bone on that ridge, and then transferring that bone that I have created on the ridge with my extraction site preservation, transferring that into the sinus, because now this has healed. I have used this bone graft material twice. I use it to maintain the ridge space, and now with my osteotomy preparation, I just push it up when I'm placing my implant. This is something that 20 years ago I never thought I would ever do, which is to do a flapless implant placement in combination with a crestal lift. Just like so many things going on at the same time, it just became very routine way of treating these patients. So did a sinus, and this is just immediate post-op of the patient. You can imagine like what kind of discomfort this patient would go through compared to what my patients went through in the past when they had multiple surgeries in order to get an implant placed. So this is how we can apply these modern concepts in today's implant dentistry. So when you look at sinus, people always ask me like, okay, I've read like so many different ways of doing this. What are your numbers? Well, my number is right here. 5 is my rule. If I have 5 millimeters on a CT scan, I can do a crestal lift. That's the very minimum. The more I have, the better it is, of course. But less than 5, I still think that the lateral approach is the way to go, because it's just too risky to do this from a crestal approach, simply because you won't have enough bone to achieve good primary stability of that implant. Regardless of your densification methods that you are used at the same time, you're not going to have the most ideal stability. So anything more than 5 can totally be elevated, and depending on what you need, you may also have to use some type of a biomaterial to achieve more ridge height, simply because what you can get from the ridge from autografting is limited. Usually 2 to 3 millimeters, that's just as far as you can go. So in terms of sequencing, I like to always start with my pilot. I measure the distance between the crestal bone to the sinus floor, and I subtract 2 millimeters. So that's what I like to do. I like to stay 2 millimeters away. 2 millimeters away, then I go to my next step, which will be using the subsequent drills that I have to use until I have the right size of the implant that needs to be placed. So the first drill is in forward, 2 millimeters short of the sinus. Now, these next drills, they will go in reverse to the sinus floor. I don't like the burrs to be penetrating into the sinus floor because they don't need to. What is elevating the sinus membrane is the bone that I'm pushing more apically, okay? And with this, we can finish up the osteotomy and have the case finished up. So basically, you have to start in forward as your pilot, 2 millimeters short, and then you switch over to reverse in the subsequent drills. If you're going to use a biomaterial with it, very important to know how much you need. About 0.25 for a premolar area and about 0.5 for a molar site. And whenever you have a cannula, I like to put in a stopper on that cannula to insert the material, so that you're not inserting the material into the osteotomy, but you're injecting it straight into the sinus floor. It makes a big difference because I don't want to coat the sides of my osteotomy with a biomaterial. I want my implant to be in contact with living, vital bone and not the biomaterial when it's being placed. And this is how you protect it from happening. I always put a stopper and I inject this straight into the sinus floor just to get the additional height that I need to get in order to have proper ridge height with my crestal elevation. So here's how I would approach something like this. I have about 7 millimeters of ridge height in that area. I have created access to the sinus. I have enlarged my osteotomy. But in this one here, I'm using a biomaterial that goes with it. And then I'm using the same drill, but in less RPM now, just to bring this material to the sinus floor. And with that, you have, in less than 10 minutes, you have an implant that is properly placed with a sinus lift here of pumping the sinus floor a good 8 millimeters and having an implant of proper size placed in that posterior maxilla. So, very significant difference in terms of how we approach the sinus areas. And that's what has changed so much my approach to the deficient posterior maxilla. Another thing that you can do with it, which is also a very popular use, is to expand the ridge. And how would you expand a ridge with a bird like this? Basically, the design of these birds comes from Summers osteotomes. Those are basically Summers osteotomes with flutes. So a Summers osteotome could expand a ridge, but it was a traumatic expansion. We were using a hammer and a mallet to just take this all the way into place. With this, you have more control because it's a rotary instrument. But as you start to enlarge the burrs, going in reverse, which is a non-subtractive osteotomy preparation, you can see the gradual expansion of that buccal and that lingual plate. And this is how you can, in many situations, minimize the need for grafting. So you can see that picture on the left shows a ridge that was probably adequate for a 4 millimeter wide implant. I plan to place a 6 millimeter wide implant because it was a big molar, and just by controlling it with the expansion that happens with the burrs, managed to stretch that ridge significantly so that that 6 millimeter implant could be placed with no additional bone augmentation. Just look visually how you can change a ridge and maximize the use of that ridge by not being subtractive with your osteotomy preparation and still have a very favorable clinical outcome. Here's another situation where you would normally dehisce or fenestrate this significantly for using a regular burr. But now what we do is we get to maintain, preserve that bone and simply displace it into a more favorable position. So just by looking at here, it's like, okay, there's no way you can do an osteotomy there without having a dehiscence. Non-subtractive drilling is very different than subtractive drilling. Not only you can do that, but you also have the control of not falling into that buccal space and losing that. Of course, this needs to be augmented. But any bone graft works better over bone than over titanium. So if you can minimize how much needs to be grafted, you're always going to have a better outcome. Another example here, an osteotomy that actually was stretched more lingually. Something that can happen when you do something like this. So here's just an implant that was placed, and this would have been too long, and this was changed back to a longer implant now based on that osteotomy preparation, which still needed to have some grafting in that area, but something that could be addressed with this type of treatment. Here's another case where you can see clinically very challenging to place an implant at this point. I think most of you would look at this like, okay, this needs to be augmented first and later placement of that implant. But just with the osteotomy preparation and ridge expansion, this implant could be placed without any dehiscences or fenestrations. We're still going to augment that area, but nothing better than having residual bone to grow bone over. So this is a tremendous impact in our practice because cases where we normally wouldn't have been able to place the implant at that point, we're able to do so by treating bone with more, with less trauma and in a more gentle way. And this has allowed me to place so many implants that I normally wouldn't have placed at that point. And with this, I have shortened treatment time for my patients significantly. And you can go one step further if you have a very significant case of ridge atrophy. So this is a very, very atrophic ridge, which normally would require ridge augmentation prior to implant placement, which would have added a good 4 to 6 months in terms of healing. If I have a good indication for a ridge split, I'm going to split this ridge. How do I split it? I go with my piezo first, I create a cut, and I create 2 vertical release incisions in here. The conventional ridge split. But a conventional ridge split would require an osteotome now to be tapped. And the easiest thing is for this osteotome to slip if you to break this whole buccal plate. So you had one problem, now you have an even bigger problem, right? Because we don't have control over it. I don't care how experienced you are, these mistakes happen. But they won't happen if you have control of your osteotomy preparation, because you're using a rotary instrument. So with that rotary instrument, I can start to stretch this buccal plate and then be able to place my implants in between these 2 bony plates in the position that I want. That's a canine, which is aligned with my lateral incisor, and that's my premolar, which is aligned with my molar. Then, of course, I'm going to grow bone in between. I'm going to do my GBR. But I change a 1-wall defect into a 3 to 4-wall defect just like that. Totally changes the regenerative potential that site has. So I'm going to put my bone graft, my membrane, just the way we're going to do it tomorrow in the hands-on session that we have, and close it up. And then 4 months later, this is ready to be restored. So I turn like a very, very challenging clinical situation into something easy, something that anyone can do, but none of this would have happened if I didn't have the right tools to make it happen. Because yes, I have tried this with conventional tools, and I can tell you that the lack of precision does not help with the predictability of that type of treatment. This is something that you can do very easily, and arguably, the regenerative outcome here was favored by the procedure because, like I said, I changed the regenerative potential the site had by changing the shape of the defect itself. So, to conclude, osteoification has been around for close to 10 years now. From the first time the Dr. Weiss gave me that prototype, and from all the research that we did after that. And I have to say that for me, there's no looking back. I really can't practice without it anymore. Doesn't mean that I densify every osteotomy that I do, but I have this tool with me. I love it in forward because it gives me precision that I never had. So I can deliver these implants in the most ideal position. But if I need densification, all I have to do is just have to flip the pedal. I flip the pedal, and this is giving me more density. I need to expand a ridge, I'll do the same. I get close to the sinus, I can elevate the sinus. So it does so much without having additional tools or kits. It's just my burst to place the implant. So that's what I had to share with you today. I'd like to thank you all for your attention. And if we have time for questions, I'll be more than glad to answer. But if we don't have more time for questions, please find me in the hallway, and I'll be glad to answer any questions you have. Thank you.
Oh, thank you, Dr. Neva. Actually, we went over time. We were having a blast with your
Thank you.
presentation. And as he's kind enough to answer any questions in the hall, we'd like to present this as a certificate of appreciation.
Thank you.
Thank you. It was a pleasure. So we're going to go ahead and resume our schedule just because we're behind, and we'll have the break later on in the day after the next, probably after the next lecture. Thank you.
again, we don't have to spend time, anesthetize the patient. That crown is really wide, and then the patients keep on yelling, and then anesthetize until, things settle in. So this is how it looks at the time. Radiographically, pretty much what we planned for, honestly. And nowadays, we could actually scan our patients, and we decide on everything with the 3D scanners. So this is how it looks. Not bad, but if you want to be again, not what I was hoping for. So we looked into different techniques, and we want to go to see what the socket shield would offer us. And just to familiarize most of the audience with the socket shield, I know that you guys know it, but just for me to review things, we basically cut the root, leave part of the root buccal surface intact and attached to the buccal surface, and place the implant simultaneously. So that buccal root with its PDL attached to the buccal plate in hopes that we maintain that convexity, the normal profile on the buccal area. And to see one of these cases where we actually planned on doing a combination of aesthetic veneers and extraction immediate implants. So this is already non-restorable. We look at the CBCT. Make sure that you don't have, if you want to do that technique, make sure you don't have a big lesion associated with it. Make sure that tooth is not mobile. Make sure that it's not vertically cracked. If you have or periodontally severely involved. Because if you keep a shield that's already infected, it's doomed for failure. So we virtually plan everything, and this is how it looks. We cut the palatal area, remove the carious lesion, and start preparing your shield. And because I did not know how that shield is going to interact with my implant, I decided I want to graft between that shield and that implant, and I want to make sure that it's autogenous. I don't want to put non-autogenous bone, thinking that this is going to optimize things for me. So this is how it looks. We placed our implant, and we grafted between the shield and the implant. And if the gap is more than 1 millimeter, I totally advise on grafting that distance. So we got our temporary abutment, and we fabricated our customized healing cap, and we dismissed the patient, and this is how the patient comes back to us. So good for us. Things clinically looks fine. The buccal contour is good too, and radiographically, this is how we started. This is what we planned and virtually planned, and this is just before placing the implant. We see that the buccal shield is still intact, it's not mobile. And this is what we the day of. Make sure you keep enough distance between your abutment and the shield. If it touches, or if you don't give enough soft tissue distance, it's gonna get exposed. And if it gets exposed, it only gets uglier and uglier with time. So this is the shield, and if we look at the things after 10 months, shield is not exposed, and things are looking good, and this is how the final crown's looking, and this is the contour of our implant area. But if anybody tells you socket shield is a simple technique that has no problems, they're not sharing the whole truth with you, because it's been reported that this shield gets internally exposed 9% of the time if you're experienced. So even if you're good, you will get that shield every now and then exposed. And if it gets exposed, it's a pattern where bacteria is going to seep and eat your bone that surrounds your implant, and then you will end up eventually taking the whole thing out. And then, let me do that on a molar. Not that I do this on a regular basis. I don't do this on a regular basis. It's an overkill. It broke my back on that day, but I wanted to put this to the test. So we have this molar, and it's non-restorable, and this is how things look like at the molar site. Tooth is non-restorable, so we decide now to prepare both shields. So we have 2 roots, we prepare both shields. You could imagine how much time that consumed, and you gotta make sure that this shield is 0.5 millimeter above the crestal bone, definitely below the gingival margin. So this is how it is. Once we make sure everything is fine, we start our implant osteotomy, and we place our implant. This time we did not use autogenous, but definitely, because I'm so worried that this might be a problem, we've decided that after we fabricate our customized healing abutment, we put in a membrane. So we make sure we separate that customized healing cap by the presence of a membrane, in hopes it doesn't get in direct contact with the shield. And this is what the scan is showing us on the mesial side, on the distal side, and this is where the implant is. So, patient dismissed like that. At the day of, patient comes back, abutment is taken out. So far, there is no exposed shield. We take our customized impression coping and we send it to the lab. We capture the profile of the socket or the implant socket, and this is how it looks. We place our crown back in, and what I like this time, I have my contour. Now, the true measurement, whether this would last or not, so this is how it looks 4 years after, and we did take out the crown, and this is how it looks. There is no exposure. So if it's done properly, if the case is selected properly, you can get away with it. And the last 2 cases I'm going to close up with. On this case, patient has a fistula coming from number 8 and a previous trauma. So radiographic assessment, we look at this initial, and this is when she presented to us. She had a draining abscess, so we took a PA, and this is how a CBCT looks like. And if you look closely, you'll see a fractured apical third and a radiopaque body on just below the nasal floor. So immediately, what I like, I use my radiologist. I ask him to navigate for me and tell me what that radiopaque. I already know that the tooth is broken and has to be removed, definitely, no doubt. But I need to know whether that radiopaque element is something that I can drill through, because I don't want to go all the way with my reflection to the nasal floor and mess it up. So he confirmed that this is a resorbed supernumerary, and definitely the tooth is horizontally fractured and needs to be extracted. So I decided to keep that and see for my chances. So we got the patient, we highlighted the crown, and we removed it. And this is how, at the time of the extraction, this is how it looks, minimally traumatic. All right? And because I already have a communicating buccal fistula, we've decided I don't want to reflect. So I'm going to tunnel my membrane in hopes that whatever bone graft I place along with my implant gets more or less contained. So we pack our particulate bone and we place our implant. And just about the time I was planning on loading that implant and connecting or picking it up, that implant started spinning. So what to do? Take it out? No. Spinner implants do work. So we kept the implant in and we switched the plan into connecting this tooth with the palatal of the adjacent teeth and dismissing the patient with that. But before doing so, we've decided to tunnel connective tissue graft on the buccal area and a free gingival graft on the crestal area, and put back our temporary and connect it to the adjacent teeth. Not the best looking temporary, I understand, but it's a lot better than dismissing the patient with an A6 retainer. People, they hate it. So this is how the patient looks like in 4 weeks, and this in 4 months. So now we're at the time where we're supposed to do uncovery, and we want to do our second stage, and we want to use that temporary crown and convert that into a temporary implant crown. So soft tissue profile looks promising, and because it's a central incisor and the patient is a young female, I want to make sure that temporary crown is ready to be loaded. So we put the resonance frequency analysis, the ISQ, and we took our measurements buccally and mesially distally. I got 20 minutes left? Kind of? All right, I'll do my best. So I'm sorry, people, if I go fast. All right, so the readings were 65 and 64, and based on the recommendations, we are in the fair, more or less fair stage to actually start loading that implant. So we temporized, we put an opaquer to hide that, but I never liked this. Even if we put an opaquer, it does not hide the grayish appearance. And in the aesthetic zone, people don't like it. But anyway, we did it. We put the locator jig, and we connected the crown, and this is how it looks. And now we used our flowable composite to start molding and shaping the tissue around. So this is how, when we picked up the crown, and this is after the work that we did before delivering that immediate temporary crown. So this is at the time of dismissal of the patient, courtesy my fellow prosthodontist, Dr. Maram. So a few weeks later, this is how the patient looks like. Yeah, fine, but still could be better in terms of color. So this is how the patient looks like. And now we want to give the patient another set of temporary. Take your time with these anterior implants. Take your time, don't rush. So try to capture the soft tissue and order another set of temporary crowns. And as you can notice, the other central incisor has already been prepared because it's part of the plan to deliver a crown on top of it. So this is how we started. This is the initial molding of the soft tissue with the first implant temporary crown. And this is how it looks before taking the patient to the final stage. So this is the second set of temporary crowns. So now we want to give the patient our screw-retained prosthesis. So we have our angulated screw channel temporary final abutment, and it can convert things. But the thing is, we placed the abutment, we torqued the abutment, and then we cemented the crown on top of it. And then, because it's screw retained right now, we can retrieve it and see. Even if we did that technique where we actually inject the material and we remove the excess, you would still have excess cement, and that's the beauty of having a screw retained restoration. You can take it out, clean it before you put it back in the patient's mouth. And this is how the patient, we started, temp in, temp off, the angled screw channel, the delivery day, and the final crown. And this is our final crown in 2 years post-operative. And this is the final crowns. Now, taking you to the last case. How am I doing on time? Okay? All right. Now, high lip line, young patient, and she came in, she said, I have this veneer, and I need this to be changed. So, of course, we don't want to touch these patients with implants because they're really hard to manage. Now, this is how the patient presented. A very bad-looking veneer. I understand her frustration, history of apical surgery, and that's how the lesion looks like. So now what to do? Immediate technique. Imagine this root out, and this thin shell of bone definitely is going to go out. Now imagine all of this grafted. And we all know if we do ridge augmentation on a regular basis in our practice, it involves a lot of pulling, messing up the vestibule, and then calling the patient for apically positioning or maybe vestibular extension surgery. So we've decided to tackle this case in a different way. We said, give this tooth a chance. Yeah? Yeah? Aren't we periodontists? We're supposed to save teeth, huh? All right, so we've decided to do a little bit of soft tissue surgery and send this to our fellow after the endo retreated that tooth along with the lateral because it was involved, and then deliver a crown. Patient went home happy. I never saw her till 2 years later. She came back. Now the soft tissue reaction looks beautiful, but that lesion did not resolve and it started suppurating again. And another CBCT shows that this lesion is not responding. Although the root canal that was done, involved an apical MTA through the canal. So did not respond. So it's about time to take the step. So we've decided this tooth needs to come out. But now we don't want to use, I am very concerned with how to temporize this patient before dismissing her. And I'm pretty sure that this tooth is not good area for an immediate implant, not with this high lip line patient. So I've decided, you know what, call in the endo again. So we've decided, flap open, do an apical surgery, and then graft the area and use a connective tissue graft. And you can notice that we've intentionally left periosteum just on top of the laterals, because I don't want to use any tacking, because it looks ugly on the radiographs, and some patients, they come back a few months later telling you there is an infection. It's not an infection, it's just that tack is poking. So, and then I used that periosteum. By the way, Dr. Nieva, thank you very much. I saw the technique of suturing the periosteum. That's where I got inspired on this one. So we sutured the periosteum on top of it, and we stabilized our connective tissue graft before dismissing the patient. And this is how the patient left. So 8 months later, everything is fine. Area was grafted, no signs of infection anymore. Now it's time to take out the tooth. So with an anterior implant, if you have the luxury, you don't have luxury at all. أفصل ورجع مرة ثانية. This is not coming out of my pocket. Okay. All right. So if you have the luxury of planning things on a 3D virtual planning, do it. Not only that, ask your lab, if they're high-tech lab you're dealing with, to actually fabricate for you charge. في charger؟ طب تعطينا charger الله يرضى. I'm sorry. It's the last case. كله it's okay. switch الله على بالك. طيب يلا الحين. Yes. So you could ask your lab to, I'm sorry about that, you could ask your lab to fabricate a locator jig for your abutment, and you can also ask the lab to fabricate for you a locator jig for your crown. I've decided this time we're delivering a temporary ceramic crown. So we get the surgical guide, we get the angle screw temporary abutment, and we get the abutment jig, the crown, and the crown jig as well. So we take out the tooth, and of course, a little bit is left in that tooth, so it wasn't really a hassle to take it out. And this is how the socket looks like. We place our guide, we place our implant, and we place our abutment, right? Now we need to provisionalize that abutment, but definitely connect tissue all the way in the anterior zone. high lip line, you don't want to mess it up. And you suture around it, dismiss the patient, and the patient comes back a few weeks like that. Now this is just a temporary crown. Now, before taking the patient, definitely we need to send for biopsy. That lesion, that non-responding lesion has to be cleared out so we can sleep through the night. And it was confirmed that it's a radicular cyst and it was not responding, so there's nothing to worry about for our implants. And this is on the final crown delivery day. Courtesy Dr. Khalid for the beautiful work. So this is how the patient now was dismissed at the time of, it took a lot of time, but definitely was worth the trial, worth the crowns, worth the time. Never forget, immediate implants are always, always heart of a lion, hands of a butterfly. With that, I would like to thank you all for the kind invitation. Thank you very much for having me.
Thank you, Dr. Hameidan.
I mean, if there are questions, and by the time Dr. Turki gets hooked, I could answer if there are any. And if there aren't any, then it's time for machboos. I'm hungry. I'm hungry. Any questions? All right. Thank you so much. Oh, there's a question in there.
I want to ask about the set of polishing stones that you're using for the temporary to make it more healthy for the gums.
Suflex, and then cotton. The restorative dentist that I work with, he uses cotton, and then steamer. That I heard Dennis Tarnow saying one time. He said, before delivering your temporaries, whether it's a customized healing abutment or a temporary crown, steam it. You cannot believe how much debris gets attached to that temporary crown. And if it's an immediate implant, don't get surprised if you have a lot of bone loss around this immediate implant. It's not the technique. It's how dirty that temporary crown was. So steam it as a last. You could use a polishing paste at the end, but that's it.
Timetable.
How long does it take to build the tissue profile? If you notice this last case, a year and a half. Anterior, high lip line, young female, deadly combo. I'm pretty sure most of you agree on that statement. Don't get me, I'm not offending, I hope I'm not offending anybody.
Hello. Oh.
All right, thank you so much. The next speaker is an outstanding speaker. I'm sure you're going to love him more. It's time for me to eat. Thank you so much for your time.
Thank you, Dr. Hameidan. So now with Dr. Turki. So Dr. Turki always wanted to follow his father's footsteps and the education path. He believed that knowledge is gained to be given. Since 2010, Dr. Turki started to be involved in courses and surgical supervisions. In 2011, he started his university, teaching career at Misr International University as a clinician. Of course, he was appointed as a clinical instructor. During the time at the university, he was one of the key staff members that helped in establishing a strong foundation for implant education. In the year 2014, Dr. Turki was appointed as a program director for MSCs and PhD student at Cairo University, where he restricted his university teaching career since 2016. At this prestigious entity, during his teaching career, he founded and designed several implant courses for short-term and long-term. He performed several implant and periodontal workshops, gave lectures and workshops in several conferences and symposiums, addressing topics that opened new insights for clinicians to apply to their daily practice. Dr. Turki is the owner and founder of Turkey's Dental Clinics and Academic located in Cairo, Egypt. Dr. Turki presenting immediate loading, the biodigital approach. So he most welcome to start now.
Yes. No. Bismillah. I just wanted to take a moment to mourn the shuhada of our brothers and sisters in Palestine and pray Allah Almighty to give them the strength to get out of this horrifying situation they're living in, and appreciate the tremendous support Kuwait is providing Palestine and the Palestinians. I'm honored to be presenting today at the first Kuwait Dental Implant Symposium alongside with these great clinicians. And also, thank you for giving me the opportunity to come back to my second country. Literally, I was born and raised in Kuwait. All my childhood and teenage memories were done here. So yes, I'm biased to Kuwait. My humble, and as you can see, I look terrible and nerdy, but put this on a side, I find I'm someone who approved to marry me, so that's not a problem anymore. My humble practice and academy are located in Cairo, and all the cases that you will be seeing in the presentation were done with the help of my amazing team. Now, survival and success. There are two different terms with different paths that need to be taken in order to achieve each one. In the early 80s, the only goal and focus of research and clinicians was to achieve success in osseointegration. And then later on, through the 90s and early 2000s, studies were tended to focus more on crestal bone level and marginal bone loss and peri-implantitis, since we started to see complications and we started to understand somehow how osseointegration happens. So there's a gradual shift in research and industry manufacturing that tended to shift from focusing on osseointegration to focusing more on bone biology. And then later on, the shift tended towards implant design. We want to achieve even better results, and we want to achieve more successful treatments for our patients. And that's the only way to achieve patient satisfaction. The moment you extract a tooth, an upper central anterior aesthetic zone, what's the first thing that will come into your mind with your treatment plan? Will you extract the ridge preservation, extract, place an implant, custom healing abutment, extract an immediate load? Probably your choice would be, or our choice would be, implant placement. Maybe if we know how to load, we will go on and load, because the patient would want an aesthetic restoration. But what about a case like this? what will your plan be when you start to place implants in the posterior region, immediately in sockets? Would you still go for immediate loading? Will this be our normal choice, or let's say routine daily practice choice for our patients? At the start, we were really happy placing implants in extraction sockets. That was something was risky back then. And then we started to place implants in extraction sockets with healing abutments, non-submerged protocols, or one-stage surgery, and then we went ahead a further step and placed a custom healing abutments. And today, this is like becoming more common and uncommon in our daily practice. And then a further step ahead through the timeline, we started to do more immediate loading cases, especially in the anterior aesthetic zone. But that's not the true timeline. Immediate loading was started since the 60s and 70s. Linko and Miller, they started immediate loading with endosseous implants, subperiosteal implants, blade vent implants. It's nothing new. It's nothing risky. There's abundance of research showing us that immediate loading is as survival rate or as successful as delayed loading. And these are just a very few studies that are available in research today that shows they both have the same survival rate. And numbers don't lie. These are numbers available in research, and the more you look into research, the more studies that show us they have the equal survival rate. Then why isn't immediate loading a routine implant treatment in our daily practice? Why is it limited to the aesthetic zone? What's the reason for that? Honestly, I don't know the answer, but I can guess. And on a side note, a clinician commented once to me on social media, and he was in a posterior immediate loading case, and he was like, why we were never taught this in our implant residency? I don't know, but I can guess one of the reasons is complications that happen when we don't carefully execute immediate loading cases. That's what happens. The patient comes to you, you have to retreat the whole case, extract the implant and start from scratch. Unfortunately, you will never, ever reach the result that they started with. It will always be a defective treatment, and the patient has to suffer for the rest of her life. Then, why do we do immediate loading? Research have shown that clinical performance of immediate loading cases, they have excellent bone stability, excellent soft tissue stability, and excellent patient satisfaction. Remember, we are all here for one simple reason: our patient satisfaction, not anything else. We do research in order to improve our treatment for our patients. We learn, we attend continuing education courses, conferences. This conference is done not to only learn a technique or two, or to understand some theories, but to do that in order to serve our patients and provide a better treatment for our patients. The only way your patient will recommend an implant treatment to his friend or family if they are satisfied with your treatment. And trust me, they won't be satisfied if you provide a dental implant treatment in 4 or 5 visits to restore one single tooth. Who would want this today? Who has time for 4 or 5 visits to restore one single tooth? So today, custom healing abutments have showed beautiful results, and Lenz, he showed that utilizing that was done this year. There are very few studies on custom healing abutments, and they're all in the past few years, and he showed good bone stability, good soft tissue stability, and good survival rates. So overall, it's a successful treatment for our patients. Through time, immediate loading is becoming more, let's say, predictable. We are able to understand immediate loading and primary stability even better than before. It started with a torque wrench where we measured torque, and then went in the ISQ reading devices to measure micromotion. And today, the Giri have made a step even further using artificial intelligence to predict the possibility of immediate loading in every single case you do in your practice. He proposed a novel tool, a device that will measure and analyze the bone the primary stability, the micromotion, and will come up with a prediction from software to tell you whether to go on with immediate loading or not. So we are as advanced as ever in immediate loading. But why isn't it still a mainstream treatment in our daily practice? Now, why do we immediate load? These two cases will show you actually why do you need to immediate load and why immediate loading is a treatment that should be applied as much as possible. On the left side, we have a delayed implant placement. Yes, I did that, and I couldn't immediate load, although I always try to target to immediate load, but I couldn't. I had 10 or 5 Newton centimeter of primary stability. The implant was a spinner, a really good spinner, so I couldn't take a risk. And we know it's not a risk, it's a mistake to load an implant that is less than 20 Newton centimeter in some implants. Others, we can go as less as 30, not below that. So it depends on the system that you are using. But research, Norton have showed us as little as 20 Newton centimeter, you can immediate load. And that's what I got after 3 months of healing period. The implant is osseointegrated, I just got a loss of contour. On the other side, not 1 implant, but 2 implants with immediate loading, done in 2 visits, completed the entire treatment until definitive restoration only in 2 visits in 8 weeks. Which patient do you think is satisfied and would definitely recommend implant treatment to his friends and relatives? That's our goal. We want more recommendation as possible, word of mouth, the most powerful marketing tool that you can have in your own practice. Now, I had to deal with the first case by connective tissue graft because we don't want this depression. And as Dr. Abdul Karim showed us, of course, yes, it's not a totally hygienic restoration, so we needed to correct this. How long does it take to correct this? 4 weeks to 8 weeks, maybe? Minimum 4 weeks. So this adds to a treatment time of 3 months, another month. Do you think the patient is satisfied? You have to control him and convince him. We have to go through 4, 5, 6, 7 visits just to restore 1 tooth. But at the end, we were successful in achieving good contour. So the end result is the same, but the time factor and the satisfaction factor is totally not the same. And then we go to another case, posterior immediate loading or immediate placement, in this case. You can immediately see the effect of extraction on soft tissue collapse. An immediate collapse. You had a rigid tooth structure that was there, you extracted this tooth structure, and what will happen? Tissue will definitely collapse straight away. So we need to provide an alternative rigid structure that would pull or push, in this case, the tissue back. Can we do this with biomaterials? They're not rigid, unless it's a bone block, and we would never place a bone block in such a situation because we don't need even to raise a flap here. So we only have particulate biomaterials. They shrink, they change shape, they do not provide the support we need. So what we do is we provide a custom healing abutment in such a case, or a temporary crown, whatever you prefer. In single crowns, single tooth restorations, doesn't matter a lot, but in multiple restorations, custom healing abutments are not the best, and we'll see why. Now, this provides immediate support to the tissue. And what will happen is that this support will continue throughout the healing period. That's what we want. Remember that the only reason for complications in immediate placement is not anything but lack of support to the buccal plate or the buccal tissue, until the new buccal plate is formed. I know that a lot of research, they show we have thin buccal plate, don't go for immediate loading, but studies like Magnetti has proved all these studies not to be really accurate. Because he showed that just after 1 week, whatever thin buccal plate you have, it will resorb after 1 week only. And the new buccal plate will start to form after 2 weeks. So by the time you have a fully matured new buccal plate, you need to provide room for this buccal plate to form. If you don't provide support for the tissue, it will collapse. It will take the space of the new buccal plate that should be there. So the main goal actually of immediate loading is not aesthetics. Immediate loading is not an aesthetic treatment. It's a biological treatment that you provide for your patient in order to achieve better results, faster results, and more predictable results. So the misconception of immediate loading to be limited to the anterior aesthetic zone is not true based on biology. This is the case that I showed you earlier where I did delayed loading. You can see we started with 8.5 ridge width. And after 3 months, we ended with 6 or 7 millimeters. So we lost 1.5 millimeters of ridge dimension just because we did not provide support. Now you can come and tell me you could have placed bone graft in this socket. What would it do? Nothing. I still have bone buckled to my implant, so osseointegration was not affected. Filling a gap with biomaterial does not improve osseointegration. It's only a crystal size keeper, and we'll see later on how research shows us. Now, on the other hand, with an immediate loading case, we started with 9.7, and we ended up with 9.4, minimal ridge loss, not clinically significant whatsoever, and we almost preserved the ridge dimension using only 3 things: an implant, an abutment, and a crown. Nothing else. No biomaterial, no membrane, nothing. It's not magic, it's understanding biology. God created sockets and teeth in a way that when they are extracted, they heal in a certain way. Our role as scientists and clinicians to understand the role or the way the socket heals and use this for our benefits, or more importantly, for our patients' benefits, for our patients' satisfaction. Results like this, today we are able to achieve in 2 visits using biological protocols and understanding and digital workflows. Other than that, it would take time. And going through the time frame that we started with through the history of dental implants, starting from the 80s to today, we started with 4 or 5 visits. That was the normal treatment protocol for any implant placement. And we all know clinicians that have started to place implants in the 90s and 2000s. It was normal to have the patient come in for implant placement, then uncover, then impression or scan, then delivery. If you're lucky, 4 visits, if not 5 visits. Later on, we knew that the non-submerged protocol, placing a healing abutment, saved 1 visit, which is 2nd stage surgery. And today, clinicians like Degidi, Herzler, and Weigel, they all showed us the one-time one abutment concept that we can provide for our patient immediate loading and definitive restorations in 2 visits. And they actually provide it in 3 visits, but with digital workflows today, you can do it in as little as 2 visits. The patient comes for 1 visit, implant placement and temporization, and the next visit before he arrives to the practice, you have his definitive restoration ready before he arrives. Without using guides, without using complicated treatment protocols, just by understanding biology. And primary stability is not really hard to perform. You just have to be cautious doing immediate loading, but you don't have to be cautious planning for immediate loading or planning to immediate load. All you need is primary stability above 20 or 25 and a precise implant abutment connection. Because if you have an implant system that has micro motion between the implant and the abutment, then biology will never work when there's movement during healing. Imagine having a free gingival graft. It can never heal if it's not stable. In our entire body, healing doesn't happen if there's any movement. Same thing for the implant. If there's movement between the implant and the abutment, the risk of failure is higher. There's a lot of implant designs today that we can use to have a more predictable primary stability. So we need to choose the implant system correctly, that is, will be appropriate for our service or treatment for our patients. to achieve primary stability. You don't want to promise your patient that you will load, but you can't. You have to have the ability to know that you're going to load, and you will load any or most, unless there's a huge defect, sockets, extraction sockets that you have, or delayed ridges. Now, Civolella, he did a very crazy study, and that's why I'm going to show you a bone graft in a jumping gap, nothing but a crystal size keeper. When you add an implant that there's no contact between the implant and the surrounding bone whatsoever, he did this. He did it on a Saudi site, an implant inside with no contact with bone, no contact whatsoever, but the implant was stable. And this is the device he made to ensure primary stability of the implant. What happened? Osseointegration did happen or not? There's no contact, no bone fill. Osseointegration happened, but in a defective manner, but it still happened. This means that the prerequisite for successful immediate loading or primary osseointegration is primary stability. That's the most important thing that you need for successful osseointegration and immediate loading. Spinato, he showed us that placing bone graft in a socket is nothing but a crystal size keeper. Remember this name, because whenever you add biomaterial that you don't need, you're providing a foreign body into your patient's mouth and providing extra treatment, extra surgical step. The patients don't always need that. And unfortunately, companies around the world, manufacturing companies and industries, they tend to push us towards using more biomaterials than we should. But if you understand biology, you would know that we don't always need biomaterials. You can use the biology of healing and the power of biology in your site. And this shows us, by Arujio and Lindy, he showed us that the biomaterial is incorporated in the soft tissue. And this is what gives you the crystal size keeper or the volume, because it's part of the tissue and not bone. It gives you more volume and more support. But if you add biomaterials only, the support will collapse. You need something rigid to even further push the bone that you added. So if you're going to add a temporary crown or a custom healing abutment, yes, sometimes adding more push or more volume using biomaterial, it could be an option in thin tissue. And what he did, placed a bone graft around this implant that is not in contact with bone, and what he found, any gap larger than 1 millimeter, nothing happened, no bone formed, although he had autogenous bone and nothing happened. But a gap that is less than 1 millimeter, bone did form, but with a defective bone to implant contact. So placing bone in a socket doesn't affect osseointegration or bone formation or healing period or healing time. It only acts as a crystal size keeper. Now, our goal with immediate loading is to achieve results like that. We want a thick buccal plate in the end, and you can only do this through narrow implant diameters and palatally placed implants. And the reason is I want to provide space for the new buccal plate to form. If I don't provide support for the tissue, what will happen? Tissue will collapse, and the new buccal plate will have no place whatsoever to form. So we have dehiscence, fenestration, implant failure, and complications in immediate loading. And you say, what happened? Because you didn't load. You place an implant immediately, you place your bone and membrane, but you still have defective restorations. The moment you place your implant as palatal as possible, and you place a narrow implant, you provide a space. With the Gedi called it the socket chamber concept. This space is what provides volume for the new buccal plate to form. If you understand this theory, you would always aim for immediate loading in a successful manner. That's what we had. Look how thin the buccal plate started, and look how thick it is now. It's 3 times or 4 times the size. What I did, I just provided space for the new buccal plate formation by applying support for this tissue until the new buccal plate forms. And this is the result we got in this case. The patient was happy, and above all, the patient was satisfied. Another case, you might think they cannot immediately load such case, maybe even you cannot immediately place such a socket due to approximation of the sinus, no bone left after extraction. But if you look at it in the larger dimension, you have mesial bone, there's are 2 premolars, so you have mesial and distal bone that you can engage with an aggressive implant. So the only way you can achieve primary stability in such a case is using an appropriate implant design. If you choose the wrong implant design, it's not going to happen. That's why I always, when I teach my students, I always tell them, you must understand and learn to use any implant system available in the market. It's not about the system that you get used to. You have to adapt to any system because they keep changing and some systems are better for other situations, so we need to understand what system to use for what case. And in this case, what we did, we placed an implant, extraction, immediate placement, and immediate loading for the 2 crowns, both restorations. In 8 weeks, we finished the treatment, and this is a 16-month follow-up. We can see the contour did not change at all without any biomaterial being placed. Just 3 things. Again, an implant, an abutment, and a temporary crown. That's all you need. Of course, you need to choose your implant system wisely, and you need to be careful and take your time during drilling. Take it as a rule, take your time during drilling, but don't take your time in many visits. Do the first visit, whatever time it takes, but do it only in 2 visits, maybe sometime 3. And posterior region, same protocol, but in this case, I did something different because remember, we have patients, and this is the most annoying question we get in implant dentistry from any patient, when they come for second stage. Second stage, the implant is totally covered by tissue, and they come and ask you, is my crown ready? Don't we get this question from patients? And you tell them, crown ready? I didn't even expose the implant, I didn't even take an impression. How can I have a crown ready without impressions? The way I did this protocol was to answer this question for the patients that are asking this. Yes, I can have your crown ready before you come to the second stage, which is not a second stage, but a second visit. And here's what I did. We placed the implant, extraction, placing the implant. Remember, custom healing abutments are made to take the exact shape of an extraction socket. But I didn't do a custom healing abutment. I did a custom zirconia definitive abutment the same day of extraction. So the patient arrives to my practice, we extract, we place the implant, we take a scan, we fabricate and manufacture a custom zirconia abutment the same day, and at the same time, we also design a definitive restoration that we will deliver after 8 weeks. And I'll tell you why 8 weeks is enough. So this is, open the space, video. Just wanna, okay. Now here is the stage where you have to direct your lab. Never let a lab direct you in your own treatment for your own patients. You have to direct the lab and communicate with the lab and show them what they need, what you need, and they will show you what's capable with the software that you're using, whether AxoCAD, whether 3Shape, whether the CEREC software. There are a lot of softwares today, as long as you understand what you want. So I was sitting with the designer and telling him, I need the contours in that way. I don't need to be over-contoured. I need to provide support with this custom zirconia abutment. And of course, in order to do this, I have to place my implant in the correct depth. And then we design together the custom zirconia abutment that would take the exact shape of the socket, that would provide support for the entire 8 weeks until the new buccal plate is formed. And he tells me, okay, you're using zirconia, the minimal thickness is this, I can do this, no I can't. We communicate with each other, we sit with each other, and come up with the best result for our patient. Your patient is your goal. It's not whether you're doing bone blocks or soft tissue or full arch. After all, patient satisfaction is a must. And if you don't do that, your practice, trust me, will go down with days and years. And other clinicians that are providing patient satisfaction, we keep on going upwards. So when we design the definitive restoration, because I want the next time when the patient comes after 8 weeks, I have the crown in the clinic, and he enters the clinic and he asks me the question, and I answer with all happiness. And he asks me, is the crown ready? And I tell them, yeah, it is ready. Come here, 5-minute visit, cement the crown, patient leaves, he recommends the implant treatment to his friends, relatives, neighbors. Everyone asks about, I didn't feel any pain. And believe me, patients like this, they never feel any post-operative discomfort. When you do immediate loading, I never thought that this is actually the reason. I really don't understand this well or fully, but immediate loading, very minimal discomfort, maybe none, no pain, no discomfort for the patient. He lives his life normally. He only has to follow your instructions. That's it. And trust me, they love it. They will come back to you the next day or after 1 week. You know, Dr. Torki, my friend did 1 single implant and he was in pain for 10 days. And you did for me 6 implants, immediate loading upper and lower, and I felt nothing with extractions, with temporization, and I felt nothing. Are you sure you placed the implants? I'm like, I'm not that crazy to convince you I placed the implants where I didn't. So yeah, I did place 6 of them. She was like, you know what? I told my friend to come and do the other implants. And I told my sister to come and do her implants. And my father wants implants, and this and this and that. She can't believe herself. And they all don't believe themselves. Because the normal concept they get from social media, from friends, from other clinicians, implant is a painful treatment, is a boring treatment. You have to go 3-4 visits going and coming back, impression taking, until you adjust the contour that you want with temporization, change your temporary once, twice, and 3 times, and you will never be satisfied. And you yourself will be bored from the patient himself. I don't want to see you again, just, okay, I'll accept this result, and you don't really like it, but you're bored, and you don't want to see the patient again. So we placed the custom zirconia abutment, and this is the immediate post-operative. This is 8 weeks post-operative. Now, I didn't place a definitive crown or temporary crown because I don't need a temporary crown. All you need is to make the contour smooth. The custom zirconia abutment doesn't need to be really high because today with cement power and the technology we have and the amazing cements, resin cements out there, we can have very strong retention with short abutments. So we placed, this is 8 weeks post-operative, the patient comes back, and I don't touch the implant. I don't need to wait 3 months. I'm not removing the screw, I'm not touching the implant, I'm not touching the abutment, I'm just placing the final restoration in occlusion after 8 weeks, 5-minute visit, maybe less, the patient goes home. And this is 8 weeks post-operative X-ray. You can see bone fill, and that's the beauty of this, with native bone filling the socket. I don't want biomaterial to fill the socket forever. I want native bone. And the only reason, the only way you can do this is by providing buccal support of the tissues. And of course, we now know today that custom zirconia abutments, they have to be fully polished, highly polished. Lingvicius has showed this several times in many studies. And this is how polished it should be. And I'll go quickly just with that. It has to be really polished. And we know we have to place the implant in the correct depth in order to have the biological width to be formed completely on the abutment and not on the implant. And I'll go quickly now. One last case just to show you. In full arch restorations today, unfortunately, clinicians are so mean to their patients. They use stackable guides, and the lab will try to sell you stackable guides. It makes them money. And he will tell you, oh, you need a bone reduction guide. You need to remove 3 millimeters of bone and take this guide and take that, this and this and that, and you end up with an FP3 restoration that patients hate. Imagine you wearing a denture made of zirconia or titanium covered by zirconia, but at the end it's a denture. Restores the tissue, restores the teeth, and restores part of the bone, and they never are able to clean it well. Why do we need to go through this? and it's becoming more common using bone reduction guides. You rarely need to reduce any bone, maybe 1% of your cases. This way, I didn't use a surgical guide, I used a prosthetic stent, just to know where to drill. Very easy. You drill freehand. If you have a scanner, then drill freehand and take a scan, let the patient rest for a while, and the lab will manufacture or mill a temporary full arch restoration that is only restoring the teeth. And the beauty is, with these ovate pontics, you will do magic. This case came late. He extracted already the teeth, so I couldn't do immediate, but I did delayed. And we also reached the same way. Now, here we have a problem. The temporary is outside the tissue. We need to do something. We need to reach this level by placing a lingual incision, opening a flap, placing a temporary restoration, let the tissue heal on the restoration. This result, we were able to achieve in 5 months. You don't want that. But I had no option because the patient already came with the teeth extracted. Now, we also do this in temporary bridge. Now, look at the beauty, this last thing I will talk about, the beauty of placing a lingual incision and immediate loading in healed ridges. Now, look at the contour, that's before placement, and now I place an implant and open a flap, push the flap buckle, and place my temporary crown immediate loading. Look the tissue contour. No connective tissue grafts, no second surgery. A 5-minute procedure of placing a single implant and maybe 1 hour of milling a temporary crown. This is the magic that you can get just by understanding that tissue will creep over your temporary crown if you provide support. Also in healed ridges. Support is not only for extraction sockets, it's for healed ridges also. And similar situations, so to finalize, what I wanted to talk to you about, understanding biology and digital workflows, is the key for patient satisfaction. You keep your patient above everything, and trust me, your implant patients will fly to you. And they will ask for you because they know you're doing something others are not doing. Thank you, everyone, and honor free.
Thank you, Dr. Turki. It was really interesting. I start changing my mind now in immediate implant. Thank you. Any questions? We might allow for 1 or 2 questions because we lack of time.
Yes.
Thank you, Dr. Turki, for this very valuable information.
Thank you.
I just want to ask you, are insisting in the word buccal support. Buccal support of what? Soft tissue or hard tissue? And does the support of the soft tissue prevent the collapse of the hard tissue?
Yeah. Of course, it's support for the buccal tissue because the buccal bone will resorb anyway.
Which buccal tissue? Soft tissue?
The soft tissue on the buccal side, buccal to the buccal plate of bone. Now, after you extract, you have buccal plate and tissue. Part of the tissue is still supported by the old buccal plate, and the coronal tissue is loose because it was supported by the root or the crown of the tooth. So when you extract, what happens is this coronal tissue will collapse, but the apical tissue is still supported by the old buccal plate. Now, within a week, the old buccal plate will also dissolve or resorb. So what do we have left? No support for the coronal tissue and no support for the apical tissue. So you'll have complete collapse of the tissue. Now, I cannot provide support for the buccal plate because it will resorb anyway. Yes. The bundle bone theory, we cannot do anything about it by Araujo and Lindy. So we need to provide support to the tissue until the new buccal plate comes and does its support. So the immediate loading idea is to provide a temporary support for the buccal tissue until the new buccal plate forms.
And in the other case for the molar, you made the immediate load also. You made this support after 8 weeks already. You
The support was for 8 weeks. Today, osseointegration happens in 8 weeks. We don't need 3 months. before it was 6 months, then 3 months. Today, with some implants, you can achieve osseointegration in 8 weeks. So after 8 weeks, you place your final restoration, and you don't need to touch anything if you have the one-time one abutment protocol. If you have the abutment there from the day of placement, you don't need to remove it. You just remove the temporary crown, place your final crown.
Thank you.
You're welcome.
في معلومة دايما عارفينها ان احنا لازم نعمل بكتيريال سيل من السوفت تيشو after the placement of implant عشان avoid any يعني تدخل او implantitis او كده. فاحنا هنا ازاي هنوصل للسيل دوت ولا هو ما بقاش اصلا valuable معنا؟
Very good question. ربنا خلق السيل. غصب عني وعنك. The seal is biologically determined. With the moment we extract a tooth, the seal will happen by granulation tissue, blood clot, and then granulation tissue. We don't need to make a seal. Rabbana, he programmed the socket to make a seal as a defense mechanism to bacteria. The moment you, and that was, Amler said that in 1969. He knew what happens by God, and we still don't believe this, but it is the truth. The moment you extract a tooth, within 24 hours, blood clot forms, protects the socket. It has to be protected because bare bone will never happen. So the bone has to be protected by blood clot, and then 48 hours granulation tissue, and then the first lining of the socket is the apical part to protect the native bone. So we don't need to provide a seal. Bone augmentation is useless in the seal. Membranes is useless. It's all waste of biomaterial. We use too much biomaterial today. And I was amazed in Canada and in the US, that was I told by many of my students, they can't actually do immediate loading a lot. They need to do rich preservation. Or else if they don't, some problems might happen legally. So they use biomaterials in too much, and companies, I believe, are behind that. So you need just to leave it to provide the seal. Yeah, if you replace bone augmentation, it's just something extra. The seal will happen anyway, unless there's no infection.
I think we need to stop now. Thank you very much, Dr. Turki, for your presentation.
Thank you.
And please accept. Certificate of appreciation.
Thank you.
Thank you very much.
Thank you. Thank you so much.
Just pass it.
So we reached to the final lecture. I hope it was informative and it was our pleasure. So it's my pleasure to introduce Dr. Abdullah Al-Nassar. Nasser is an assistant professor in the prosthodontics department at the Prince Sattam bin Abdulaziz University. He graduated from the same institute in 2015. He completed prosthodontics and he followed also to get his fellowship in Loma Linda. He's continuing in education and he's following his career. So without further ado, please.
Thank you. Assalamu alaikum. Thank you for the introduction. Good evening, everyone. First of all, I would like to thank the organizing committee of the Kuwait Dental Implant Symposium for arranging this prestigious meeting and for inviting me to be part of it. To begin with, I would like to talk about the digital workflow in prosthodontics. Most of the prosthodontics, including myself, we were not comfortable utilizing a full digital workflow in fabricating full arch implant prostheses in the maxillary and mandibular arches. So as a prosthodontist, I tried to find some solutions to solve some of these problems associated with the scan aligning or the error that associated with the final product. So I came up with a novel technique that enabled me to use the digital workflow solely without combining it with any analog workflow. We used to have at least mounted a verified master cast as a backup plan or just to make sure that our final processes is as we planned. So at the beginning, why we are incorporating a digital technology in dental field? Now, we incorporate any new approach in the dental field just to improve the efficiency of the treatment and make sure that this approach is a predictable approach and to provide us with a successful outcome. So what about the digital technology? And this is what we're gonna know at the end of this presentation. There are three main elements in the digital technology and dental field. The first one is the data acquisition, and the second one is the computer-assisted or computer-aided design software, and then the computer-aided manufacturing machines. So in the data acquisition, we obtain the data either from the CBCT, intraoral scanning, facial scanning, or through the desktop scanners to scan the models. And then we transfer the data, the STL files, into the computer-aided designing software to either do smile design or to design and fabricate the final processes, or also for digitally implant planning. And then once we design the final processes, we export these files and transfer it to either the printing machine or milling machine. Now, in the literature, there are multiple published protocols for designing and fabricating full arch implant processes. The first one, double digital scan, reverse cam body, photogrammetry, and triple digital scan. In the double digital scan, the author utilized a fiducial marker, and basically it's attached to the keratinized attached mucosa, and then they do intraoral scanning for the prosthesis. They remove the prosthesis and attach scan bodies, and then they do intraoral scanning again, and then they transfer it to the designing software to perform the alignment using the fiducial marker. But this technique is limited only to the maxilla, and we can't use it in the mandible due to lack of enough keratinized non-movable mucosa. So the same author came up with another approach for the double digital scan by utilizing the anchor pins. And I think all of us can agree that this approach is considered an aggressive approach. So, and it's limited only to the immediate implant loading. The second protocol is the reverse scan body protocol. And this is a new protocol nowadays. Basically, we remove the prosthesis from the patient's mouth, we attach the reverse scan body to the prosthesis and do scanning for the intaglio and camus surface of the prosthesis along with the attached scan body. And then we do intraoral scanning for the scan bodies and the prosthesis, and then we perform the alignment in the software and we design the final prosthesis. But this is this technique, it's still limited, and I don't think it's readily available to everyone to use this scan body. And the next one is the photogrammetry. Basically, in this technique, we use a domino-like scan body, place it in the implant by using, and then we use a specific camera on a specific machine to capture and virtually transfer the implant position from the patient's mouth to the designing software. Then we remove it, place scan body, scan it again. This technique is good for immediate conversion or fixed implant prosthesis fabrication if the patient doesn't have a fixed interim prosthesis. And the last protocol is the triple digital scan. In this scan, the author duplicate the existing prosthesis that the patient has, and then they made window in the anterior 4 implants, and then they perform intraoral scanning for the existing prosthesis that the patient has. They removed it and based scan body on top of all of the multi-unit abutments. They perform full arch scanning, and then they removed the most posterior 2 implants and placed the prosthesis with the windows. And they scan it again, and then they perform the alignment. But from my observation, I found out that some of these scan bodies are not aligned perfectly. And we afraid that that could lead to error in the final prosthesis. So when we compare the digital and analog workflow for fabricating full arch implant prosthesis, in vitro studies of digital scanning have reported accuracy comparable with that of the conventional impression. Digital workflow reduced the post-operative complication, increased patient satisfaction, and maintaining the long-term predictability of the treatment outcome. So for implant dentistry, the clinical validity of the digital scan is determined mainly by the passive fit of the prosthesis between the superstructure and the implant, or the superstructure and the multi-unit abutment. So an acceptable misfit value has yet to be determined. Excessive misfit between the prosthesis and the implant or the abutment may lead to mechanical failure or biological complication. So let's go now to the analog workflow, and let's see the sequence of the analog workflow so we can have a comparison between the digital and analog workflow. So in the analog workflow, in the first visit, we can do border molding for the full arch, make final impression for the implant, and then in the next visit, we do a verification jig just to make sure that the cast that we have is a verified cast. In the third visit, we do a jaw relation to mount the cast in the appropriate occlusive vertical dimension. And then in the fourth visit, this is an optional visit if we're going to do a copy mill final framework. We try in the cutback framework to make sure it's passively fit, so before we send it to the milling center. And then in the fifth visit, we try in the framework, make sure it's passively fit, and we have enough hygienic space if we're planning for that. And then in the finally, we place the final prosthesis. So if we evaluate this analog workflow, this analog workflow will provide us with successful outcome, and it's a predictable treatment approach, but the efficiency, it's not that efficient because we need multiple appointments, a lot of laboratory as well as clinical procedures. Now let's go to the clinical situation. So I performed this novel technique. I applied it to multiple of my patients, and today I'm going to share with you one of the completed cases to show you the end result of that technique. So the patient has mandibular hybrid prosthesis, maxillary converted fixed implant prosthesis, and she wanted to have a maxillary and mandibular zirconia fixed complete denture. So we decided to use this novel technique. This novel technique, basically, it's rely on having a customized scanning device. And to design this device, I scanned the screw-retained abutment by using a monoscan body outside the patient's mouth, and then I brought it in the designing software to form a coping that will fit perfectly on top of the screw-retained abutment. And then we designed the customized scanning device that have 4 extensions, 4 cylindrical extension. On top of each extension, there is a hemisphere, and on top of it, there is a notch. The main idea of this notch is to help us to perform the alignment of the scan later on, and this is what I'm going to show you in the upcoming slides. Then after we designed the customized scanning device, we printed it, and we attached abutment screw to it. We tried it on the screw-retained abutment outside the patient's mouth and make sure it's perfectly seated. At the day of the scanning, first day of scanning, we remove the prosthesis from the patient's mouth. We scan the intalio and camu surface of the maxillary and mandibular prosthesis. So now we have the STL file of the prosthesis. We place the prosthesis back in the patient's mouth, we dismiss the patient. And then we transfer this STL file to the model editing software. And we trimmed the most anterior implant, and then we splinted the remaining 2 parts with the connecting bar. We did the same thing with the maxillary and mandibular section prosthesis. After we designed that, we printed the sectioned prosthesis and have it ready for the scanning. At the day of the scanning, we have the section prosthesis, maxillary and mandibular, along with the customized scanning device. We brought the patient again for the second visit. And then we scanned the prosthesis in the patient's mouth, maxillary and mandibular, and also we captured the bite. Then we removed the prosthesis, leaving the multi-unit abutment. We started by scanning the multi-unit abutment itself, and then we attached the customized scanning device, and then we scanned the multi-unit abutment with the customized scanning device. Then we placed the sectional prosthesis, and we scanned it again with the customized scanning device. We removed it, and we placed the scan bodies on the most posterior implants, and scanned it again. And finally, we removed the customized scanning device and performed full arch scanning. And we did the same in the maxilla, following the same sequence, starting with the multi-unit abutment and ending up with the full arch scanning of the scan bodies. We dismissed the patient, and then we had a total of 6 scan files. Scan for the prosthesis, scan for the section prosthesis, multi-unit abutment, and the scan bodies. Now we transfer all the data to the designing software. The first step, we aligned the section prosthesis with the interim prosthesis that the patient has. Now let's talk about the alignment, how we perform the alignment of the remaining 5 scan devices. So as we talked before about the notch on top of the scanning device, so that helped us to determine and make sure that we placed the point in an accurate position. So we placed 4 points, and then we performed the alignment between the scan files. So the sequence of alignment, we had the full prosthesis that we aligned the section prosthesis to it, and then we started with the sectional prosthesis. We aligned the multi-unit abutment with the customized scanning device with it. And then we aligned the multi-unit abutment scan with the previous one. And then the 4 scan bodies with the customized scanning device to the previous file. And finally, we aligned the full arch scan of the scan body to it. We did the same thing in the mandible. We started by aligning the sectioned prosthesis with the interim prosthesis, and then we performed the model alignment in the same sequence as we did in the maxilla. We transferred then we end up having a virtually mounted models at the appropriate occlusal vertical dimension that we want. We did a digital walks-up at the first visit, at the first stage, and make sure that we have centric contact as well as eccentric movement. The main goal in this situation is to have a mutually protected articulation, or what's called canine guidance for this patient. So once we make sure that the prosthesis or the design as what we want, we went ahead and merged the component and make a space for the titanium base abutment and the screw access hole. We export the designing prosthesis or the designed prosthesis, and we milled it into a BMA. We milled the maxillary and mandibular interim prosthesis to try it in the patient's mouth, evaluate the occlusion, aesthetics, and phonetics. Once we milled it, we attached a titanium base abutment and cemented by using resin cement. And at the day of the placing the prototype, the most important thing is to evaluate the passive fit of the prosthesis. Now there is multiple technique or multiple tests to evaluate the passive fit of the prosthesis. The first one is by applying alternate finger pressure, just to see if there is any rocking in the prosthesis. And then second one is direct vision and tactile sensation. And this is mainly for the abutment level prosthesis, where we can see the junction between the abutment and the screw-retained abutment. And also, taking periapical radiographs, it's important to see if there is any gap between the prosthesis and the implant. And also one screw test. And this test is considered one of the most accurate tests to evaluate the passive fit of the framework. And basically, this test, we tighten one screw at one terminal without tightening any other screws, and then evaluate all the remaining abutments to see if there is any gap between the prosthesis and the implant. If there is any gap, that means there is a misfit. And lastly is the screw resistance test. And also this is considered an accurate test. Basically in this test, we tighten the abutment that closest to the midline, and then we go distally and tighten the remaining abutment until we encounter a resistance between the screw head and the abutment. Once we have a resistance, the most allowed turn for the screwdriver is half turn. So once we have a resistance, the most allowed is to turn the screwdriver half turn. If we needed more than half turn to seat the prosthesis, that means there is a misfit in this abutment. So we placed the prototype in the patient's mouth, and we evaluated the centric occlusion, and we had enough contact or even contact in the right and left side. And also we evaluated the excursive movement. And as you can see, we were able to achieve a mutually protected articulation, anterior guidance in the patient. Also, we evaluated the phonetics, aesthetics, occlusal vertical dimension, and the patient was pleasant with the final result of this prosthesis. I dismissed the patient, and then I called the patient for a follow-up to see if she's happy with it. And once she and I were happy with the final result, we went ahead and milled the final prosthesis into a monolithic zirconia prosthesis. And also, we attached the titanium base to it and cemented by using resin cement. This is a maxillary and mandibular occlusive view of the final prosthesis. And this is MIP position of the prosthesis. Here you can see also we're able to achieve a canine guidance in the final prosthesis. And at the day of the placement, we decided to go ahead and virtually design and print occlusal device or night guard. So we perform intraoral scanning for the final prosthesis, and we capture the bite at open occlusal vertical dimension to make sure that the final or the occlusal device is fit perfectly, and we don't need to do any adjustment at the patient's mouth. So also we evaluated the aesthetics, phonetics, and occlusal vertical dimension. It was the same as the prototype. And when you can see here the huge transition from the initial presentation of the patient and the final outcome. For me, it was a successful outcome, and we didn't need to do any adjustment in the patient's mouth. So for me, that was a proof concept for utilizing this novel approach. So we went ahead and designed the interim prosthesis, and we printed it in-house at the same day. And we made sure also to have a mutually protected articulation even with the occlusal device to protect the implants. We placed the device in the patient's mouth, and we gave the patient also oral hygiene instruction. So to wrap up the sequence of this digital workflow, so we needed a total of 3 visits. The first visit, we scanned the prosthesis, then design the section prosthesis. And then in the second visit, we perform the 5 scans, and then import it into the designing software to make the alignment. And in the third visit, place the prototype. So now, let's compare the digital with the analog workflow. So it's obvious to us that the analog workflow will need multiple appointments, and it could be even more than 6 appointments. It will need a lot of laboratory procedures, clinical procedures, and material waste as well. But for the digital workflow, we need only 2 visits with the patient, and the third one will be placing the prototype. So to evaluate the digital workflow, I think we can say that the digital workflow will provide us with successful outcome, and it's a predictable and efficient treatment approach for full arch implant prosthesis. So the take-home message is, doesn't want to come. Okay. Digital impression for full arch prosthesis are now possible and predictable. And digital technology for implant prosthesis enhances patient experience. New workflows offer clinicians option for various simplified solution. Future research and development will enhance the digital experience. With that being said, I would like to thank you all for your attention, and I would like to thank the organizers also for the invitation. And thank you so much.
We have the time maybe for a question or two.
Thank you for the amazing lecture.
Thank you.
I'm actually interested in full arch and digital workflow since many years. I would like to ask, this technique is mandatory needs a prefabricated prosthesis, like the prosthesis you started the procedure with.
Yes.
And basically you will do this with the analog as well, like with the analog technique?
What do you mean?
I mean the prosthesis that you start with, it's already there. Did you construct it digitally or analog?
No, analog.
Analog.
Yes.
So we still need the analog for your technique.
We still need the analog, but still we can solve this problem by combining the photogrammetry with it. So the solution for this one is to use the photogrammetry. Yeah. But would you buy the device and the machine just to make it? This is a simplified solution. For this one, we need to do a conversion for the prosthesis. So let's say the patient has complete denture. Yeah. We don't need to make any impression or anything. We can make the conversion in the patient's mouth, and then we perform the scanning. So analog, it means that we need to make impression for the patient, have a cast, scan the cast in the lab.
Okay, I'm sorry, I'm going through the questions because
Yes,
it's
go
very
ahead.
interesting for
Thank
me. You did 5 times full arch scanning.
Yes.
What scanner can do this? I'm struggling actually, especially in the lower, when I'm dealing with full arch. The scan is not easy at all. So you did 5 times
Yes.
scanning and it looks perfect.
I use Trios.
Trios.
Yes.
What Trios? Like
The third one.
The third one. Okay, that's amazing. And what is the software for the alignment? Is it the ExoCAD?
ExoCAD, yes.
Last question. I'm sorry. The alignment jig, you did it over the multi-unit abutment. It's actually a non-hex abutment.
Yes.
So how can you keep it still in the same position without rotation?
So the trick is to have a good assistant, really. And once you place it and tighten it, it won't move. Even though it's not hexed, but once you tighten it well, it won't move. It won't rotate, I mean.
Yeah, you need to carry
So
it.
I like to use the Pranama retractor. Ask my assistant to hold it. The total time for the scans, it takes like, for me, 25 to 30 minutes.
Yes.
So I think this is convenient for me and for the patient.
Because a little bit of a movement.
I agree with you.
ruin
Yeah,
everything. You
yeah.
have to
And this is what I wanted to also emphasize on. The most important is to keep the customized scanning device at its position and to have a good assistant.
Thank you.
Thank you.
Any more questions? Next time, sit in the front.
Okay, تعبناك yeah. Doctor, thank you for the great lecture and the nice innovation here.
Thank you.
It's certainly a nice economic alternative for photogrammetry. Question regarding your alignment or aligning jig. What's specific about it? I mean, it seems that you have 4 hemispheres.
Yes.
For for matching different scans. Is there anything specific about this design? Is it proprietary? Can you have 3 domes instead?
Yes, so actually I tried with 3 domes before I went with the 4th one. I tried with the 3-1, but the alignment wasn't perfect. So I added the 4th extension and the lingual. And the perfect for me was perfect from the first time. So this is why we decided to just keep it 4. You can go with 5, you can go with 6, but it will be more difficult for you, and it will interfere with the section prosthesis, and also it will interfere with the tongue as well. So by keeping it 1, I think it was helpful.
Do you have a paper published on that?
Yeah, so we submitted actually a patent for it, and also we submitted the paper for the publication for this technique.
Okay, wonderful. Thank you very much.
You're welcome.
Thank you, Doctor.
Thank you.
Please accept this humble.
Thank you so much. Thank you so much. Thank you all.
دكتور أحمد.
مساكم الله بالخير جميعا. بداية مشكورين على حضوركم. أحب أشكر المحاضرين على المحاضرات الجميلة. يمكن أول مؤتمر من مؤتمرات جمعية أطباء الأسنان يكون فيها بري كونفرنس الامبلانت سيمبوزيوم هذا. صراحة أنا أحب أشكر رابطة جراحين اللثة على رأسهم الدكتور الشراد والمقرر الدكتورة منيرة، ما قصروا، يعطيكم ألف عافية. بس إذا ممكن كشكر وتقدير لهم على المجهود، تفضل دكتور أحمد على ستيج إذا نقدر نكرمك. الله يعطيكم العافية.
الله يعافيك، مشكور.
ما قصرتوا.
مشكورين على
ما
السبورت.
قصرت يا مشكور يا ابو عمر. دكتوره منيره راشد تفضلي. شكر موصول لجميع اعضاء الرابطه، ما قصرتوا ومشكورين على حضوركم.